Sir, is my screen visible, sir?
Yeah,
visible.
Okay, sir. Okay, sir. Thank you so much, sir.
So உங்க டாக் வந்து சார் சொல்லிருக்காரு இல்லீங்களா, டோட்டலா 30 minutes plus 15 minutes for question discussion.
Yes, sir.
ஓகேங்களா?
Okay, sir. Okay, sir. Thank you so much, sir.
Thank you.
Shall I unmute now, sir? I'll rejoin
நீங்க
later.
பண்ணிக்கலாம். நீங்க unshare பண்ணிக்கலாம். And then
Okay, sir.
Thank you.
Okay, sir.
Thank you.
Thank you so much, sir.
Sir. Hello, sir.
Good morning, Dr. Rajendran.
Hello, sir. Through here, sir. Good evening, sir.
Good evening.
Sir, good evening, sir. Good evening.
Hello, Rajendran.
Sir, good evening, sir.
Good evening, Rajendran.
Sir, good evening, sir.
இன்னைக்கு மாஸ்க் இல்லாம இருக்கீங்க. Good. Sunday.
ஆமா சார், Sunday.
Can you hear me?
Sunday at my farm. I am at my farmhouse, sir. That's why I'm.
Yeah. You have to be careful. So everybody is having. So in Chennai, so many of our doctors, parents are having positivity. And yesterday, and today I had message.
Hello, Karthik.
Hello, Karthik.
Unmute பண்ணுங்க.
கார்த்திக் கோயம்புத்தூர் இதுல பாத்திருக்கேன்.
Hello, sir. Hello.
பாக்குறேன் நான்.
Oh, can you hear me, sir? Can you hear me?
Yeah, I can hear you very well.
Karthik, உங்க ஸ்கிரீனை ஷேர் பண்ணிக்கிறீங்களா? கொஞ்சம் ஒரு தடவை செக் பண்ணிக்கிறீங்களா?
எதுங்க சார்?
உங்க ஸ்கிரீனை ஷேர் பண்ணிடுறீங்களா? ஒரு
one second, share screen. Okay, இது என்ன பண்ணனும்? ஷேர் ஸ்கிரீன் பண்ணிட்டு
பவர் பாயிண்ட் ஜஸ்ட் ஓகே ஆவறதான் பாத்துங்க.
டெஸ்க்டாப் 1 போட்டுட்டு இது 1 செகண்ட். வருதா சார்? தெரியுதா?
வரல.
நீங்க தெரியுறீங்க, ஸ்லைடு தெரியல.
நான் தெரியறேன், ஸ்லைடு தெரியல உங்களுக்கு. இருங்க வரேன். இதுல இது போட்டா
அந்த ஷேர்னு கீழே ஷேர்னு போட்டுருக்கு பாருங்க, அதுல பண்ணுங்க. பண்ணிட்டு then you click on your PowerPoint. கீழே ஒரு greenல you put that share and then click that this thing. You have downloaded the desktop, so that particular PowerPoint you click.
First you open your PowerPoint.
Yeah, I've opened my PowerPoint.
And now you go to Zoom app போய்டுங்க.
Yeah.
அங்க கீழ ஷேர் ஸ்கிரீன் இருக்குது இல்லையா?
அது எனக்கு வந்து டிசேபிள்டா வருது.
போயிட்டு தான் இங்க வந்திருக்காரு. படம் தெரியுறாரு.
இல்ல, you are a co-host, so you should be able to share.
அந்த கீழ இருக்கு பாருங்க, கிரீனா.
இருங்க வரேன். rectangle
ஸ்கொயர்ல ஷேர் ஸ்கிரீன் போட்டுருக்கோம்.
இருங்க சார் 1 second. It
Yeah,
is
take
just
your
ask.
time. There is
Yeah,
time.
yeah.
Another.
And system preferences. Okay.
Thiru, others have come. Kritika.
Dr. Kritika has joined.
Acha. Hello, Kritika. Good
You
evening.
Dr. Vijay Bhaskar வந்துட்டு ஜாயின் பண்ணிட்டு he has gone out. He will come back, sir. ராஜ்குமார் தான் இன்னும் வரல. அண்ட் பழனிராமன் வந்து அவர் வந்து ஒரு இன்னொரு ஏதோ டாக் முடிச்சுட்டு தான் வராரு சார். சோ அதனால he will join bit late.
அவர் பல இடத்துல பேசுறாரு. ஏதோ கட்சிக்கு போற மாதிரி. அந்த காலத்துல கட்சி மீட்டிங்க்கு அண்ணாதர் எல்லாம் லேட்டா வருவாங்க. இங்க முடிச்சிட்டு அங்க போற மாதிரி. ஹலோ செந்தில் பிரசிடென்ட் சார். வணக்கம் வணக்கம்
சார். வணக்கம் வணக்கம் சார். நல்லா இருக்கீங்களா?
நல்லா இருக்கும். பிரசிடென்ட்டுக்கு என்ன சார் தமிழ்ல சொல்லுங்க? ஜனாதிபதி. ஜனாதிபதியா? தலைவர் தான் சார். தலைவர். ஓகே. ஏன்னா நான் வந்து இங்கிலீஷ் சொன்னேன்.
என்றும் தலைவர்.
என்றும் தலைவர்.
அது வாய்ப்பு இல்ல.
வாய்ப்பு இல்லையா? அது rules don't permit, you know. Rules don't allow, no, to continue. Only Chinese premier can be president forever.
South Korean sir? Yeah, North Korean.
North Korea. Kim.
And also Russia.
ஆமா. இல்ல ரஷ்யால கூட எலெக்ஷன் இருக்கு. Putin this thing.
But he has been quite long, நினைக்கிறேன் சார்.
ஆமா, long, but he has been elected by foul means or this thing we don't know.
எல்லாருக்கும் வணக்கம்.
வணக்கம் சார்.
சார் இந்த சாட்டர்டே சண்டேவா மாத்துறது எப்படி சார் இருக்கு?
சாட்டர்டே சண்டே
இல்ல சாட்டர்டே எல்லாரும் எதிர்பார்த்துட்டு இருப்பாங்களான்னு யோசிச்சேன்.
நீங்க முதல்லயே கொண்டு வந்துட்டீங்க. ஆன்டிபயோட்டிக் நெக்ஸ்ட் வீக்ல வருது. ஆன்டிபயோட்டிக் வாரம் நாட். So you are well advanced. எப்பொழுதுமே காலை ஒரு அடி முன்னால் வைத்திருப்பீங்க.
இல்ல சார் அது இந்த சிஎம்ஏ அரேஞ்ச் பண்றேன்னாங்க. சரி நான் தான் இதை கன்வெர்ட் பண்ணிடுங்க. ஆன்டி மைக்ரோபியல் வீக்.
யா அதுதான் செந்திலுடைய முத்திரை.
எல்லாம் கைடன்ஸ் தான் சார். எல்லாம் ப்ரெடிசர்ஸ் உங்களை மாதிரி சில பேர் வந்து கைட் பண்றது தானே சார்.
என்ன சார் நான் வந்து they tell me more as a critic than as a guider.
இல்ல சார் சில பேர் கைடன்ஸ், சில பேர் வந்து ரோல் மாடல்ஸ், சில பேர் வந்து இன்ஸ்பிரேஷன்.
ஒரு லட்சுமி நாராயண் பிரசிடென்ட் அந்த இதுல கும்பகோணத்துல ஒரு இது நடந்தது.
ஆமா சார்.
அதுல வந்து அந்த எண்ணெயை விட்டு ஒரு வீடியோ எடுத்திருந்தாங்க. லைபாய்ட் நிமோனியா. அப்ப நான் முடிஞ்சிட்டு not ethical to drop, instill oil and then take a video picture. We could have shown it as cartoon. என்ன அது we will not allow our own child to be this thing, subjected to such a this thing. தெரிஞ்ச என்னோட டேஞ்சர் தெரிஞ்சு அதுக்கு அவர் சொன்னார் உடனே லட்சுமணன் சீனிவாசன் எப்பவுமே ஏதாவது கிரிட்டிசிசம் சொல்லுவாருன்னு. அது இன்னும் மறக்கலன்னா.
இல்ல சார் அந்த மாதிரி யாராவது ஒருத்தர் வந்து கரெக்ட்
எத்திக்கல் பிரின்சிபல்ஸ்லாம் இப்போ ரொம்ப இம்பார்ட்டன்ட். இப்போ பாருங்க இந்த ஜூம்லாம் வந்து கொஞ்சம் அந்த இது எக்ஸ்டர்னல் ஜெனிட்டலே காமிச்சாலே கட் பண்ணிடுறான், உடனே ஸ்டாப் பண்ணிடுறான். பிகாஸ் we have to get prior permission or cover that area or cover the eyes.
Yes.
Hello, Dr. Tirumurugan, can you hear me?
Yes sir.
இது சார் இந்த ஸ்கிரீன் ஷேரிங் போட்டா ஹோஸ்ட் டிசேபிள் த ஸ்கிரீன் ஷேரிங் மெசேஜ் வருது எனக்கு.
திருமுருகா நீ தான் வழி விடணும். அந்த நந்திக்கு வழி விட சொல்லி
இப்போ வரும் வெளில போயிட்டு வந்தாரான்னு தெரியல. இப்ப பாருங்க, இப்ப ட்ரை பண்ணுங்க வரும்.
நந்தனார் வந்து அந்த நந்தியை விலகுன்னு சொல்றாங்க சிவனை பாக்குறது. அந்த மாதிரி
வந்துச்சு. ஓகே குட். ஓகே சார் குட்.
நாங்கலாம் செக்யூரிட்டி மாதிரி வேற ஒண்ணும் இல்ல.
ஆமா நந்தியும் செக்யூரிட்டி தான் நடராஜருக்கு.
ஸோ இதெல்லாம் அப்படியே ஒழுங்கா அப்படியே டைரக்ஷன் கொடுக்குற மாதிரி தான் சார், வேற எதுவும் இல்ல.
See, Tirumurugan, he has been at the receiving end for so many years as undergraduate, postgraduate. So he cannot escape me now. அதுக்கு தான் முன்னாடியே வந்து உள்ள விட சொன்னேன், உங்களை பெர்மிஷன் கேட்டேன் கொஞ்சம் ரேக் பண்ணலான்னு.
அப்படி இல்ல சார், நீங்க பண்ணதுனால தான் சார் இன்னைக்கு கொஞ்சமாவது உருப்பிட்டு இருக்கோம்.
அப்படி சொல்லு.
இல்லன்னா எந்த தெருல சுத்திட்டு இருப்போம் எனக்கே தெரியாது.
Yeah, thank you for giving me also this honor along with other teachers of yours. Yeah.
டெஃபினட்டா சார், அதுல ஒன்றும் சந்தேகமே கிடையாது. தேங்க்ஸ் டு உங்களெல்லாம் இருந்ததுனால தான் கொஞ்சமா உருப்பிட்டு இருக்கேன்.
வெற்றிசெமல்ல நெத்தியடி கொடுத்து உங்களெல்லாம் செம்மப்படுத்தி வச்சிருக்காங்க.
நிச்சயமாக சார், அதுக்காகவே உங்களுக்கு எல்லாம் ஸ்பெஷலா கடமை போட்டிருக்கோம் சார்.
கிறிஸ்டோபர் எப்படி இருக்கான்?
கிறிஸ்டோபர் எங்க இருக்கானே
He
தெரியாது.
hasn't joined. இல்ல, he is there in Michigan, but he hasn't joined yet. நாங்க 2 தடவை ட்ரை பண்ண ஸ்டேட்ஸ்ல பதில் பேசுறேன்னா அப்புறம் பேசவே இல்லை.
சார் உங்களுக்காக பதில் பேசுறேன்னு சொன்னேன், நான்லாம் அனுப்பிச்சா மெசேஜ் அனுப்பிச்சா அனுப்ப கூட மாட்டான்.
நீ கிளாஸ்மேட்டுப்பா, சண்டை போட்டிருப்ப, ஏதாவது டூக்கா போட்டுருப்ப. சாரி செந்தில், நாங்க போர் அடிக்கிறோம் உங்களை.
அதெல்லாம் ஒண்ணும் இல்ல சார்.
சார் அவங்ககிட்ட நிறைய சண்டை போட்டிருக்கேன். இல்ல நிறைய சண்டை போட்டிருக்கேன், அதெல்லாம் நான் சொல்லவே இல்லைன்னு சொல்லவே மாட்டேன்.
கிறிஸ்டோபர் இஸ் a pediatric cardiologist சார். ஜிப்மர்ல MBBS MD படிச்சுட்டு ஈவன். கார்த்திக், you are seen, your slides are very well seen.
Okay, sir.
And very well made slides.
Can you stop?
Thank you, sir. Yeah, I'll stop it, sir. I'll just
I just stopped sharing.
Yeah, sure.
இன்னும் ராஜ்குமார் தான் கேட்கணும், அவர் ஒருத்தர் தான். Just I need to find out what's happening with him.
ராஜேந்திரனை பார்த்தோன்னு எனக்கு ஒரு பழைய ஒரு PhD பண்ணணும்னு ஒரு ஆசை இருந்தது. என்ன தெரியுமா சார் அது?
யாரு சார்?
ராஜேந்திரன், கொள்ளிடம் முருகேசன், அவங்கெல்லாம் அந்த ரமேஷ், சிதம்பரம் ரமேஷ்லாம் பார்த்தோன்னு சொல்லுவேன். I want to do a genetic study to find out what is the gene for the youthfulness. இவரை ராஜேந்திரனை பார்த்தோன்னா அதுதான் தோணுது எனக்கு. அது பண்ண முடியாமல் போயிடுச்சு. அந்த காலத்தில் அவ்வளவு ஜீனோமிக் இதெல்லாம் வரல, அட்வான்சஸ்.
Okay,
இப்போதான் வந்திருக்கு.
Okay, I think we can start நினைக்கிறேன். சுரேஷ் வாங்க. வணக்கம்
சார்.
ஹலோ சார், சுரேஷ் பாலன் வணக்கம்.
வணக்கம் சார். ஸ்ரீனிவாஸ் சார் வணக்கம்.
Okay, சுரேஷ் நீங்க ப்ரொசீடிங்.
கார்த்திக் பாலசுரன் வணக்கம்.
வணக்கம் சார். வணக்கம். ஹாய் சார். ஹாய்
சுரேஷ்
வணக்கம்.
வணக்கம்.
ப்ரொசீடிங் ஸ்டார்ட் பண்ணுங்க. பீடியாட்ரிஷியன்ஸ் பிரேயர், அப்புறமா அப்படியே ஒரு சார் வந்து ஸ்ரீனிவாசன் சார் மட்டும் ஒரு ஃபெலிசிட்டேஷன் மட்டும் சொல்லுங்க.
வைங்க சார்.
ஒரு 5 minutesல முடிச்சிடலாம் இனாகரல். திருமுருகன், can we start?
Yes sir, just ஒரே ஒரு நிமிஷம் சார், இன்னும் 1 minute. I just start recording. Okay sir, we can start sir.
அகர முதல எழுத்தெல்லாம் ஆதி பகவன் முதற்றே உலகு. இனிய மாலை வணக்கம். சுரேஷ்
So welcome. So very good evening to all. Respected President Dr. Sendil sir, Treasurer Dr. Rajendran, Joint Secretary Dr. Tirumurugan, Professor Srinivasan sir, retired HOD from JIPMER, our guide and philosopher for all our IAP TNSC activities, and the various speakers who have joined today for the Tele-Cme on rational antibiotic therapy in pediatrics. Good evening to all once again. So it is a very good initiative and program on the part of IAP TNSC to observe the various weekdays as proposed by this IAP, Central IAP. So even though we had hectic programs during the last few weeks, our president has made it a point that we should conduct a program, and he made it a very novel one in that it is a Tele-Cme, which is going on to have for 4 hours. So we have got excellent speakers, Dr. Karthik Balasubramaniam, Dr. Rajakumar PS, Dr. Kritika, Dr. Palani Raman, and Dr. Vijay Bhaskar will be talking on the various topics. And at the outset, I welcome Professor Srinivasan sir, who has joined with us. He is a young.
Suresh, one nimsham. We'll go to the pediatrician's prayer and then we'll finish. Rajendran, solla.
Yeah. Good evening to everybody. குழந்தை மருத்துவனின் இறைஞ்சுதல் எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும். நோயரின் துன்பம் தீர்க்கும் திறன் நமக்கு வழங்கப்பட்டது எப்படிப்பட்ட சிறப்புரிமை என்பதை பணிவுடன் நாம் உணர்வோமாக. எல்லா குழந்தைகளுக்கும் அவரது குடும்பத்தினருக்கும் அவர்களின் சமுதாய படிநிலை மற்றும் சாதி மத பிரிவுகளை பாராமல் நலம், கற்றல், ஈகை, அன்பு, அமைதி ஆகியவற்றின் தூதுவர் நல்லவற்றை உள்வாங்கவும் மாற்ற முடியாதவற்றை காரணத்துடன் ஏற்றுக்கொள்ளவும் போதுமான மெய்யறிவும் புரிதலும் எங்களுக்கு வழங்குக. உங்களது வாழ்த்துக்களையும் அருளையும் கருணையும் எல்லா சூழல்களிலும் நேரங்களிலும் அனைத்து மக்களிடையே கொடுத்து அருளுங்கள். தேங்க்யூ.
So thank you, Dr. Rajendran sir. So once again, I take this opportunity to welcome our Professor Srinivasan sir, who has joined today. As I earlier told, he is one of our guide and well-wisher, who always takes part in the various IAP programs. Yeah. And even today in this Dakshin Badigan, he last September, he was very active in the Dakshin Badigan. And now again in our program for this Rational Antibiotic Week, he has again joined us. He is also very active in the IYCF platform, where they have been conducted various programs for breastfeeding awareness among the Anganwadi workers. I don't know how he has got so much time. So he's a young person, even though he's retired, but still young at heart, knowledge and dissemination of knowledge and encouraging the youngsters. And I wholeheartedly welcome Professor Srinivasan sir on behalf of each and every one of us. And I also take this opportunity to welcome the various speakers, Dr. Karthik Balasubramaniam, Rajakumar, Dr. Kritika, Palani Raman, and Dr. Vijay Bhaskar, who have joined to share their experience, to give away their knowledge on the various topics on this rational antibiotic Tele-Cme. These viewers, I welcome all the participants who have joined online, the pediatricians, general practitioners, postgraduates, and dear friends. Thank you, sir. Thank you very much. Sindhil sir. Unmute பண்ணுங்க, unmute sir.
So during this antimicrobial week celebrations, we have taken the topic of rational antibiotic therapy in pediatrics today. So as I ponder over the past 3 decades as a postgraduate, the infections were dominated by the bacteria. So I remember we used to send blood samples for viral studies to probably to King Institute that days. So that was the only thing we did. We knew about the viruses, probably a case of encephalitis or similar to that. We were doing for poliovirus and other things we were doing in ICH. So gradually it shifted. The era shifted and the bacteria, we were using all types of antibiotics. It was actually an overusage and of course an abuse of antibiotics. And over the decades, 2 decades, we have seen the shift. The bacteria have been taken over by the viruses. So despite the viruses coming to the forefront and dominating the infectious disease scenario, and we have been of the practice of prescribing antibiotics, even though it is a viral infection. And time and again, doyens of pediatrics like Professor Srinivasan, Professor Amdekar, they have told us that the unnecessary use of antibiotics should not be done. And Professor Amdekar's disciple, Dr. Palani Raman, he took it like a war crusade along so many other pediatricians, and he was very dogmatic in his saying that 90% of the infections are viral nowadays. Only 10% need antibiotics. So this is the way the scenario or the evolution of the infectious diseases pattern started. So with these antibiotic usage, we have come to a point we are having dearth of antibiotics nowadays, and the resistance, the decreased sensitivity, multi-drug resistance, all these are coming into fore. So with this view, and now the nature also has taught us a lesson that the virus is going to dominate us in this COVID pandemic. So we must understand this scenario, and as senior pediatricians, we have gone through this phase, and so we understand all these realities. The youngsters should know this, and they have to do a rational antibiotic therapy. So this is what is our dissemination of knowledge hereafter. With these words, I think we have been nurturing young talent. We have got 5 wonderful youngsters, and they are going to talk about this rational antibiotic therapy in the coming 3 hours. And so with this, I welcome everyone, and of course the speakers, delegates, my dear office bearers, Professor Srinivasan, Professor Dr. Rajendran, who's there. And I request Professor Srinivasan to say a few words about his experience, and then we'll go to the CME. So unmute பண்ணுங்க சார், unmute பண்ணுங்க, கேட்கல சார்.
நன்றி தலைவர் செந்தில் அவர்களே. நீங்கள் இந்த உயிர்கொல்லி மருந்துகள் ஆன்டிபயோட்டிக்ஸ் பற்றி நீங்கள் இந்த வாரத்துக்கு முன்னாலே நீங்கள் முதல்ல இதை பேசுறதுக்கு சிறந்த தலைப்பாக எடுத்துக்கிட்டு 5 இளைஞர்களை நீங்கள் கூப்பிட்டதற்கு மிகவும் நன்றி. பெரியவங்க என்ன மாதிரி வயசானவங்க பேசினா இந்த பெருசுங்க இப்படி தான் பேசிகிட்டு இருக்கோம், அவங்களுக்கு வேறு வேலை இல்லைன்னு சொல்லுவாங்க. ஆனால் இப்போது இந்த மாதிரி இளைஞர்கள் இந்த மாதிரி முக்கியமான தலைப்பை எடுத்து அதை சிறந்த முறையில் சொல்லும் பொழுது கேட்பதற்கு நிச்சயமாக காதுகள் கொடுத்து கேட்பதற்கு நிறைய பேர் இருப்பாங்க. அவங்க அதை தொடர்ந்து நடத்தணும்னு இருப்பாங்க. அண்ட் சுரேஷ் பாலன் அவர்கள் ப்ரிவென்டிவ் மெடிசன்லையும் இருக்கிறதுனால இது கரெக்டாக அவர் தலைமை தாங்கி இந்த ஆன்டிபயோட்டிக் யூஸை எப்படி அப்யூஸை ப்ரிவென்ட் பண்ணுறதுங்கிறது ரொம்ப முக்கியமான ஒரு இது. So it's very important that this topic has been chosen and you have selected the appropriate persons to talk about it. So I'm sure they are going to do justice. So I think I will not waste your time. So I'm waiting to hear from them and take home some points. Thank you so much.
Thank you, sir.
Dr. Rajendran or Dr. Thirumurugan, please, you can take over the proceedings of the Tele-Cme.
Yes, sir. Sir, Rajendran, sir.
Unmute பண்ணுங்க Rajendran.
Yeah, Thirumurugan, you proceed.
ஒன்றும் இல்லைங்க சார், அந்த CME credit points பற்றி நீங்கள் சொல்லிடுறீங்களா சார்? I'll just share the slide. Just ஒரே ஒரு செகண்ட் சார்.
நீங்கள் சொல்லிடுங்க, ஒன்றும் ப்ராப்ளம்.
Okay, sir. So we are proud to say that this CME credit, the CME has been awarded 2 TNMC credit points by the Tamil Nadu Medical Council. So there are certain steps to be followed for following this, for getting the credit points. First, we need to make sure that you are attending the CME. So we request you to enter your name and your TNMC number along with your mobile number in the chat box if you are on Zoom, and in the comments section if you are on YouTube live. That way we'll know that you have attended the program. And then you need to pay rupees 250 towards the IAPTNSC, the details of which is available in the website. And after that, again, you go back to the IAPTNSC website and then complete the registration form within the next 72 hours. Once you have done all these 3 steps, then we will be able to you will be able to apply for on your behalf regarding the credit points. So again, to repeat, stage 1, you need to enter your name, your Tamil Nadu Medical Council number, and your mobile number, either in the chat box of Zoom or on the YouTube live comment box. Number 2 is to pay rupees 250 towards IAP TNSC. And number 3 is to complete the registration form, which is available in the website. Okay. So I think with that, I'll request Dr. Karthik to start the proceedings.
Thank you, Dr. Tirumurugan. Can you hear me now?
Yeah. You
Okay,
need to share your slides, Doctor.
Yeah, I'm just sharing the screen now. Are the slides visible?
Yeah, your slides are visible. Yeah, fine. Perfect.
Okay. Shall I start?
Yeah.
Okay. Thank you, sir. A very good evening to one and all. For those of you who are who do not know me, I am Dr. Karthik, and I'm a practicing neonatologist at Coimbatore. I work at Women's Center by Motherhood. Manage a level 3 NICU in our center. And at the outset, I would like to thank the organizing team of the IAP Tamil Nadu State Chapter for this invitation. And I'm happy to be here. And I'm going to talk on the rational use of antibiotics, particularly in neonates. And as Sir earlier said, there's no doubt that one of the most commonly misused or abused drug throughout the world is the antibiotics. And probably that's the reason that we are encountering so much of multi-drug resistant organisms. And then nature is again teaching us that, you know, a virus still are more powerful in controlling the world. Okay. Okay. So what is the I'll just give a brief overview of what I'm going to talk over the next half an hour. A brief introduction on neonatal sepsis. What are the effects of antibiotics in a neonate? And what are the commonly faced challenges while prescribing antibiotics in a neonatal intensive care unit? What are the adverse effects of prolonged antibiotic therapy in neonates, and why we need to be very cautious in using antibiotics? And a brief definition of the various neonatal sepsis before discussing about when to use, what kind of antibiotic to use, and how to use, and the importance of the antibiotic stewardship program in any institute. So what is rational use of any drug? So as per the WHO definition, it says, yeah, can
you switch on your video, please?
Oh, you want me to switch on the video? Yeah. Okay, can you?
Yes, you can proceed.
Okay, sorry. So what is, okay, as per the WHO definition, the rational use of any drug refers to correct, proper and appropriate use of a drug. It's basically defined by the 8 R's, which means that the drug should be used for the right indication, and the right drug should be used for the prescribed for the defined diagnosis. The dose of the drug should be appropriate for that particular individual and for that particular condition. The drug should be administered at the right time through the appropriate route, and a trained personnel, trained staff should be there to provide the medication. And the particular drug should be used for the right duration, not too long or not too short. And the drug should be provided at a reasonable cost. Only if you satisfy all these 8 R's, then one can say that, you know, we are actually using a particular drug rationally. Otherwise, it's still we are using it irrationally. So coming to neonatal sepsis, we all know that the sepsis, the infection in neonates is the most important cause of neonatal morbidity and neonatal mortality. In fact, it contributes to a very significant portion of the infant mortality rate. And preterm babies, and particularly small for gestational age babies, are at very high risk of infection. The smaller the baby, the more preterm the baby is, the more is the chance of infection. Let's say again, because of varied reasons, because these babies lack IgM, because the production of IgM starts sometime after 38 to 40 weeks of gestation. the transfer of IgG antibodies actually takes place after 30 weeks of gestation. So these babies often lack sufficient amount of IgG. The immune response is very poor, both antibody-mediated immune response as well as the cell-mediated immune response is very poor in neonates. And these babies, when they're born prematurely, these babies are admitted in the NICU and they undergo various invasive procedures, which invasive procedures which again predisposes these babies for various infection.
Okay, sir. Thank
you. Whereas a fetus inside the womb is in a sterile environment. So once the baby is born, the baby is exposed to various organisms from the maternal vaginal tract, the organism from the rectum, the organism from the perineum, infect the babies or colonize the babies, and some of these cause problems in babies. And again, a preterm baby once admitted in the NICU, the nursing environment again exposes these babies to various organisms. The manifestation of infection in neonates are very non-specific, and it's sometimes very difficult to make a diagnosis of infection, and these babies deteriorate very rapidly. So there's no doubt again that antibiotics, antibacterial drugs, antiviral drugs are in fact lifesaver for these small babies. So it's a double-edged sword. It's both a lifesaver. At the same time, if not used appropriately, it can cause various complications in neonates. Coming to the effects of antibiotics in neonates. Now, the gut of a fetus is sterile. There is hardly any organism in the intestines. The flora of the neonatal intestine is established in the first few days of life. I'll come to that, what kind of flora is there in the immediate postnatal period, how it's established. The use of antibiotics actually delays the microbial colonization. Of course, all babies, all preterm babies, when they are admitted in the NICU, they are symptomatic. Babies require, they are immediately started on antibiotics, and use of antibiotics actually delays the colonization of the intestines. There are some studies which have shown that the concentration of lactobacillus and bifidobacterium is only 1/15 of what it should be at day 30 of life. Prolonged use of antibiotics also limits the number of the bacterial species, both commensals as well as the other bacterial organisms. There is an inverse relationship between the duration of antibiotic and the number of species. The longer the duration of antibiotic, less will be the number of bacterial species within the intestines. And use of prolonged antibiotic therapy also promotes overgrowth of other bacterial species. Some of them are pathogenic. So the bacterial diversity within the fetal gut is restricted, and the volume of these commensals are also restricted. And of course, we are all aware that these commensals, these bacteria play a very important role in immunomodulation, immunoregulation of the gut, and prolonged use of antibiotics actually predisposes to necrotizing enterocolitis in these babies. This is a very, very beautiful depiction of the gut microbiota in term babies and preterm babies. And for understanding the red line, so the first box is for the Staphylococcus, the second is for the Enterococcus, the third is for the Enterobacteriaceae, and fourth is about the Bifidobacterium. The red line actually indicates the gut microbiota in a term baby. The green line and the blue line actually represents gut microbiota in the preterm babies, extreme preterms and very preterms. The x-axis represents the gestational age. The y-axis represents the percentage of these organisms as measured by relative abundance. If you carefully look at this particular graph, this published in 2018 by Corpella et al., you find that a baby who is born at term, if you carefully look at the red line, somewhere around 38 to 40 weeks of life, there is hardly any Staphylococcus, Enterococcus, Enterobacteriaceae. Whereas in the immediate postnatal period, you find that the Bifidobacterium, the red line actually shows an increase in concentration, which means that immediately after birth, the concentration of commensals increases. Once the baby starts feeding on mother's milk, there is hardly any pathogenic bacteria, rather it is the commensal which actually colonizes the gut. Whereas if you look at the blue line and the green line, say for example, a baby is born at say 30 weeks or 28 weeks of gestation, if you carefully look at the x-axis, you find that the blue line and green, you find a huge amount of pathogenic organisms, particularly the Staphylococcus, Enterococcus, Enterobacteriaceae. And in fact, it takes about few weeks for the concentration of Bifidobacterium to reach about, say, 50% of the total organism. So the microbiota in preterm babies, whether the babies are put on antibiotics or not, is completely different from what is there in term babies. In fact, this picture is completely complicated by the use of antibiotics in preterm babies, because most of these preterm babies end up in the NICU and end up getting antibiotics. So what does the early gut microbiota look like in term babies? For example, in term babies who are born by normal vaginal delivery, the gut microbiota is colonized. The gut is colonized by Lactobacillus, Bifidobacterium, Pivotella, etc., which are immunomodulators, which are probiotics. In term babies who are born by LSCS, the gut is colonized by the various skin organisms like the Staphylococcus, Propionibacterium, etc. If you look at the preterm babies, whether they are born by normal delivery or by LSCS, the gut is colonized by the pathogenic organisms, the Staphylococcus, E. coli, Klebsiella, which are there in the NICU environment. So the gut microbiota is completely different in preterm babies as compared to term babies. So again, if the antibiotics are not used rationally, if there is irrational use of antibiotics, of course, the gut microbiota gets altered. There is increased antimicrobial resistance, and we may end up in adverse drug reactions, a lot of medication errors. And unnecessary use of antibiotics also leads to unnecessary cost, which again may break the patient confidence in the treating physician. Now, what are the factors that actually lead to irrational use in antibiotics? So some of these factors, which we carefully look at, it's predominantly the lack of knowledge, because everyone is aware that since antibiotic is one of the misused drug, if one is not aware of the baby's clinical condition, one is not aware of the the usage of the drug, then you end up giving the antibiotics irrationally. And the other important thing is not many units have a policy. So again, whenever if one is managing a neonatal unit, looking after small babies, it's always better to each unit has their own policy, because
share your
hello
screen. Yeah, can you share your screen? No, that slides.
It is visible. It is
Visible?
visible. It's visible. It's visible.
It's visible, sir.
You are having a problem. You are having a problem with your network.
Okay. Sorry, continue. Okay.
Yeah. So each unit should have their own policy. What antibiotic they are going to use, depending on the kind of organism that they separate in their unit. And again, the other factor that contributes to unnecessary use of antibiotic is to have a wrong diagnosis. If your diagnosis is wrong, then you might end up in using antibiotics unnecessarily. The other important factor is the fear. So if we do not want to lose our baby, so the fear of losing patient is again the very important reason why antibiotics are used unnecessarily. The other few reasons which I would quote is the free availability of few drugs. Sometimes the parents may not be able to afford a certain drug, so you might have to compromise in choosing another particular drug for that particular patient. And of course, unethical practice all contributes to irrational use of antibiotics. So if we can address these issues, having a unit policy, having a proper diagnosis, looking at the evidence, again, one can avoid unnecessary use of antibiotics in babies. Now, with respect to NICU, what are the challenges that we face in choosing the antibiotic? The unique challenges in NICU, first and foremost, is the clinical signs in babies are very non-specific. Even a non-infectious process, for example, a baby who has apnea, just apnea alone may look like the baby is having an infection. A baby who has gastroesophageal reflux may show signs of tachycardia, tachypnea, which again resembles infection. So that a lot of non-infectious pathologies in neonates can mimic infection in babies. So we have to be very careful while making a diagnosis. And again, in very small babies, a baby who is weighing just about 700 grams, it's very difficult to obtain sufficient blood quantity for culture. If you look at any microbiology book, or if you talk with any microbiologist, they would require a minimum of 1 ml of blood to isolate the organism, or at least 2.5 ml samples to get the to have a a good culture for obtaining positive blood culture. Sometimes in these babies it becomes difficult, so you might have to end up treating with empirically in these babies. Sometimes even if you're able to isolate an organism, like if you're able to isolate an organism like coagulase negative staph, still you are in a dilemma whether it is a contaminant or whether it is the actual organism which is causing trouble in this baby. So some of studies have shown that the use of antibiotics in just clinical sepsis is several times higher than in proven sepsis. In fact, the blood culture, we all know that it's positive only in about 20 to 30% of babies. So these are some of the unique challenges that we face in NICU while prescribing antibiotic policy. The other important challenge in NICU is about the trends in early onset sepsis and late onset sepsis. The classical definition of early onset sepsis is if the onset of symptoms is before 72 hours of life, it is considered to be early onset. The infection is transmitted from the mother, from the maternal vaginal tract, and the baby is predominantly used to present with respiratory symptoms. Whereas the classical definition of a late onset neonatal sepsis includes onset of symptoms after 72 hours of life, and most of these infections are horizontally transmitted from the hospital environment. Mostly are nosocomial, and these babies present with systemic signs. But these definitions do not hold true now, because it may hold true in a developed country, in a NICU in UK, US, yes, these patterns may be completely different. Whereas in our setup, in Indian scenario, the organism profile is similar, whether it is early onset or late onset. The organism profile is very similar. So the trends are completely changing. So there's no clear demarcation between early onset and late onset. If the area where the baby is cared for, the labor ward is not properly maintained, the NICU is not properly maintained. The moment the baby gets to the NICU, the moment the baby gets an invasive line, the baby is like to get an acquired infection, nosocomial infection. So the organism profile is completely similar, and there is complete overlap between early onset and late onset now. The other important challenge is sometimes we might end up, continuing antibiotic for a longer period of time. The reason being the illness severity. Your culture may be negative, your blood parameters may normalize, but still the baby is sick. So one may still, reluctant to stop antibiotics. So that's another important reason why antibiotics are continued for a longer period of time. As earlier I said, sometimes the culture becomes unreliable. If you grow a coagulase negative staph, it is very difficult to differentiate whether it is an infection or a contamination. Sometimes some babies, the acute phase reactants still remain elevated. The use of antibiotics may sometimes get rid of the organism from the body, but because of the systemic inflammatory response syndrome, the acute phase reactants tend to remain high, which again, prompts you to continue antibiotics. False negative blood cultures. Blood cultures are positive only in about 20 to 30% of cases. If the culture is not properly collected, the blood sample is not properly collected, then the chances of getting a positive blood culture is very less. And as earlier I said, a lack of a unit policy, a treatment guideline, again, and prompts you to continue antibiotic for a longer period of time. Some of the risk factors for longer antibiotic therapy include this Coppola et al. In Journal of Pediatrics published that the baby who is born with an extreme low birth weight, with a smaller gestational age, baby who is asphyxiated at birth with an Apgar score of 6 at 5 minutes, baby requiring endotracheal intubation, surfactant administration, more number of ventilated days, or requiring oxygen for a longer period of time, with a history of maternal chorioamnionitis, tend to receive antibiotics for a longer period of time as compared to other babies who do not satisfy these criteria. Now, what happens if these antibiotics are continued? I mean, the antibiotics are given empirically for a longer period of time. Cotton et al. Published in Pediatrics, where they looked at extreme low birth weight babies. About the total number of babies was 5,693. This particular study showed that if the empiric antibiotic is continued for each additional day, there is a 4% increased risk of necrotizing enterocolitis, and there is a increased chance of death. That is, prolonged antibiotic therapy defined by antibiotic more than 5 days, empirical antibiotic therapy more than 5 days in the absence of a proven infection. For each additional day, there is an increased chance of necrotizing enterocolitis and death. Similarly, Coppola et al. Published in Journal of Pediatrics, where they looked at 300 neonates less than 32 weeks and less than 1,500 gram birth weight who survived for more than 7 days. Again, prolonged use of empirical antibiotic therapy was associated with higher incidence of necrotizing enterocolitis, late onset sepsis, and death. Again, prolonged antibiotic also increases the risk of invasive candidiasis. Use of broad spectrum antibiotics, particularly third generation cephalosporins, is associated with an increased risk of invasive candidiasis, and the incidence of invasive candidiasis vary from 2.4 to 20% in this particular study. Unnecessary use of antibiotics for a longer period of time increases the hospital stay, increases the risk of antimicrobial resistance, particularly multiple drug resistance with increased mortality rate. Now, this is a very important study which I would like to quote here. I think this will probably reflect what is happening in India as well. So this is a study published in British Medical Journal 2009. It's about the neonatal sepsis in South Asia, the spiraling antimicrobial resistance. It's basically based on the literature review where several studies were collected from PubMed and Web of Science. And this particular study included 109 studies. About 69 studies were included from India, 16 from Pakistan, 7 from Bangladesh, 14 from Nepal, and 1 from Sri Lanka, and 2 multinational studies, the young infant study and the etiology of neonatal infection in South Asia study. Now, what did they find? So if you look at this particular, this is very important, which I would like everyone to concentrate. Now look at India. The total number of studies included were 64, which included about 18,761 isolates. So if you look at the incidence of culture positive sepsis for every 1,000 live births, it's about 16 in India. For every 1,000 live births, we are having about 16 culture positive sepsis. And the case fatality rate, that is for every 100 culture positive sepsis, the case fatality rate is 34.4%. And this includes, all neonatal age group. So it's very alarming that for culture positive sepsis, like 1 in 3 babies will die. And about 34 from India, 30 from Pakistan, and total is about 34. And if you look at the organisms that are isolated, about 50% of these isolates are Klebsiella. The 42% of these isolates were E. coli, and 43% of the isolates were methicillin resistant Staphylococcus aureus. Even though we say that viral infections are still playing a role, this particular recent study where they specifically look, these studies were included over a period of 10 years, that is from 2009 till 2018. And over the last 10 years, the bacterial pattern has not changed much, in the sense it's the same Klebsiella, E. coli, MRSA, which are contributing for the culture positive neonatal sepsis with a very high case fatality rate. And the reason for very high case fatality rate is probably because of antimicrobial resistance. This is a study which includes both hospital and community-based studies. So it's, and again, when they looked at the sensitivity pattern of these microbial organisms, now if you look at the first half of the tabulation, if you look at the hospital setting, if you look at Klebsiella, E. coli, Acinetobacter, Staph aureus, you find that almost they are more than 80% of them are resistant to ampicillin. About 70% are resistant to gentamicin, and almost close to 80% are resistant to cefotaxime, ceftazidime. Luckily, still meropenem, they are not. Many of these organisms are still, sensitive to meropenem. And if you look at the community setting, the Klebsiella, E. coli, and Staph aureus, they are still, majority of them are resistant to ampicillin, and however, they are sensitive to gentamicin, sensitive to cefotaxime, ceftazidime, and meropenem. So it's still very clear that the pattern has not changed. We get more drug-resistant organisms in the hospital setting as compared to the community setting. And this particular study, this particular research has clearly shown that the group B Streptococcus, which is considered to be one of the major organisms causing neonatal sepsis in the Western world, in UK and USA, has still not been isolated in the South Asian region. Of course, there are a few incidences where we still isolate group B streptococcus in neonates, but still these studies are still just strengthening what was there earlier. The same pattern of organisms, even though there is a overlap between early onset and late onset, but the pattern of organisms are the same. The significant finding is the majority of them are resistant to the commonly used drugs, ampicillin and gentamicin, which is very alarming. Luckily, till now, still majority of them are sensitive to meropenem. So before going into when to use antibiotic, what kind of antibiotic to use, and how long to use, let's look at few definitions for clarification. Neonatal sepsis can be broadly classified into 3 different types. Like we label it as suspect sepsis, where you suspect an infection, a probable sepsis, and a proven sepsis. Now, when you say suspect sepsis, it means that the baby is at risk of infection, which includes, the baby has some symptoms, minimal symptoms, but your laboratory findings are not conclusive. So basically, you just want to rule out infection. And sometimes, in a perioperative situation, the babies are exposed at risk of infection because of the exposure, because of the surgery. So these situations, we label them as suspect sepsis. The other important category is the probable sepsis, where the baby has all the clinical evidence of sepsis, like the baby has clinical findings suggestive of infection, but laboratory findings are, which shows the counts are abnormal, the CRP is elevated, the X-ray is abnormal, but the culture is negative. You are not able to isolate an organism from the blood. So probable sepsis includes, pneumonia, feed intolerance, NAC, and in even situations where you are not able to make a diagnosis, sometimes you end up treating like probable sepsis. The third important category is proven sepsis, where there is definite sepsis. The clinical findings are suggestive of an infection, and your blood culture is positive. So you might be able to grow up organism from the bloodstream. It could be bloodstream infection, or it could be a catheter-related infection, or from other sites. Sometimes you might be able to isolate the organism from the CSF, abscess, urine, etc. Or it could be a local infection like cellulitis, thermophlebitis. So this is a proven sepsis. Now, why this categorization is important? Because this again helps us in rationalizing or in formulating the antibiotic policy for any given baby. Now, these are some of other definitions, like, what do you call empirical therapy? Empirical therapy, where you start the baby on antibiotics, but still you're not made a diagnosis. So that is called empirical therapy. Definitive therapy is where you make a diagnosis of infection and then you treat it. So that is definitive therapy. Prophylactic therapy, as I said, in a perioperative situation, sometimes at risk of infection, the babies are put on prophylactic antibiotics. As such, in neonates, there is no role for prophylactic antibiotics as of now. So empirical therapy, so in a case of suspect sepsis, where you suspect infection, the culture is pending, you start the baby on empirical therapy. So when you stop your therapy by about 3 or 4 days, you label it as limited therapy. When you continue it for more than 5 days, then you label it as prolonged therapy. As I quoted earlier, the prolonged empirical therapy is harmful. So even when you start on empirical therapy, it's always better to have a policy so that you stop antibiotics earlier once the baby improves. Now, coming to the last part of my talk, how to rationalize when to start antibiotic in a neonate. Now, a baby is born. Now, where does the confusion start? Now, you have a baby who is asymptomatic, but you have a lot of risk factors. Say, for example, mother may have features of infection. There can be prolonged ruptured membrane, maternal fever. But you find that the preterm baby is absolutely fine, breathing well, temperature is normal, no tachycardia, no tachypnea. The question that comes to your mind is, does this baby have an infection? What is the chance that baby becomes symptomatic because of this infection? Now, how to pick up such infected neonate? How to differentiate these neonates from those babies who are not infected? The other scenarios where you have symptomatic babies having some features of infection. The dilemma is whether are these symptoms because of infection. Now, how to prove that these signs are because of an infection, not because of any other illness. So that's how the confusion starts. Now let's look at few scenarios. Now we have scenario 1. There are risk factors in the mother. The baby is asymptomatic. The risk factors include, prematurity, prolonged ruptured membrane, sometimes maternal fever, maternal tachycardia, etc. But the baby is well. Now three options are with us. Now, either since the baby is well, some would like to wait, watch, and then act. Some would, start antibiotics based on risk factors. Or some would investigate proactively for evidence of infection. Now, option one, now wait and watch approach. Now, this again is little tricky because it again depends on, like, if you leave such babies without antibiotics, how many of them would eventually become symptomatic? Now, this is a very good study which published in way back in 2003, where they found that in babies who are more than 35 weeks of gestation, if the baby is asymptomatic, even with risk factors, only 1% of them actually turned out to be symptomatic. So, in a situation where the baby is your clinical finding, if your clinical acumen is good, if the baby is clinically well, even in the absence of risk factors, you can still wait and watch because not many babies would turn out to be symptomatic. But again, in this situation, you need to have a close monitoring. You should train your staff to look for subtle signs of infection. Otherwise, you may end up a baby becoming sicker. The other option for a asymptomatic baby with risk factors is based on the risk factor based approach. This is more commonly used. A lot of risk scores have been devised for these asymptomatic neonates. One of the risk score that I would like to say here is by the Reddy et al. It's again, various factors were looked into based on the multivariable regression analysis. These are the factors which are used for assessing the risk score. One is intrapartum pervaginal examination more than equal to 3, presence of clinical chorea amnionitis in the mother, birth weight less than 1.5 kg, male gender, mother not receiving intrapartum antibiotics, gestation less than equal to 30 weeks. So each factor is given weightage. And if the total score is 6 and above, then there is a very high probability of the baby becoming symptomatic. So asymptomatic baby, risk factors, one option is to wait and watch. The other option is, the risk factor based approach, where based on these risk factors, if the score is more than 6, one would like to start the baby on antibiotics because the chances of such babies becoming symptomatic is very high. The third option is to straight away investigate immediately and then start the baby on antibiotics. But since in asymptomatic babies, there is no ideal screening test to identify these neonates at risk of developing significant infection. So there are various screening tools, but none of them is a single screening tool is not the ideal one to pick up the early onset infection. So a combination of tests could be useful. I'll show you what they are. Now coming to scenario 2. So scenario 1 is an asymptomatic baby with risk factors.
Dr. Karthik, sorry to bother you.
Yeah.
Another 5 minutes.
Yeah. I'll finish. I'll quickly wind up. The other scenario is a baby who is symptomatic due to early onset sepsis. The baby becoming symptomatic within the first 72 hours of life. So the baby is symptomatic and the baby is, and there are risk factors present for infection. You are then you can go ahead and treat with start the baby on antibiotics. Scenario 3 is symptomatic, where you suspect a late onset sepsis and nosocomial infection. Baby developing symptoms after 72 hours. With the clinical signs, one can make a diagnosis of an infection. And some of the blood tests can be used, which will help in predicting infection. So simple approaches, asymptomatic risk factor based approach is useful. For a symptomatic neonate, if there is low probability of infection based on your clinical examination, you can do a screen. If the screen is negative, you can wait and watch. If the septic screen is positive, you can start the baby on antibiotics. If your baby is symptomatic and your clinical examination suggests you have high probability of infection based on various other factors, then you can go ahead and start the baby on antibiotics. Now, what antibiotic to start? Now, the choice of empirical antibiotic therapy, if you look at the guidelines from the developed nations, they say start with ampicillin and gentamicin because the group B streptococcus is very common here. Whereas in our country, it is again very important that we have to individualize. We have to individualize on what kind of bacteria that we separate, we isolate in our unit. So based on our own culture sensitivity pattern, it's always better to start our unit policy to formulate a policy. So what we do are in ICU. So our first line antibiotics is basically ampicillin and amikacin. for intramural babies. For outbound, where sometimes we suspect staph infection, we start them on ampiclox because clox is not available separately. So we use ampiclox and amikacin. Our second line choice is piperacillin, tazobactam, and amikacin, or piperacillin, tazobactam, and vancomycin. And our third choice is meropenem and vancomycin. If your infection control measures are stringent, if you are maintaining a very good asepsis protocol in your unit, then you won't be reaching the third line at all. I would say in the last 2 years, hardly we have used meropenem in 3 or 4 babies, not more than that. So most of our babies end up with ampicillin and amikacin alone. So how long to give? So for the duration of antibiotic, one has to a full diagnostic evaluation is important, looking at the blood count, CRP, other infective markers like procalcitonin, blood culture, etc. The most important is you have to trust the lab. If your sampling should be adequate, and you have to trust your reports. If the serial CRP is normal, or if your serial procalcitonin levels are normal and your culture is negative, baby is clinically well, you can stop antibiotics after 36 to 48 hours. You can use the help of various biomarkers. Just like to quote this Neopin study, which looked at the procalcitonin guided therapy. Procalcitonin is a very important inflammatory marker which rises even before CRP. It helps in making a diagnosis, at the same time helps in guiding your antibiotic therapy. About 1,710 groups were divided into 2 groups. One, the decision of antibiotic was based on procalcitonin. In the other group, it's based on the standard therapy. For the procalcitonin group, the duration of antibiotic therapy was less. So, but of course, getting this test done is a little difficult because it's a little costlier as compared to the CRP. So this is the nomogram to say that if the procalcitonin level is high, more than 0.5 microgram per liter, the chance that baby has an infection is very high. If the procalcitonin level is less than 0.5 microgram per liter, the chance of the baby having infection is less. So these are the various biomarkers which can be used. Commonly used one is the CRP. Procalcitonin is now seems to be a promising tool. So we need to look at the lab cost and the affordability, the feasibility before getting the levels done. So how long to give? If the baby, in the case of suspect sepsis, culture negative, the baby is well, once the blood culture is negative, you can stop antibiotics by about 36 to 48 hours. So once you start the baby on antibiotics and a suspicion of infection, it's always better to have an early exit policy. And if the baby is still symptomatic even after 48 hours and or showing clinical deterioration, then only have to think about upgrading antibiotics as per your unit policy. And as I said earlier, look for other etiologies. Bacteria is not the only cause, or infection is not the only cause of clinical deterioration in units. There are cardiac causes, other non-infectious causes which may have to be looked at. You have to reevaluate antibiotic regimen every now and then. Look for non-infectious etiology. This particular study, the etiology of neonatal infection in South Asia study showed almost equal viral infections in babies from 0 to 60 days of life. This includes both hospital and the community-based study. And one of the common viral infections that they have isolated is the respiratory syncytial virus. So the baby is not responding to antibiotics. Think of other non-infectious causes. How long to give? If the culture is positive, no evidence of meningitis, 10 to 14 days is sufficient. Once the culture is positive, it's always better to narrow down the antibiotic based on the sensitivity pattern. Choose the antibiotic that is least toxic. At the same time, look at the cost as well. In case of culture positive sepsis in the presence of meningitis, one may have to continue antibiotics for 3 weeks. And you might have to choose an antibiotic with good CSF penetration in the presence of meningitis. Again, even if the culture is positive, you have to reevaluate your antibiotic regimen. First, look at the site of collection. Sometimes growth from a non-sterile site, for example, a tracheal aspirate may indicate colonization, not necessarily infection. So you have to take that also into account before changing your antibiotic. And once the sensitive pattern is available, narrow down your antibiotic and stop the empirical antibiotics for which the organism is resistant to it. Suppose if you are isolating a gram-negative bacillus, then there's no point in continuing with vancomycin, because that sometimes you may end up when generating resistant organisms. The third important factor is timing of microbiology report. So you have to discontinue antibiotic therapy as early as possible, because most of the meaningful blood cultures should be positive by 40 hours. If you're not able to isolate an organism by 40 hours, then it's very unlikely that in the sense if you are isolating an organism after 40 hours, there is a very high chance of contaminant or colonizing organisms. So delay in growth may indicate contaminants or colonizing organisms. So when do you upgrade empirical antibiotics? If there is no clinical improvement with the current antibiotic, you may have to upgrade. For any antibiotic, give at least 48 to 72 hours time before you say that this antibiotic has failed. I've seen people changing antibiotic every day. So don't do that, because your inflammatory markers will rise for a couple of days before they start coming down. So clinically look at the baby. Once you start the baby on antibiotic, wait for at least 40 to 72 hours before changing. Okay, antifungals, there's no role of prophylactic antifungals in neonates. There are some risk factors for fungals, only in those babies who require prolonged antibiotic therapy, who are in NICU for a longer period of time, beyond 4 to 6 weeks of life, may require antifungals. Okay, so just to conclude, the 10 fundamental questions that one has to answer before starting antibiotic. The first question is the patient infected with a bacterial agent, or is it a non-infective etiology? Do I need to start the baby on empirical antibiotic based on your clinical findings, whether it is suspect, probable, or proven infection? And you have to be careful while choosing the antibiotic. Make sure that it is less toxic, and put every effort to have a microbiological diagnosis. Make sure that you collect relevant samples, and always look at maternal blood reports, urine culture reports as well before you make a decision to start antibiotics. Look at your unit organism pattern. Are you dealing with drug resistant, multi-drug resistant organisms like MRSA, ESBL, etc.? And what is the most appropriate antimicrobial therapy? And what are the factors that you need to look at while giving antibiotic therapy? And have a clear-cut idea about the duration of antibiotic, whether you're going to give it for 3 days, 5 days, or 7 days. So, and above all, the most important thing is infection control measures. If your unit is infection-free, if your ASAPS protocol is stringent, then you are unlikely to get more infection. So your usage of antibiotic will be very minimum. Thank you. So I think I'll stop here. Thank you, Dr. Thedumurugan. Thank you all. Am I audible?
Yeah, thank you very much.
Yeah,
thank you.
Yeah,
Suresh Balan, sir.
Thank you, Dr. Karthik Balasubramaniam, for your vivid presentation
Thank you,
on
sir.
the rationalizing antibiotic prescription in neonates, covering a very broader aspect, right from choosing the antibiotics in general and about the normal gut microbiota, factors contributing to irrational use of antibiotics, challenges in NICU, trends and reasons for prolongation of antibiotics and adverse effects, etc. When to start antibiotics, what to start, and the 10 basic questions you're supposed to ask. So I request all the participants who are having some queries to post them in the chat box so that we will have it after the next presentation. So once again, thank you, Dr. Karthik Balasubramaniam, for your nice presentation.
Thank you, sir.
Next topic will be on the rational use of antibiotics in PICU by Dr. P.S. Rajakumar. So he is a pediatric intensivist and associate professor of pediatrics at the Sri Ramachandra Medical College and Research Institute, Chennai. And we are very fortunate to have him here on this Tele-Cme, who will be speaking on rational use of antibiotics in PICU. Over to you, sir. Welcome and over to you.
Can you all see the slide and hear me?
Yes, sir. Yes, sir.
Yes, Raj. Welcome.
Thank you, sir. Good evening, all of you. First, I want to thank Dr. Thedumurugan and all the organizers for giving me this opportunity to talk. So the topic given is rational use of antibiotic in pediatric intensive care. And I think Dr. Karthik has already enumerated the principles of antibiotic, selecting an antibiotic in NICU, and many of those principles are common for both in a neonatal intensive care unit and the pediatric intensive care unit. Now, the overview of the talk is going to be about what is rational antibiotic use, why it is important, what are the challenges which are unique to PICU, how to select a drug rationally, what about de-escalation, source control, little bit about antibiotic stewardship, and take-home message. So this has already been covered in the previous talk. So when you say a rational choice of antibiotic, it means you're selecting an antibiotic which is appropriate to the infection. So depending on the organism, the susceptibility of the organism to antibiotic, the site of infection, the severity of infection, the host factors, whether the patient is immunocompromised or immunosuppressed, getting the drug dose correct, adequate dose, correct route, and the method of administration, whether you're going to give it as a bolus or going to give it as an infusion, and what is the duration of antibiotic therapy, like whether you want to give it for 7 days or 14 days. Plus, you take into account the other important factors, what is the cost factor, whether the patient is allergic to that or not, all those logistic availability in your hospital. The next other two important thing is minimizing the side effects of drugs. And in the current era, minimizing development of drug resistance. That seems to be the main reason why there is so much emphasis on rational antibiotic therapy. So this, to start with history, we all know this is Alexander Fleming, who discovered penicillin in and was given Nobel Prize in 1945. But what he told in his Nobel Prize lecture is very relevant even today. So what he says is, if you don't give adequate dose of antibiotic, and the microbe is exposed to non-lethal quantities of the drug, it may make them resistant. So as far as 1945, the problem of antibiotic resistance was envisaged and was actually verbalized by none other than Alexander Fleming. And these words are true even now. And why this antibiotic resistance is so important. So what we see may be a tip of an iceberg. Like in our unit, the incidence of carbapenem resistant enterobacteriaceae is very rare. We get occasionally, maybe I would say less than 5%. But what we see is only a tip of an iceberg. If we don't take it seriously, we'll only face the fate of the Titanic ship. So however strong your unit is, it's going to collapse. Now, this is a few statistics to drive home the importance of the problem of drug resistance, how serious it is. If you take any antibiotic which is introduced into the clinical practice and see the duration that it takes for the drug resistance to develop, there many drugs develop resistance in a very short period of time. So in the y-axis, we have the names of drugs and the class of drugs. And in the x-axis, we have the time in years, 5 years, 10 years, like that. If you see, many of these antibiotics develop resistance within the first 3 years of introducing into the clinical practice. Some drugs like vancomycin has stood the test of time, and the resistance developed much later, only recently. So this tells you the rapidity with which microorganisms develop resistance. And I have to acknowledge, like, some of this, the next following slides are actually from Dr. Irasha, who is an ID physician from Mumbai. This slide tells you about the timeline of drug resistance, like the chronology. Like if you see this sulfonamide was introduced in 1930, developed resistance in 1940. You can see the duration, within 10 years. So some drugs it will be even shorter than that. And only drugs like, as I said, vancomycin from 55 to 1990, the gap was big. Otherwise, over a period of time, we have seen a lot of antibiotic resistance. It is continuously increasing. Now, it was known for a long time, but the seriousness was realized for the first time in 2004, when Infectious Diseases Society of America came out with a paper entitled Bad Bugs and No Drugs. So, in fact, they sent a white paper to Capitol Hill, that is the government, assessing the rapidly growing public health crisis in the emergence of bacteria that were resistant to most of the antibiotics. And they even said that if there are no more antibiotics in pipeline at that time, and if the situation is if the situation continues, then we would be left with no choice other than accepting death The only hope being the patient's own immunity. The person is immunosuppressed, then there is no chance for the patient to survive the multi-drug resistant organism. So this was started in way back in 2004. Then following that in US, in California, they introduced a lot of legislations. Like it mandated every hospital to have a committee to evaluate their antibiotic use, to create an oversight committee to monitor responsibilities for this issue. And it became a well-known problem. And then in India, if you see, it came into focus after the New Delhi metallo-beta protease was discovered in Delhi. So carbapenem resistance and the seriousness of that was came into play. And in 2011, the national antibiotic policy was formulated, and there was a complete ban on over-the-counter sale of antibiotics and restrict the usage of third-line antibiotics only to tertiary care hospitals. So in theory, it looked like a fantastic concept, but then immediately it was publicly withheld by the health minister because of a lot of resistance from both healthcare industry as well as pharmaceutical industry. So this never came into practice actually. There was a Chennai declaration. A lot of ID physicians came out from a declaration in 2013, and it's called as a Chennai declaration. And they made recommendations, why there is a problem in tackling this, how it could be amicably solved so that all the players accept the restrictions. And the health ministry organized meetings of task force members and were supposed to come out with a national antibiotic policy. But in practice, we still don't have an existing robust antibiotic policy which is able to solve the problems. And on the same sidelines, there is another paper from NEJ, of course, it's from adult medicine, where there was recurrent episodes of Clostridium difficile due to antibiotic use, and they could not eradicate with oral vancomycin and metronidazole. In fact, they tried duodenal infusion of donor feces. So the situation became that bad, they ran out of all options. And imagine you infusing another person's feces into your own gut just to escape Clostridium difficile. So things were becoming very bad, and still the problem continues. So why this problem is continuing? So what are the challenges that we face in PACU? So one of the main reason is most of the patients who come to PACU are severely ill, and probably they have only, and many of the time the primary diagnosis is infection, or sometimes they have other multi-organ problems and for which they need intensive care, and then during the course of illness they acquire a hospital-acquired infection. And many times the only one probable chance for them to survive is a good broad-spectrum appropriate agent. And again, we need to start it very early when a lot of information is not available, and so about the patient, about the organism. So many times you are forced to use higher an antibiotic upfront. So one of the main thing is the child is so sick, why? How can I take a chance? What if a narrow spectrum antibiotics fails? The second one is most of the patients who come to PACU are already referral patients. They're already managed in the community in the early days of infection, and many times they're already given broad spectrum antibiotics. How often we see a community-acquired pneumonia treated with oral linezolid. Linezolid is probably the only drug that is left out for resistant organisms like vancomycin-resistant enterococci. But because of the ease of availability and an oral route, sometimes it is abused in the community. So already when they come, they're already on multiple drugs, meropenem, vancomycin, and fluconazole, and they are referred to the hospital. So what do you do? So would you stop it on the first instant, whether they have acquired some infection in the referring hospital? So this always is a big question for us to decide what to do. Then a patient in a PACU is managed usually by multiple consultants. In addition to the PACU doctors, you will have a surgeon, you will have a physician, you will have other super specialists, and everybody may not be in the same page with respect to the view of antibiotics. There may always be, and you need to have some give and take on selection of an antibiotic in a particular child. And sometimes some of the things that we do, taking a culture, especially repeat culture, 2 sets of blood culture, then the markers for infection, and some of the sepsis panel. Many of these things are high cost, may not be available in some centers. Some of the patients may not be able to afford it. The next one, certain things like minimum inhibitory concentration of an antibiotic or the hospital antibiogram is not available to the clinician to make decisions. So many times we have to use your gut feeling and your theoretical knowledge of whatever happens in other hospitals to decide our antibiotic. And many times the cultures themselves are negative, either because they have already received antibiotic outside or the amount of blood taken is not adequate. So for various reasons, the antibiotic, the culture result as such is negative, and that prevents us from de-escalating. Even if the child improves after 72 hours, what do? We don't know the organism. So which one has made an improvement, especially if you use the combination to start with. And similarly, there are various formulations and various brands. You have, for the cost sake, we may use a generic brand and other things. So again, whether they are all really of same efficacy, we absolutely don't have any idea. So we go many times by what the pharmacy company person representative says, and which may not be true. So these are some of the challenges that we say. So this is just the overall, what is the seriousness of the problem and why it is a big problem. So now with this background, now let us just see a scenario and then see what can be done about it. Okay, so this is a 16-year-old girl who came with partial hanging, and because mother scolded her. Nowadays, children are very sensitive, so she hung herself, and there was a prolonged period of hypoxia. Had a low conscious level, came with shock because of cardiac dysfunction, was intubated in the emergency room, was started on inotrop. So this is the X-ray of the child. So on day one, he's only hanging, there is no fever, but the ER physician thought, the child is very sick, already intubated, and we have put a central line for the inotrop. So we need to do something to prevent infection. So started amoxicillin, and because there was no fever, they did not take any culture. So then the patient came to ICU. Then 3 days over, then high fever spike started now after 3 days. Still child is ventilated, conscious level is not improved for extubation. As a central line now for the inotrop. Now what do you do? So already is on amoxiclav, so they wanted to do something more higher spectrum. So antibiotic was escalated to meropenem. This time cultures were taken. Thankfully, at least this time cultures were taken. Both blood and endotracheal cultures were taken. And they, on reviewing after 3 days, fever is still not settling. And now the kidneys also started failing. And the blood culture by now is growing coagulase negative staph aureus. So what do you do now? So coagulase negative staph aureus, they thought, okay, it may be a contaminant, or patient is sick as the central line. So maybe it is the skin colonization has gone into the bloodstream. So with that rationale, they started vancomycin. And this is already now 7 days over, so on iron antibiotics. So why don't we add fluconazole? So vancomycin and fluconazole. So still there is no improvement after 48 hours. So what do you do? And then you call an ID consultant. This sometimes happens in an ICU setting. So what are the things which have gone wrong here? To start with, when the patient came, it was non-infective cause. Even though the patient was sick, there was absolutely no indication for starting an antibiotic. Prophylactic use of antibiotic in a ventilated child or in a child with a central line to prevent ventilator-associated pneumonia and central line infection, not correct. And again, there was no culture which was taken. Somebody is raising hand. Should I respond to that? Okay. And the next thing is after 3 days. The next thing is after 3 days, the child was not improving. Again, they were escalated to meropenem without knowing what is the site of infection, what is the organism. There is no clue because culture was not taken the first time. And then after 3 days, the second time around, the culture was sent, but it has grown coagulase negative. So most probably it is because of inappropriate sampling. The skin contaminant is probably grown. And only one culture was taken. So if they had 2 cultures, at least they would have had a benefit of doubt, whether it is growing from both the bottles or only in one culture. That would have helped them to differentiate whether it is a skin colonizer or a skin contaminant or a real infection. Even that was not there because only one culture was sent. And again, they added fluconazole and vancomycin without a definite evidence for fungal infection. Again, fluconazole was added. So this is a common scenario. So what can be done? How to avoid all these things? Now, I don't know whether people have seen this movie 12B. So for those who have not seen, no, this movie will go into two halves, no? Like he will catch the bus 12B or the hero will miss the bus 12B. If he catches the bus, what happens to him? A different thing unfolds in the story. And if he misses the bus, a different thing happens. So like that, if the same patient, if we had applied the principles of rational antibiotic therapy and antibiotic stewardship, how story could have been different. So let us just see this. So by the way, what is antibiotic stewardship? It is just a mechanism to monitor the use of antibiotics. It may be a coordinated effort between different people, depending on the hospital. You may have the medical team, ICU team, and the microbiologist, or sometimes you may have an ID specialist replacing the microbiologist. You may have a pharmacist in some hospitals. So the main objective is to minimize the development of drug resistance, along with minimizing toxicity, minimizing things like Clostridium difficile. And this should be combined with a comprehensive infection control program to limit the emergence and transmission of drug resistance. And this has a lot of impacts on reducing the healthcare costs and improving the overall outcome of patients. Now, again, with the same patient, so should we start antibiotic on the first thing? So how to go about it? So in general, I think most of the things were covered in the previous talk, just to use the principles and apply it in a given patient. So first question is this an infection? No, this patient has come within 1 hour of hanging to the hospital, and the child is very sick, but the sickness is because of the hypoxic insult, and there is no fever, and there is, as I said before, there is no role for prophylactic antibiotic to prevent infection, VAP in a ventilated child, to prevent a line infection in a child with central line. So that prophylactic use is not indicated. Is this a bacterial infection? Again, there is no question of bacterial infection. There is no, the other questions you don't have to answer, but we'll go through this question. Is this bacterial infection? What are the site of infection? What is the host? Who is the host? What is the age of the patient? Whether the patient is immunocompetent or not, because this decides what is the organism. For example, if a child comes with an infectious syndrome, for example, a lung infection, pneumonia, or a CNS infection. So depending on the age and depending upon their immunocompetent state, the organism will differ. So it is important that we take this factor into consideration before selecting an antibiotic. And what are the likely organisms? Using these factors, what are the likely organisms? Whether it is a community acquired or hospital acquired. We know that hospital acquired, the chance of drug resistance is going to be more, but nowadays we have a lot of drug resistant organisms coming from community itself, especially ESBL. ESBL gram-negative infections we are getting from community, not just hospital acquired. And what is the likely susceptibility pattern? No, is it just ESBL or is it even carbapenem resistant Enterobacteriaceae? So what is the likely susceptibility pattern? Then the other logistic factors, no, is it available? What is the cost? What are the side effects? And will it suit the patient's underlying condition? So use all these principles and then select. For example, this patient, there was no role for a prophylactic antibiotic. So let us assume that this patient is not started on antibiotic. So in that case, how would you prevent infection? So the next question is, this patient is very sick, is having invasive things. That is correct. And you're not putting on any antibiotic. But how will you prevent infection? So again, this is just by simply following some basics of infection control. Like any invasive procedure you do, like for example, a central line insertion, you need to use full personal protective equipment. Of course, now I don't have to tell much with the coronavirus pandemic. People have started using more than this level of PPE for even touching a patient, probably, or sometimes even the patients are having more PPE than the doctors now. So in fact, the hospital-acquired infection, it will be nice to see the incidence of hospital-acquired infections during the COVID time for patients admitted for other reasons. My guess would be that the infection rate would have been less because everyone uses PPE, at least fearing coronavirus, even though they are not afraid of multi-drug resistant bacteria. And for any procedure, whatever things are required needs to be kept at the bedside. You know, for a central line, you need to have all this, this for the intubation, this for central line, all the different sizes, central line tray, gloves, suture material. Because it's simple fact, if everything is not available, if for one component is missing, then in an emergency, when the patient is sick, the clinician may do it without using that. And if you're using ultrasound to make sure that you get it without much delay, multiple attempts, Again, you need to have everything available. If it is available, then the chance of using is high. And if you use everything, the chances of preventing infection is high. Then once the patient has invasive airway and invasive lines, then how to prevent infection? There are predominantly the nursing care plus the treating doctors, especially the junior doctors who handle the patient on a round the clock. Like all the steps of hand hygiene should be followed. And things like central line, you can use devices like bionectar and clay connectors, which are not routinely recommended by CDC. But if the infection rate is high, which is the case with many of the units in India, using these devices helps in reducing the incidence of infection. And again, of course, here even the dressing should be transparent. So you can use gauze dressing only if there is soakage or oozing from the line. And you follow certain things like bundle. So when we say a bundle, it is a set of interventions. If you do everything as a whole, it achieves much better results than individually applying them. So we have a CRBSI bundle. CRBSI is catheter-related bloodstream infection. So this is a terminology which we say when a patient has a central line infection and the central line is the cause of the infection. This has to be differentiated from another terminology which is called as CLABSI, which is central line associated bloodstream infection, CRBSI and CLABSI. When you say CLABSI, it means you have a line, you have a blood culture proven infection, and you don't have an obvious external source other than a bloodstream infection. But you cannot be 100% sure that it is the central line is a cause for the infection. When you say CRBSI, catheter-related bloodstream infection, again it satisfies all the criteria for CRBSI. Line should have been there for more than 48 hours. Blood culture should be positive. But the extra thing, and there should be no other source of infection. But the additional criteria is, if you're taking a culture from both central and peripheral line, the same organism with the same sensitivity pattern should be grown from both the cultures, and the one from the central line should grow faster than the peripheral line, maybe more than 2 hours compared to the peripheral line, provided you take both the cultures at the same time, one after the other. So here we are saying that the central line is a cause for the bloodstream infection the patient is having. So to differentiate these two things, these two different definitions are there. But when we say CRBSI bundle, it is not about CRBSI, it is about preventing CRBSI. What are the interventions we do? This is one of the forms, like the nurses are supposed to do it every day and they have to put yes, no. For every shift, in fact, they have to do it. Of course, the initial things are at the time of insertion. Like assess, the remaining things are all about everyday care. Whether the nurses use hand hygiene every time. And they are really assessing whether there is a need to keep the line every day. When it is not required, you remove it. And then at the time of insertion, as I told, whether all the prepared cannulation trolley with all the necessary items are available, whether the person who inserted used a surgical barrier precaution while inserting the line, preparing the skin, 2% chlorhexidine was used. So these points are all for at the time of insertion. The remaining things for day-to-day care of the central line for the nurses and doctors, sterile transparent dressing, which should be changed whenever it is soiled. You should not use ointments for dressing. Look for signs. The main reason for keeping a transparent dressing is you can see whether there is any signs of site infection, like pus discharge or redness. And cleaning access port with alcohol before line access. So each port of the central line when you're accessing, you have to clean with alcohol. No routine change of catheter. Just because the line is in place for 7 days, you don't have to remove it. And again, if you're suspecting infection, putting a guide wire and changing the line, again, that is not indicated. And if at all the infection is proven, you may have to remove and insert a line in another site rather than putting a guide wire and changing it. If you're using things like TPN, then it should be at a dedicated port because the infection rate increases if you use that. So these are some simple interventions. If you do everything together, the chance of line infection is less. So you follow all these things. So similarly, you have a VAP bundle to prevent ventilator-associated pneumonia, like hand hygiene, keeping the patient elevated. Sometimes some patients, we may stop the sedation to assess whether they are ready to come off ventilation, but it may not be appropriate for every child. Using oral care with chlorhexidine. And the other two, there is not much of evidence in children. It is mainly from adults, using peptic ulcer prophylaxis preventing DVT prophylaxis using heparin. That is all not required in children. And frequent emptying of content. This is something which is very pertinent for children because we always use heated humidified ventilator circuits. You have to make sure that the water condensates and the water trap is at the lower level, or you use a heater wire circuit in both the limbs to prevent water condensation. Whether chest physiotherapy, and whether you're trying whether the child can breathe spontaneously every day. So these are certain things. So similarly, I won't go into the details. Similarly, to prevent urinary tract infection, you have a UTI bundle. So all these things should be used every day and it should be monitored. And if you do that, the chance of infection is less. Now let's go back to this patient, what happened. So the same patient, we didn't start any antibiotic in the beginning, but let us say after 3 days, fever spikes appear, child still ventilated as central line. Now what would you do? Would you start an antibiotic like ceftriaxone? I think maybe here it will be difficult. I don't know whether people will be able to type an answer. What would you do? Would you start ceftriaxone, or you would still wait, or would you do something else? Okay, I'll go to the next slide. Maybe it is difficult to interact with an online session. Again, you follow the same same principles. Now, is this an infection? Yes. So now this child has fever, new onset fever, and very likely it is an infection. Whether it is a bacterial infection, even viral infection is possible, even in the ICU. But let us say we do a white cell count and a CRP, both are high, showing neutrophilic leukocytosis. Again, whether these inflammatory markers are routinely necessary for doing it, especially a costly investigation like procalcitonin. So there is no evidence to say that you can decide whether to start antibiotic or not to start antibiotic using just a biomarker. Even if you use procalcitonin, if it is high, we will start. If it is low, we will not start. That much of power these investigations definitely do not have. And but then what is the point of doing it? No, it is only useful for other reasons. Like after 48, the decision to initiate antibiotic is clinical. But once you start, and after 48 hours, if the child is clinically better, no fever, and the initial culture is negative, then it becomes easier for the clinician to stop the antibiotic if the initial inflammatory markers were negative, the culture is negative, and the clinician is better, and the child is better. But if the initial inflammatory markers were high, then some clinicians may want to continue the antibiotic for a little longer. So that way it may be useful in reducing the, stopping the antibiotics more proactively. Or if the CRP was high and the organism is growing, is grown in the blood culture, then the duration of antibiotics can be adjusted. If the inflammatory markers settle, when it is repeated after say 5 days, when it is significantly, the inflammatory markers have significantly come down, you can cut down the duration of antibiotics. So now we are cutting down the duration of antibiotics from 14 to 10, and there are some infections where, like ventilator-associated pneumonia, we treat only for 7 days. Even a sick patient with ventilator-associated pneumonia, if the fever settles down and if the ventilator settings come down, if the organism is isolated and we are giving an appropriate antibiotic, and if the inflammatory markers settle down, we don't continue antibiotics beyond 7 days. So previously we used to treat for 10 to 14 days. So that can be cut down by using inflammatory. So that is the main use, but it is not useful to decide whether to initiate or not. Still it is lying, it is to our clinical judgment. Now in this particular patient, what are the site of infection? So again, the child came with a hypoxic insult, whether that is causing it. Sometimes brain injury can cause central fever. So usually those children, their neurological status would have worsened and they may have other brain stem signs. So this child is not having any such things. Then this child has a central line that could be a possible source. The child has is intubated on ventilator. So you need to see whether the secretions are very thick. The nurses may be able to give a good idea about how the secretions are changing, and whether the ventilator settings are increasing, whether there is increase in the oxygen requirement, whether the white cell count is high. Of course, that we know. Whether the chest X-ray is showing new infiltrates. So those things will tell whether the lung is the focus. If the X-ray is clear, the ventilator settings are the same, and the secretions are not changed, then inspecting the back, inspecting the skin and over the body for any skin and soft tissue infection. Nowadays, with the use of alphabet and the good nursing care, the chances of bed sores become very less nowadays in the most of the ICUs now, but still it is a possibility. If the skin is intact, the lung X-ray appears normal, then the most of the time it is either the urinary infection or the central infection. Most of the time, the serious one is going to be the line infection. So again, this patient X-ray, ventilator settings, back, urine, everything is normal. So you're mostly left with central line. And the age and the immunocompetent or not, again, we already know this patient is immunocompetent and we know the age of the child, so that we will skip. And what are the likely pathogens? Now with the central line, if you go by the literature, most of the books would say Staphylococcus aureus, no? Staph aureus and Staph epidermidis, because they are the skin organism, then they may go enter the line. And that is the most common organism given in most of the books. But in but if you see in our unit, it is almost 9 out of 10 times gram-negative bacteria rather than.
Dr. Rajkumar, sorry to bother you.
Yes.
Another 5 more minutes.
Yeah, okay. So rather than a gram-negative bacilli, rather than a gram-positive bacteria, so you would actually select a gram-negative cover like Piperacillin tazobactam rather than going for vancomycin or cloxacillin. Again, we know it is hospital acquired. And what is the likely susceptibility pattern? The likely susceptibility pattern is ESBL. The carbapenem resistant enterobacteriaceae is extremely rare in our unit, so we don't use drugs like colistin upfront. And again, meropenem and piperacillin, which one would you choose? The child is not in shock and just a fever. You would rather use a narrower, a lower spectrum like piperacillin tazobactam rather than meropenem. So this child after 48 hours still has fever and piperacillin tazobactam started after taking 2 sets of blood culture. So the important thing is to always take a blood culture, an adequate amount of blood culture. If you use a pediatric bottle, at least you need about 1 to 4 ml. And 2 sets of cultures are required for you to differentiate whether it is a contaminant or not. And the important thing is to initiate the antibiotic early. Like this is from an adult intensive care unit. So every hour of delay in initiating the antibiotic increases the odds ratio of death. Even 6-hour delay may increase the odds ratio of death by 10 times. So you should always start the antibiotics at the earliest. And if you are using the antibiotic, how would you use it? So you use the pharmacokinetic principles. So some drugs act by the peak concentration, like aminoglycoside. So those one, it is better to give 1 dose every day, once a day with a higher dose. Some drugs, the time that their minimum inhibitory concentration, their drug level is above the minimum inhibitory concentration, how long it is above is an important factor, like beta-lactams. So these antibiotics, it's better to give over 4 hours. Every dose is given over 4 hours rather than over bolus dose. So we can optimize those things. So this child after 2 days, still fever is there, but child is clinically better and it is growing ESBL, Klebsiella, sensitive to piptas and mero. Just because fever is persisting, would you escalate the antibiotic to meropenem? So again, some people might do, but then you always have, I'm skipping this slide for want of time. So you always have the other weapon with you is source control. So the organism is sensitive to piperacillin tazobactam, your antibiotic choice is right, but the presence of fever continuing after 48 hours just indicates that you need to tackle the source. So just removing the central line, getting a peripheral line, and by this time the child is already off inotropes, you can certainly do it. So similarly, when it comes to a lung infection, if there is a pus in the pleural cavity, you need to drain it. So this child is better, central line is removed, piptas is continued, after 2 days child is extubated, there is no fever. How long would you do antibiotics? So again, we have seen the shorter duration is as good as longer duration. So the line is removed, the child settles, things like staph epidermidis, even 7 days is enough. For an ESBL like this, 10 to 14 days would be needed. And for VAP, as I said, 7 days would be enough. So you shouldn't settle with that. You need to do a root cause analysis. Why this child had a line infection? What can be done? What corrective and preventive actions can be taken? So there are different methods for doing that. I'll skip that. If you, all these terminologies are new and confusing, it is just investigating what happened. Another way in that. So the way we do it is very important. It should be like a team huddle like cricket and not like a court judgment where you are finding fault with the doctors and nurses. So there will be a form and you do an analysis and then find out. Maybe it is because, they inserted the central line, the first person wore the PP, the second person who came to help did not wear the PP because the second dress PP kit was not available. The hand hygiene complaint was less during that week because the census was high and the new nurses from other area took care of the patients. So what do you do for that? You empower the nurses to stop the line insertion if the PP is not worn by the doctor, having an extra central line, having things like ultrasound which may prevent failure on the first time itself. For the nurses, constant training of nurses, making sure that they use hand hygiene all the time, and adequate availability of sanitizer. So you find the cost of, these are all statistics I'm skipping. No, nothing is rocket science, but the problem is we are very good in doing all rocket science. But when it comes to common sense, it is not always practiced because it is difficult. So, part of my talk would have looked like infection control, but it is because antibiotic stewardship and infection control go in hand. We cannot select rational antibiotic without using infection control principles. Now, just one point, if you have an ET culture growing candida, what would you do? A urine culture or ET culture growing candida, even if the patient is having fever, usually indicates colonization. You don't have to jump to give antifungal. And the third scenario, I'll just tell one point. You have, this is a patient with ALL relapse, neutropenic, ventilated shock, central line on Miro-T CoAM4, and the blood culture is carbapenem resistance. So what do you do with that? So this is one of the new emerging problems. So the drug resistance, the traditional DISC method is there, but the newer method is MIC, and the even more recent method is molecular test. So you can do tests like to know the molecular genetic mechanisms. So these are the various mechanisms. This was actually Klebsiella which resistant to all, but it was the mechanism of resistance was OXA48. So with this, you can decide which antibiotic to give. Rather than colistin, these children will respond to drugs like ceftazidime, avibactam. This is another newer antibiotic. You can avoid the use of drugs like colistin, which you want to reserve it. So this is like mechanism of resistance, which newer antibiotic we can use or not. So this is one of the emerging trend in units which see a lot of drug resistance. That is a problem. And not only that, you need to isolate this patient. Just
Dr. Rajkumar, one more minute, please.
Yeah. So isolating this patient is very important, and you may involve an infectious disease specialist, and a teamwork of all the doctors working in the ICU is very important to come out with protocols and make sure that all these things are implemented. So why it is all very difficult to implement? Is it because of ignorance? I don't think ignorance is a factor. Lack of time, yes. Lack of resources, yes. But the problem is probably not a lack of solution. It is a lack of acceptance. We don't accept the seriousness of the problem because it involves a change, and any change in our habit, the way we do, is very difficult. Unless we accept the seriousness and we believe that we can make a change, we can definitely make a change. So I'll come to the last slide, take-home messages. If the take-home message from this talk is on expert carbat test and use of newer drugs like ceftazidime and avibactam and fecal therapy of Clostridium, then probably I failed in what I wanted to convey. So the more important thing is antibiotic resistance is a serious problem. Just using simple principles of selecting an antibiotic and then using infection control measures and identifying what is happening in your unit and find ways of improving the quality of care given. That will go a long way in avoiding. So this is the summary slide I want to give. Every time you select an antibiotic, always go through this checklist. I think Dr. Karthik made 10 points. I had 8. I think he had 2 more. So if you just follow those 10 questions, 10 points before you select an antibiotic, then you can go a long way in preventing the emergence of drug resistance. Thank you. I'll stop.
Thank you, Dr. Rajkumar. Sir.
Thank you, Rajkumar. I think you are nicely explained about rationale of antibiotic usage in PICU. More than that, you have to explain about ICU care bundles. That's very important. IV line as well as WAP bundles and as well as central line bundles like that. You have narrated nicely. And any questions from? Yeah.
So we got 1 or 2 questions. One to Dr. Karthik.
Yeah.
That is the empirical antibiotic use in high-risk neonate, either cephalosporin or along with aminoglycoside. Empirical antibiotic use in high-risk neonate.
Hello. Yeah, can you hear me?
Yeah.
See, the question is, do you start empirical antibiotics in a high-risk neonate? The decision to start antibiotic just not rests on the neonate is high risk or not. It depends on whether the baby is symptomatic or not, whether symptoms are because of infection or not. A preterm baby, 28-week, 1 kg baby, of course, it's a high-risk neonate, but it doesn't mean that the child is at risk of infection. That doesn't mean the child has symptoms suggestive of infection. Say, for example, I'll give you a clinical scenario where a baby is born at 28 weeks of gestation with a birth weight of, say, 1 kg or 900 grams. The indication for preterm delivery is maternal PIH. Mother has IBP or evidence of preeclampsia, that there are abnormalities in Doppler where the blood flow to the babies are affected. Now, baby is delivered by cesarean section. No, it's a clean delivery with intact membranes. The baby is symptomatic because of respiratory distress syndrome. So in this scenario, there is no indication to start the baby on antibiotics immediately. The baby is born under a by cesarean section. The baby is admitted, baby is on ventilator support or CPAP support just for premature lungs. The baby needs surfactant therapy. There is no indication to start antibiotics straight away because we have managed so many babies, so many small babies without antibiotics. But the same situation where the mother has prolonged ruptured membrane, mother has fever, there is evidence of chorea amnionitis, she has UTI, the baby is delivered in such a scenario, yes, and the baby is symptomatic, then in such a situation, it's very difficult to differentiate whether the distress is because of RDS or the baby has a congenital pneumonia. In that situation, you may start the baby on antibiotics. So just high-risk neonate doesn't mean empirical antibiotic therapy. High-risk neonate with symptoms, and whether symptoms are because of infection or because of other reasons, then you can consider starting the baby on antibiotics. If so, the other question is, if so, is it a broad spectrum cephalosporin alone or along with the aminoglycoside? The first choice of antibiotic will always be always depend on your unit policy. Say, for example, if you have a very good infection control, you can manage the same baby with first-line antibiotics like ampicillin and amikacin or ampicillin or gentamicin. At most, you can use second-line antibiotics, which may be peptaz or peptaz with amikacin. The use of cephalosporins initially it's little tricky because there are few reports where the use of cephalosporins as an empirical therapy increases the chances of antibiotic resistance, increases the chances of invasive fungal infection. So even though a beta-lactam along with aminoglycoside will be the preferred antibiotic choice, it will be rather penicillin group of drug with an aminoglycoside is preferred as compared to a cephalosporin with an aminoglycoside. And cephalosporin, because there are a few case reports where they've seen that the use of cephalosporin has increased the risk of NEC, drug resistance, candidiasis, etc. So you do not have to go and start straight away with cephalosporin. I think the first-line antibiotic, ampicillin, amikacin, or peptaz amikacin would be beneficial. But again, you have to look into your organism pattern. The best thing is to look at the organism pattern for the previous 6 months. The previous 6 months blood culture growth, the sensitivity pattern will definitely help you in guiding your antibiotic policy.
Karthi, I think you are a consultant at Women and Child Health. I think you are doing wonderful work. And the past 6 months, what's an organism in your NIH is getting?
Sir, we have a very good asepsis protocol in our unit. Most of our infections are, I would say, it's early onset vertically transmitted. Of course, we have grown Klebsiella E. coli, but these are scattered episodes. In the last 2 years, we had 2 episodes of outbreak. One, we had a Serratia outbreak. We had 4 babies growing Serratia simultaneously in the unit. So we had to ship all the babies to the ICU. We have to clean the unit, fumigate. We have to, basically we couldn't find out where the organism had come from. And ultimately we found that it was from the stored maternal milk, which was used because all these babies, out of these 4 babies who grew Serratia simultaneously, we lost one of them because of severe fulminant sepsis with NEC. And all 4 babies had a similar clinical presentation. They had present with feed intolerance, abdominal distension. And when we looked at we did a detailed analysis when we looked at the surveillance cultures. Ultimately, we grew Serratia from one of the stored milk bottles which we had in our fridge. So we had to completely shut one of the rooms and we had to isolate the babies. The other outbreak that we had was almost a year back. We had a Klebsiella outbreak. We had around 5 babies growing Klebsiella. And again, there was a breach in the asepsis protocol and we had to completely get it rectified. So we get, as of now, we are getting cultures only on and off. Yeah. So it's Klebsiella, Serratia, we do see E. coli. We haven't seen Acinetobacter in the last 3 years. We haven't seen the fungal growth in the last 3 to 4 years. It's Klebsiella, Serratia, E. coli predominantly that we see in our unit. And luckily, till now, all these organisms are sensitive to the commonly used antibiotic. Even if they are resistant to ampicillin, they are sensitive to amikacin. We haven't seen any resistant to amikacin as of now. We have seen resistance to ampicillin.
Yeah, that's actually, you have to tell correctly. At the individual ICU, I think they have to find out what's antibiotic regimen for that particular ICU.
Yeah.
That's very important, because if you are taking some ICU for Pune, they are having to start with ciproflox because whatever the organism that's prevalent in that area, that's very important. That the standard is of antibiotic, we can tell that sometime empirical, but we have to, each ICU, they have to formulate and they have to use minimum antibiotic. That's correctly said. Thank you. And I think you told that procalcitonin, that's actually, now it is definitely guide us for going for antibiotic, initial empirical antibiotic. I think
one more question. Best agent for skin cleaning before vaccination, venipuncture, or giving starting an IV line, taking a blood for culture. What is the best agent for skin cleaning?
Regarding skin cleaning for vaccine, sir, we are not advising any antiseptics. We are only giving sterile water only. That's the indication. I think regarding blood culture also same thing. And regarding venipuncture and the insertion of IV line, I think Dr. Rajkumar can tell.
No, for venipuncture and IV line, standard recommendation is to use isopropyl alcohol. Some units may use chlorhexidine, but for central line insertion, we use chlorhexidine. They have compared chlorhexidine, isopropyl alcohol, and povidone iodine, and they find chlorhexidine to be a better agent to prevent line infections. So otherwise, for venipuncture, isopropyl alcohol, and for central line, chlorhexidine.
Okay, sir. So I think with this we will conclude the first 2 part of the scientific program. Rajendra sir, can you introduce the next speaker, sir?
Yeah, please. Next one is I would like to introduce Dr. Kritika from Tele-Cme Medical College, and she's going to talk about rational anti-tuberculosis therapy. Can you project your first slide?
Yes, sir. I've started sharing my screen, but it's not coming up.
Thiru, can you help?
Hello.
The screen photo vandrichu. Screen la photo. Yeah. Okay.
She's assistant professor, government Tele-Cme Medical College, and undergraduate from Madurai Medical College and PG Madurai and Institute of Child Health and Research. Yeah, you can start, doctor. Thank you.
So I couldn't move my slides, sir.
Thiru, can you?
Yes, sir. So before beginning my topic, my tons and tons of thanks to the triumvirate, Dr. Sendil sir, Dr. Suresh Balam sir, and Dr. Rajendran sir, and the one-man army, dear and respected Palaniraman sir, for granting me the opportunity for sharing my maiden presentation in this privileged and august forum. So this is my disclaimer. The memes, pics, and templates used in this presentation are used only for entertainment purpose, for joyful learning, unlearning, and relearning, and for more retaining of information with related learning, but not to offend or hurt any living or dead persons and pathogens. So RNTCP had been rechristened as NTEP last year with a goal of zero death by tuberculosis and TB elimination. That is, no new case of TB is going to get detected by 2025. This huge leap of control from control to elimination was not achieved in some few months or years. It is a 60-year-long story where it was started as a national tuberculosis program in 1962, taken over by RNTCP by 1998, where the entire country was covered by RNTCP program in 2006. And here we are in 2020, aiming towards the elimination of Mycobacterium tuberculosis. But how are we going to accomplish this of control to elimination? So how are we going to bridge the gaps? So in pediatric tuberculosis, most of them are non-specific manifestation. Children are quasi-bacillary in nature, and extrapulmonary tuberculosis is more common in children. So among the benefiters of RNTCP, 6 to 7% are children. And also the contribution of pediatric tuberculosis in under 5 mortality is not well known. It can be either muscurading as a case of some or a severe acute malnutrition and pneumonia, or it can be hidden with so many under the others. So 10% of under 5 mortality are contributed by others. So TB may be hidden in the others. So how are we going to bridge the gaps, and how are we going to accomplish from control to elimination? So before going to the strategies, let us know who is our enemy and who are we fighting against. So as we are evolving from control to elimination, Mycobacterium tuberculosis also updates itself. So when we started speaking about control, MTB updates and it became a 2.0 version. So becoming resistant to INH and rifampicin, emerging as a multi-drug resistant tuberculosis. So when now we are speaking from control to elimination, Mycobacterium tuberculosis has updated itself to 3.0 version. So becoming resistant not only to isoniazid and rifampicin, but also to the second-line injectables and fluoroquinolones. Moreover, it has the company and a strong alliance with two dreadful enemies of humanities, that is HIV and severe acute malnutrition. So how are we going to tackle our enemies? He is also evolving along with us. And also remember, the bacteria updates itself, it survives, it strikes and kills. So what is the expectation? How are we going to tackle our enemy? We think it will be a high-tech, we are having so much of high-tech investigations and treatment, and it's just as simple as removing the red chip from the chitty. But in reality, it is not so. So the weapons for us are very limited. And they are a molecular testing to detect the tuberculosis earlier, and also to know whether the Mycobacterium tuberculosis is susceptible to the available drugs. And also we can go back to contact tracing and treat them. So these are all the weapons available. So they are very simple. We can use our weapons well. As we know, in history, most of the wars were won by intelligent strategies and planning, making the best use of the available resources. Let's see how are we going to accomplish. Once the goal is set, it's better we forget about the goals and focus on the system instead. So what does NTP says? So when we describe the case properly and accomplishing microbacterial diagnosis in every case with a proper reporting to the government and treating tuberculosis appropriately with the drugs and ensuring proper follow-up of all the children, so we can eliminate tuberculosis. It was not like that. So giving a primary complex drug for 6 months, everything will be eliminated. 6 மாசம் வந்து primary complex treatment கொடுத்தா TB eliminate ஆக போகுது. It is not an easy job like that. So here we are. So in pediatric TB, so most of the pediatric tuberculosis is underdiagnosed and underreported, but being overtreated. It is right time we balance the diagnosis, reporting and treatment. So who should be rational here in anti-tuberculosis treatment? It is not enough if only one person or the leader becomes rational. And every one of us, every pediatrician, every treating physician should stick on to the rational tuberculosis treatment. Because remember, we are not fighting the joker, but we are fighting against the superstar with the foreign alliance. So where should I be rational? Either in case finding or diagnosis of tuberculosis or in treatment of tuberculosis. We should be rational in all of the above situations. So let us go to a case. There is a child A who is 4-year-old complaining of cough for the past 2 months, mostly a dry cough, more for the past 1 week, and he's also having a low-grade fever for the same duration. Mother is complaining that the child is not growing well, he's a very picky eater, not having so much of appetite, and also father has a chronic cough who had been given several courses of antibiotics sans relief. An investigation done were skin test for tuberculosis read 9 millimeter, ESR was 38 millimeter per hour. So shall we go to the X-ray? So wait, before investigating and analyzing TST and X-ray, have we defined the symptoms properly? The fever should be persistent. Presumptive tuberculosis, certain criteria should be satisfied. The fever should be persistent without a known cause for 2 weeks with or without an unremitting cough for more than or equal to 2 weeks. So we have these 3 types of cough. So mostly in acute cough, which increases in intensity by the end of the first week and by the starting of the second week, sometimes it may even take 4 weeks to settle down, and mostly it will be a viral induced cough. And also recurrent and acute cough, you can very well see that there are 2 peaks and in between there is a symptom-free interval. So what is this persistent non-remitting cough? We can see it is stepping up in intensity as the week progresses, and it is bothering the child much. Along with weight loss of 5% in 3 months, or no weight gain in 3 months, or poor weight gain despite nutritional rehabilitation in children with SAM. So it can be a presumptive tuberculosis. And contact with a patient with pulmonary tuberculosis in the past 2 years. If the child is symptomatic, even any form of tuberculosis, pulmonary or extrapulmonary, is significant. So again, coming to the case 1, we have not defined the fever and cough properly in the previous slides. On further questioning, the fever was recurrent but not persistent, and cough is more nocturnal and dry, and there is a relief with a bronchodilator. And proper documentation of the weight is essential. Here it is mainly the mother who is mentioning that the child is fussy eating, and proper percentage of weight loss is not mentioned. I used to tell, even if we walk from Kanyakumari to Kashmir, you cannot find even a single mother who is saying that the child is eating well. Even if the child eats 6 ghee roast, the mother will be saying, and next, contact questioning is very important. Not everyone who is coughing is having a tuberculosis. Here, father may be thought of as a contact, but actually father is a chronic smoker and his cough was due to wheezing or COPD. So the case 1, it was not a tuberculosis case, but a non-tuberculous cough, most probably cough dominant asthma. So the first step towards a rationality in anti-tuberculous therapy is case definition. We should properly define the case and describe the case. So we should be stringent in including them into the criteria for tuberculosis. We should not be hitting hard at the wrong person. We should localize the correct person and hit hard. And as with the presumptive pulmonary tuberculosis, there are certain presumptive extrapulmonary tuberculosis features also, which are organ-specific symptoms. And TB can involve any organ except the hair and the nail. So it may be pertaining to the particular organ. For example, maybe a swelling of the lymph nodes, which is lasting for more than 2 weeks, increasing in size, or it may be a joint tuberculosis, bone and joint tuberculosis with pain, swelling of joints, nocturnal pain, awaking the child from the sleep, and also difficulty in walking, or it may be in the meninges, presenting itself as neck stiffness or altered sensorium, etc., with or without the constitutional symptoms. So take home message 1, the proper characterization of symptoms is a very important starting point. So now with this, we go to our case 2. So he is a 6-year-old male child who presents with persistent fever for 45 days, occurring daily along with the cough. So yeah, he fits into our definition. He weighed 18.5 kilos before 6 months, and now he weighs 16.5 kilos. There is a definite significant weight loss. And his mother gives a history of a neighborhood grandpa who spends all the time sitting in the front pile of his home, spitting all the time. What is the next test you would want to do? Sputum smear examination, or a CB-nat of sputum, smear or CB-nat of gastric lavage, chest X-ray, or TST. So before proceeding to answer, we have to understand a difference in the disease and the diagnosis among the adult and the children. There is a divisional split. In a case of adult who has a very high load of bacteria and who are more infectious, they used to have a positive bacteriology than the children. So most of them, the first test we would do will be the sputum smear examination for AFB or a sputum culture or sputum CB-nat. Whereas in a case of children who are quasi-bacillary, and also here the children won't spit out. So we have to go for some invasive procedures like induced sputum or a gastric lavage, which is devastating not only for the children and the family, but also for the treating doctors like us. So children are not miniature adults. So before going into the proper collection of the sample to prove the microbiological diagnosis of Mycobacterium tuberculosis, we should make sure that there are some X-ray changes and also there is some evidence of infection. So the answer here would be the next investigation we should do in a case of a presumptive pulmonary tuberculosis in children will be chest X-ray and skin test for tuberculosis. So what is the algorithm for interpretation of chest X-ray? Take care of the prim, see whether it is a normal or abnormal. Think whether we have ruled out TB mimics, like it may be a thymus shadow or it may be a hair plate in a case of a girl child. If abnormal, there are 2 options. Is it highly suggestive of tuberculosis or it is a non-TB specific? So what are the highly suggestive Findings in a case of X-ray, which are suggestive of tuberculosis, the presence of the paratracheal node or a hilar node, and also presence of the Gorn's complex where there is some parenchymal changes along with the draining lymph node. And you can see the miliary deposits here, or it may be a cavitatory lesion. So Gorn's complex or a fibrocavitary lesion or miliary, these three are the very specific for tuberculosis, or it may be non-specific like some parenchymal changes and persistent pneumonia. So how are we going to tackle this? And skin test for tuberculosis, what is the strength and type of the PPD you would use for the Manto? So the answer here is 2 tuberculin unit of 40-23 twin 80. So the rationalism starts from the case finding, proceeding to the screening investigations for tuberculosis. We should use the proper strength. We should apply it in a proper technique. We should interpret it properly because it should not be reported as a positive or a negative, but it should be reported as this much millimeter, whether it is 8 millimeter, 9 millimeter, or 15 millimeter like that, and document it. And a word about IGRA. So there we use the tuberculin test, we use the whole of the tuberculin. Here we are using the specific antigens for Mycobacterium tuberculosis like ESAT6 or CFP. This is unaffected by BCG status and NTM unlike the previous one. It can be accomplished in a single visit, but there are some pitfalls here because it is an expensive, need to be processed within 6 hours. In high burden countries like ours, the role is not well established, and also the role in younger children and immunocompromised children also not well established. So, but in future, we may have some recommendations about IGRA. So the next test will be CTB or Copenhagen test for tuberculosis. It is the same as that of this tuberculin skin test. The technique is very much same, and the antigens used are ESAT6 and CFP10. It is easy to use and point of care. It is unaffected by the BCG status and also by the age and the immune status, which is contradictory, which is in opposition to the IGRA. So whenever the reading is more than or equal to 5 millimeter, it is read as positive CTB test. So take home 2. The first set of investigations we should do in a case of presumptive pediatric TB are chest X-ray and skin test for tuberculosis. And tuberculosis skin test is TST is no more tuberculin skin test. It is now TB skin test because CTB is also being used, and it is used only to detect the latent tuberculosis infection, but not for the diagnosis of tuberculosis. Positive TB skin test neither rules in nor rules out the tuberculosis disease. But why should we detect this latent tuberculosis infection? So we will see in the subsequent slides. So before leaping into this busy slide, let us look before we leap. So before starting to proceed to the algorithm, the first step is to look for any risk factors for drug resistance of tuberculosis, like contact with the MDR TB case, or if it is a recurrence, is it a second treatment, whether the child had already undergone any treatment, all these details to be looked at. In case none is seen, we have to proceed with the algorithm for pediatric pulmonary tuberculosis with no risk factors for drug resistance. So this presumptive tuberculosis who are satisfying the symptoms, and with the screening investigations of chest X-ray and the skin test for tuberculosis, we can have either of the 4 results. The chest X-ray may be highly suggestive with the specific findings of tuberculosis. In that case, we attempt to prove the disease microbiologically. So either it can be done on the expectorated sputum or gastric lavage or induced sputum and subjected to WHO approved rapid diagnostic test. So these 3 results are possible. It may be positive. When the rapid diagnostic test, that is CBNAT, is positive, yeah, we have proved it as a case of microbiologically confirmed tuberculosis. But if it is negative, but tuberculin skin test is positive, we look for any other alternative diagnosis. If there is none, we can put it as a case of clinically diagnosed tuberculosis. And in one situation where the 2, that is RDT and skin test, both are negative, it's better to refer to the expert and let him or her handle the case. When there are non-specific shadows in the chest X-ray, first we need to give some course of antibiotics. After the course of antibiotics, still there are persistent shadows and symptoms, then we again attempt the microbiological diagnosis like before. So then we have 2 results. One, if the rapid diagnostic test is positive, then we confirm that it's a case of microbiologically confirmed tuberculosis case. If negative, that means there are non-specific shadows, child not responding to antibiotics, and rapid diagnostic test is negative. It may be another cause of persistent pneumonia and refer to the expert for further workup. So third possibility will be both chest X-ray is normal and tuberculin skin test is positive. In case it may be a extrapulmonary tuberculosis, again we need to refer to the expert. If both are chest X-ray is normal and TST is negative, we need to look for the alternate cause. So what is the antibiotic we have to give for the non-specific shadows? It's nothing but our amoxicillin. We should not be giving any higher antibiotics like amikacin, ceftriaxone. Why? That also we shall see in the subsequent slides. So the antibiotic of choice for the non-specific shadows to treat is amoxicillin. So now we are going into the WHO approved rapid diagnostic test. What is the motto behind this rapid diagnostic test? This is CBNAT, TrueNAT, and CBNAT Ultra. All these rapid diagnostic tests not only help in diagnosing Mycobacterium tuberculosis, but also tells us whether that Mycobacterium tuberculosis is sensitive to rifampicin or not, which is the most important weapon in our war. And comparing these with the conventional and the gold standard diagnostic test, CBNAT can detect even the load of bacilli is 131 per ml, CBNAT can detect the Mycobacterium tuberculosis, whereas for sputum it's need 10,000 bacilli per ml. Mycobacterium MJIT can detect even 10 mycobacterium presenting in 1 ml. TrueNAT can detect 150 per ml, and CBNAT Ultra is more sensitive, it can detect even 16 bacilli presenting in 1 ml. So what is the advantage of these rapid diagnostic tests? As the name implies, the results are given within 2 hours. Though it is later than 1 hour, here we have ruled out 2 things. It is more sensitive, and I also have ruled out the reader bias. Whereas the gold standard Mycobacterium JIT, here the time taken will be 9 to 13 days, 9 for pulmonary tuberculosis, 13 for extrapulmonary tuberculosis in case the load is high. If suppose the load is very low, as in a case of samples like pleural fluid or ascitic fluid, it can take even 4 or 5 weeks. So this Mycobacterium JIT culture, liquid culture costs only 1,000 rupees. So what about WRDT? So we have to get the specimen in suspected children. So divide it into 2 aliquots. 1 aliquot is submitted for WRDT. So even 1 sample is required if you are doing a rapid diagnostic test. If the first aliquot is positive, then we confirm that it is a case of microbiologically confirmed tuberculosis. What to do with the second aliquot then? So if the patient is affordable, the conditions are feasible, then please send the second aliquot to the MJIT culture, and also we can have the LPA sample. If the growth tuberculosis, then we can subject into LPA. The first aliquot is negative, it is a must that we have to do the liquid culture in the second aliquot. So what is the order of preference? First choice will be CBNAT or molecular drug sensitivity testing using line probe assay if the smear is positive. Remember, line probe assay is not a diagnostic test, but it only tells you the drug susceptibility or the resistance. If the smear becomes positive, we can subject that smear to LPA, or if the culture grows Mycobacterium tuberculosis, then that sample can be subjected to LPA. So the second choice will be liquid culture with LPA DST, and third choice will be liquid culture with a phenotypic drug susceptibility testing. So CBNAT is preferred in children because it has a high sensitivity. Even paucibacillary children can be diagnosed microbiologically with the help of CBNAT. Can be done both in respiratory and non-respiratory specimens. It should be transported in the Falcon tubes with a minimum sample of 5 ml. It can be done even in the lymph node biopsy or the FNAC, and no preservative should be added to the specimen in a case of tissue samples. This is TrueNAT, and it is done in 2 steps. The first step detects the Mycobacterium tuberculosis. In a case of CBNAT, it is a 1-step process. It detects Mycobacterium tuberculosis. At the same time, it tells us whether it is a rifampicin sensitive or a resistant sample. Here, the first step, it detects the Mycobacterium tuberculosis. Once it is detected, then second step, it is then subjected to further analysis whether it is a rifampicin sensitive or resistant. So what actually we want? We want a test or a test. It should be simple to perform. It should be available everywhere. It should be non-invasive and highly sensitive and specific. Result should be quick and very, very cheap, no matter if it is free. But what actually we get? So you may question me. So you have told about CBNAT, you have told about TrueNAT. It is available in every district headquarters hospitals, and MGIT is available in 4 centers in Tamil Nadu. So what is the problem in getting it done and microbiologically proving that tuberculosis? But the crucial step in microbiological diagnosis is not in running the test, but in obtaining the sample, the proper sample. So do you expect a 3-year-old or a 4-year-old child to properly cooperate with you to collect samples by induced sputum after a salbutamol trial and after some 3% hypertonic saline and chest percussion, whether aspirating, or is he going to cooperate with us for fasting and introducing a tube into him on by 12 o'clock and keeping it there and again drawing the sample by 5 o'clock? No, it is next to impossible. And also in a case of extrapulmonary, we have to go for a CSF analysis, lymph node aspirate, tissue biopsy, everything is invasive. And bronchoalveolar lavage is available only in some apex centers. So the main problem we face is sampling. And also we can get some supporting investigations with the histopathology of the tissue specimens or with the imaging, ultrasound of the local part, CT, MRI contrast, particularly in meningeal tuberculosis, and in abdominal tuberculosis, contrast enhanced CT and barium. So we can use both. We can use imaging guided tissue sampling. So what should we do for a maximum yield? We have to commit ourselves. We should do it personally, or any senior resident should do. We should not ask a staff nurse, or if we ask a staff nurse to take the sample, we should educate her the importance of doing it properly. So collecting the proper samples and collecting it in adequate amounts properly, sealing it properly, storing it and transferring it. If not, let us commit ourselves, let us do it ourselves. We should go to any lengths to prove it microbiologically. Udayavan parka vittal oru mulam kattai அப்படினு சொல்வாங்க. So don't pass on the job to others. So take home 4, try the most maximum to attain a microbiological diagnosis. And drug sensitivity testing is done for all cases of tuberculosis with a WHO approved rapid diagnostic test. And one more, all diagnosed tuberculosis case must be offered HIV testing. So we coming back to the case 2. So what do we want to do next? So we went ahead with chest X-ray and TST. It is highly specific and suggestive of tuberculosis, and skin test for tuberculosis read 50 millimeter. So what next? So we proceeded with the microbiological proof. CB0 confirmed Mycobacterium tuberculosis, and it was sensitive to rifampicin. And we did HIV, it was negative. So now, which category treatment shall we start? Previously, there were so many categories, 3, then it became 2. Now there is only 1 category. Whether it is a new or a previously treated presumptive drug sensitive tuberculosis. This new case may be microbiologically confirmed or a clinically diagnosed pulmonary or extrapulmonary. So our case falls into this criteria, new microbiologically confirmed pulmonary tuberculosis. How are we going to treat him? With 2 HRZT and 4 HRE. So ethambutol is being added and continued in the continuation phase also, usually for the duration of 6 months. So in case of bone and joint tuberculosis, the phase and the meningeal tuberculosis, the continuation phase may be extended for even 8 to 10 months. And also the dose has also been altered. In the case of isoniazid, this is only the average dose. The range will be plus or minus 5. So isoniazid, the dose has been hiked up to 10 milligram per kilogram per day, rifampicin 15, ethambutol 20, and pyrazinamide 35. So have a look at the ceiling dose. So in the case of isoniazid, the ceiling dose or the maximum dose we can give is only 300 milligram. Even if the child weighs 35 kilos, if it is more than, even if the child weighs more than 30 kilos, we should stick on to the maximum ceiling dose of 300 milligram. So it is very easy to remember this weight bands. Actually, in government hospitals, these weight bands are available for the fixed drug combination doses. So for the first 4 rows, it is a multiple of 4. 4, 8, 12, and 16. From the 5th row, it becomes multiple of 5. So up to 4, it comes in the ascending order, and after 4, it starts descending. So we gave 4 to 7, 1 tablet of a pediatric fixed dose combination and 1 ethambutol tablet. So it is available separately because this is dispersible, this is not dispersible. Should I add any other drug to the above regimen? That is 2 HRZT plus 4 HR we have started. Should I add any other drug to the above regimen? The answer is yes. What is that drug? It is pyridoxine at a dose of 10 milligram per day till the duration INH is being given. So why? Because we have hiked up the INH dose, and from alternative therapy in the case of DOTS, we have moved on to daily dose of tuberculosis. So now ATT is given daily and the doses being hiked up. There are more chances that children may go in for a peripheral neuropathy, which is very difficult to recognize, and once happens, it is irreversible. So we have to go for a pyridoxine supplementation 10 milligram per day. Should I add steroids here? No. The indication for steroids is MAPM. MAPM in Tibetan language means undefeatable, and in the language of the eastern states of India, it means a good, nice abort to settle down. So there are certain aborts where the tuberculosis bacteria has settled down, can cause numerous inflammatory reactions. So there we have to address the problem with the steroids. So remember as MAPM, meningitis, Addison's disease, pericarditis, uveitis, and miliary tuberculosis with hypoxemia. So now Take home, in a case of a rational antituberculous therapies, category 2 has been withdrawn as we are shifting to the universal drug sensitivity testing. And now the drugs are given daily and the doses have been hiked, and ethambutol and continuation phase is added, and pyridoxine supplementation to everyone who is taking INH as a part of their therapy. Now the child has been started on treatment with 2 HRST and 4 HRA along with pyridoxine. What next? So we have to ensure a close clinical and laboratory follow-up in children also. So this is a new addition in a case of RNTCP. Clinical and laboratory follow-up with the children every month, and we have to assess whether the child has improved or partially improved or if there is no improvement. So how to follow up clinically? There are 5 S. We can remember it is a mnemonic 5 S. So the 5 S are very improvement in symptoms and signs. Are there any side effects of the medications? And have we addressed the treatment of the sister conditions? And is the patient sticking on to the treatment? And laboratory follow-up, microbiological, we should not repeat the CBNAT as a follow-up test because CBNAT can even detect the dead bacilli and it is not useful as a follow-up test. We can do a sputum smear examination if needed. And MGIT culture, it can be done when the child is not responding to the therapy for 4 weeks. And there is no need to do a baseline LFT. Once the child shows any symptoms of hepatotoxicity, then we can go for an LFT. Chest X-ray after completion of the treatment to know the improvement, other imaging accordingly. So now we have started him. On close follow-up, the child is not showing any clinical improvement and also there is no weight gain. So what could be the cause? It can be anything. So in follow-up, we have to do a 3D audit. The 3D audit is whether we have given the drugs correctly, whether the dosage is correct and appropriate, and have we diagnosed correctly? Is the child adhering to the treatment or is there any associated conditions? Can it be an upgrading reaction or is it the dreadful drug resistance? Is there any comorbid infection or is the child throwing up that is not retaining the drug but keeps on vomiting? It can be anything. So after quickly rule out all these things, if there is nothing found and drug resistance is suspected, we have to do smear in sputum or gastric lavage and induced sputum. Here we should be very, very aggressive in obtaining the samples for this because it had not responded and it can be a drug resistant tuberculosis, and send the samples for liquid culture and also first line LPA to rule out the isoniazid acid resistance. So what is the mistake I did in this case too? I did not look before I left. I did not investigate that spitting neighborhood grandpa. And so I am paying the fees. So drug resistance is rising, and they report incidence of 2.6% incident drug resistant tuberculosis is reported among the newly diagnosed cases, and in previously treated it is 12%. This Mycobacterium tuberculosis can turn resistant to all the available first line drugs or the second line drugs. In case of non-response, previously they were extending the IP regimen, intensive phase regimen. Now no need to extend IP regimen, but instead investigate aggressively and rule out a drug resistance tuberculosis. So I'm not going into the detail of drug resistant tuberculosis because it's beyond the scope of the topic, but there is some regrouping for the drug resistant tuberculosis of drugs. There are 3 groups. We can see here amikacin has climbed down the ladder and has been pulled down, whereas linezolid and levofloxacin has gained importance. So we saw there that non-specific shadows of the lung has to be treated with amoxicillin, but not with the other drugs. We had been treating all those things with ceftriaxone and amikacin, and soon the bacteria became resistant to amikacin. It can turn resistant to any second line drugs. And now, very careful word about linezolid. Are we misusing linezolid? If any soft tissue infection or a skin infection doesn't subside, give linezolid. If it is a otitis media, give linezolid. If a lymph node tuberculosis, give linezolid. This is what we are practicing. Some of us, not all of us. But it is high time we stop doing these things because linezolid is a very, very valuable drug against the Mycobacterium tuberculosis. It is oral, having 100% bioavailability. So you have to be careful in rationalizing the antibiotics in our office practice also. The 2 important new drugs are bedaquiline and delamanid. Delamanid has been approved for treating children more than 6 years of age, whereas bedaquiline we can use more than 18 years of age as per WHO. But under certain circumstances, it can be used in 12 to 18 years of age. So new grouping of drugs is used in the longer MDR-TB regimen, and delamanid approved for treating MDR and XDR-TB in children more than 6 years. So we have rationalized the case identification and also the screening investigations and diagnostic investigation and also the treatment. So now we are coming to the preventive part. So indications of preventive therapy with INH 10 milligram per kilogram per day for 6 months along with pyridoxine for 10 milligram per day. So the previous conditions are retained. Neonates born to mothers with either pulmonary or extrapulmonary active tuberculosis and neonates exposed to TB postnatally and asymptomatic contacts less than 5 years of age. They must be treated because the chances of progression from infection to the disease is very, very high in this age group. In infants, it is 50%, whereas in 1 to 5 years of age, it is 25%. Whereas for others in the lifetime, it is only 10%. And the other chunk of group who should be investigated aggressively is this CL-HIV, that is children living with HIV with a known exposure or a positive skin test for tuberculosis, and children going to be getting a long-term immunosuppressive drugs. Of course, all these things, LTBI treatment with the preventive therapy should be started only after ruling out active tuberculosis. The new addition in this group is asymptomatic household contacts of 5 to 15 years of age with or without evidence of LTBI. So this has been added. We know our weapons are scarce. So we cannot manage a drug-resistant tuberculosis with available weapon. It will be a long duration treatment with certain drugs which are having so much of side effects. So can we achieve the reduction in the progression to infection to disease by treating this 5 to 15 years of age is the rationale behind this. So LTBI detected with appropriate testing in asymptomatic contacts more than 5-year-old should be given preventive therapy. So for this only the skin test for tuberculosis are being used as a screening test. And last thing, there is a Nikshay Poshan Yojana. So this is a government program and it provides incentives to the patients and also the providers. Remember, not notifying TB is an offense. If you are treating a patient with an anti-tuberculosis drug, we should immediately report it to the government authorities and also it should be entered in the Nikshay Poshan Yojana. So whenever we come across filling a form, we feel like Varthapadada Valibar Sangam Siva Karthikeyan. I can even better take care of the cattle instead of filling up the form. But I want you to have a look on this particular picture. It was sent to me by Dr. Sharad Balaji. So in Nikshay portal, they are offering so much of things, enrolling, testing, treatment details, whether they're adhering to the therapy, outcomes or notes. So here, there are some 9 patients and follow-up of drug-sensitive tuberculosis is being done in some of them. So the CBNAT has been proven, these people have been proved to have a microbiological evidence of tuberculosis. And here, if you see, in a case of a follow-up DSTB, CBNAT positivity, again, MTB was detected in the culture and also rifampicin resistance is also detected. So this is the rationale behind sending the second aliquot to liquid culture, even if the CBNAT is coming positive and it is sensitive to rifampicin, and also entering all the details here. So whoever is doing the investigation should enter all the details of the patients and in the follow-up section of the column. So here we see a CBNAT sensitive to rifampicin. Now it is rifampicin resistance. It can be a secondary resistance. And here again, follow-up of DSTB with the first line LPA. So they have told the MTB is detected resistant to both rifampicin and INH resistance. So this follow-up details can be accomplished from Nikshay Poshan Yojana. So do I have time for some case scenarios?
Another 3 more minutes, doctor.
Okay, sir, I'll go to this. So this was a child who was presented with a lymph node enlargement. So what is the rational treatment? We have antibiotics for 7 days, review after 2 weeks, and subject the child to FNAC. If it is not subsiding, go for either a CBNAT or a AFB or a histopathological. So we went ahead with that. And there was an exudative type of Cox lesion was noted in the FNAC specimen. So this is histopathologically proven and we are rational in starting anti-tuberculosis treatment here. But
Dr.
let us take a look at
is it
this,
audible?
sir. Yes, sir. Am I not audible, sir?
Yeah. You proceed. Yeah.
So this test was done on the 17th of the May, but before that, ultrasound of the local region was performed and which showed intraparotid lymphadenopathy with perinodal inflammation and nodal conglomeration suggestive of TB lymphadenitis. So our radiologist was able to pick up this TB lymphadenitis even before the HPE was available, before the HPE, we do HPE examination. So this is the usefulness of the utility ultrasound, where we can detect the caseation of the node with the help of ultrasound. And this was a child who presented to us with the inability to walk, but with a normal sensorium, no bladder bowel disturbances, and without fever. This was his stage. This was the thing which was on the admission. On examination, nothing was remarkably wrong except some sluggish reflexes, no sensory disturbances. But during the first week of stay with us, he progressed to have inability to use upper limbs also. So we provisionally diagnosed him as a case of a Guillain-Barré syndrome and started him on methylprednisolone. And later, in the second week, he developed an altered sensorium. Then neurologist suggested that it may be a case of Adam. So MRI was suggested, MRI was done at the time with the brain and spine screening, which was normal, and reassessment of the child was done. So this is how we have to proceed in a case of a suspected meningeal tuberculosis. When the clinical investigation is fitting into the suspicion of tuberculosis, then we have to go for a reassessment in the second or a third week. So we noticed the attitude of the left lower limb was different. That is, a little toe was touching the bed. So that then we examined him, that the deep tendon reflexes were found to be brisk. We suspected a focal neurological deficit, and staff nurse told, ma'am, while giving sponging, I felt he is febrile. So we again initiated the workup, did CBC, ESR was high in 3 digits, LP was traumatic, unfortunately, but biochemical sugar low and protein mildly elevated with a few lymphocytes, but CB NAT negative. So we noticed 3 things here. There is a fall in the GCS, and there is a focal neurological deficit and fall in sugar. Whenever we see these 3 things in the reassessment, we should have a high index of suspicion for tuberculosis and also low threshold for starting ATT. And he was started on ATT along with steroids and anti-edema measures. There was some improvement in the 3rd week, but he started worsening in the 4th week. We repeated the imaging, which showed hydrocephalus. This is the usual scenario in any case of tuberculosis. The first imaging may not show the hydrocephalus, but the repeat imaging may show the hydrocephalus. We proceeded with the external ventricular drainage, but the patient unfortunately did not recover from the ventilatory settings and he succumbed to the illness. What is the irony is, the fluid was collected when EVD was done and underwent CBNAT, and in that MTB was detected, which was sensitive to rifampicin. We don't know where we went wrong in this case.
1 more minute, please.
Yes, sir. Yes, sir. So this is the conclusion slide. In a case of a rational TB treatment, from history to high funda investigations and treatment, we should be rational with a case description, with microbiological diagnosis and reporting, categorizing as whether drug sensitive or drug resistance and suspecting it, treating, follow up, and preventing. Then we can be able to bloom the TB elimination. So this is the take home messages. So report any case you are seeing as a tuberculosis or treating as a tuberculosis. Chest X-ray and skin test for tuberculosis is the first investigation. Do maximum attempts to prove microbiological diagnosis. Universal drug sensitivity testing is the rule. Always do HIV testing in a case of tuberculosis case. The treatment is now daily drug with a hiked up doses, only 1 category along with the pyridoxine. There is new grouping for drug resistance tuberculosis. Delamanid has been approved for treatment more than 6 years, and INH therapy is offered as a preventive therapy for children even more than 5 years. So TB can present not only in 10 avadas, but it can have 100 different presentations, and it's a great mimicker and also an imposter. So we need to suspect it, define it, try maximum to prove it, and treat it, of course, rationally. So I thank the institute where I learned and the institute where I am still learning with fun. And I acknowledge all these people for helping me in the presentation. And these are my references. And thank you so much. So I want to conclude. Let us what is CC. Thank you so much for the opportunity, sir.
Thank you, Doctor, for the excellent presentation.
Dr. Kritika. I think
wonderful.
you have done
wonderful presentation. Really
Thank
nice.
you so much.
Really nice presentation. Covering the introduction part of the change of terminology from RNTCP to NTEP and how to proceed with the case, the various take-home messages. Wonderful. Excellent, phenomenal. Arumiyana presentation.
Thank you.
Doubts in
Thanks,
the
sir.
questions you will ask after this session. Okay.
Thank you, sir. Thank you so
Thank
much.
you. Thank you. Thank you. Rajendran sir, next.
Yeah, next I think Dr. Panniraman is match finisher like a Dhoni, no? He will come and finish the match. I think he's going to speak. Dr. Panniraman sir.
The youngsters have finished.
Yeah.
Dhoni on that, Dhoni.
Stalwarts are starting.
Sir, am I audible? Am I audible?
Yes.
Yeah.
Because here electricity is not there. So I am not using the video, only the slide part.
Sir, video வேண்டாம் சார், உங்களை தெரியாத ஆளே இருக்க முடியாது.
ஆமா, you are so bright.
slide தெரியுதுங்களா சார்? ஸ்லைட் தெரியுதா?
Very well sir.
பையனாவன் தெரியாத குழந்தையே கிடையாது.
அதான் சார்.
ஆமா, எப்படி மேட்ச் finish பண்ண வந்துட்டானல, சூப்பர்.
First of all, thank you very much for the office bearers of IAPTNSC, Dr. Sendil, my other secretary and treasurers. I'm not able to attention appear. Thank you very much for all for the opportunity. And this week we all know it's a Rational Antibiotic Awareness Week, and September 28th is mainly the Rational Antibiotic Day. To start with, outline of my talk will be the introduction, rational antibiotic therapy, case scenarios, and take-home message. We all know next to paracetamol, it is the most commonly used drug, and rational use of antibiotic is the need of the hour. Every other patient goes out of the clinic with antibiotic. Only lesser and lesser antibiotics are in the pipeline. Next. And what do you mean by rational antibiotic therapy? Rational na பயந்து ஓடுற வேண்டாம் எல்லாரும். Rational is nothing but it's a word derived from rationalis, from a Latin word. Its meaning is reasonable or logical or sensible. So use antibiotics sensibly or with good reasons. Simply சொல்லப்போனா, use it when required, don't use it when not required. So this is the final thing. Rational antibiotic therapy, it is not a very rocket science term. It is a simple term. Use it when it is required. Don't use it when it is not required. So when you use it rationally, when you follow the rational antibiotic therapy, this precious gem will be preserved for the next generations to come. So that is the advantage of using, and we have to preserve this gem. So that is the main thing behind this lecture. If we are going to follow the irrational antibiotic therapy, we are going to continue the same thing. What will happen? That is the end of the antibiotics. Tirumurugan, disturbance. Hello, Tirumurugan. Hello.
Mute பண்ணியாச்சு.
All right. So if you are irrationally using the antibiotics, what will happen? It is finally the obituary is going to be happen. Like we are going to be 100 to 120 years back. We are going to pre-antibiotic era. Even a simple tonsillitis can kill a child. So this should not happen to our grandchildren. See to that we should follow a rational antibiotic therapy. All the speakers have really clearly told about the basic steps in choosing the antibiotic, about the rational steps. About neonatologist told 10 steps. About ICU specialist told 8 steps. Just I am telling you 5 steps. First of all, we should know, am I dealing with the infection? If at all, am I dealing with a viral or a bacterial, parasitic, fungal, and whatnot? Then if it is an infection, bacterial infection, is it a community acquired bacterial infection or a nosocomial infection? And if bacterial, we should know whether I am dealing with a community acquired gram-positive pathogen or a gram-negative pathogen. And finally, what is the resistant pattern in the community going on? We should be aware of this thing. Epidemiology, we should know. From the nearby medical college, we should try to acquire the antibiogram. So these are the basic steps in choosing rational antibiotic therapy. In office practice, what you do is mostly an empirical rational antibiotic therapy, not a definitive antibiotic therapy. What do we mean by definitive antibiotic therapy? Culture sensitivity path, specific antibiotic use பண்றது definitive antibiotic therapy. In office practice, முக்காவாசி நம்ம தோராயமா யூஸ் பண்றது, but அதை தோராயமா யூஸ் பண்றதை ப்ராப்பரா யூஸ் பண்ணணும். We should choose properly with the evidence available, with the science available, we should use it. Next, going to the thing, and if antibiotic used to be used, consider the choice very carefully. என்ன பண்ணணும்? It has to be a narrow spectrum antibiotic and best antibiotic with less side effects and low cost. For example, staph infection, narrowest spectrum antibiotic na cloxacillin, that is the best antibiotic for clog. Like that, we should choose a narrow spectrum antibiotic. For example, acute streptococcal sore throat or penicillin is the narrow spectrum antibiotic. Like that, we should try to choose the narrow spectrum antibiotic with less side effect and low cost. So going to with the morbidity pattern, and for example, this is the morbidity pattern in basically in office practice. This is done by our study in our center long back. About one third of the 40% of the patients belong to the common cold, cough, and fever. Next comes the 50% fever, then diarrhea around 10%, skin comes around 10%. These four constitutes nearly more than 75 to 80% of our cases. And this is the area where antibiotics are commonly used as well as misused. Let us see how to use it rationally in these areas. Common conditions we see daily are fever, cold, cough, diarrhea are mostly viral. 90% தெரியும் நமக்கு வந்து mostly viral. Only thing is we don't have the guts to not to use antibiotics because of the many factors like peer competition and particular patient pressure, and many factors play a role in our irrational antibiotic use. We should try to prevent it. Let us go through the common scenario. I'm not going to boring you. I'll try to make it the clinical exercise very simple as possible. I'll try to finish it as it is possible. Coming to scenario 1. This is a 1-year-old child with a fever for the past 48 hours with purulent nasal discharge. You can see the yellowish purulent discharge in this 1.5-1-year-old child. So my question is whether I should start antibiotic for this or not. How do I know this is a simple cold or a complicated cold? How do I know? What does the evidence say? Am I dealing with this a simple common cold or a complicated cold? So let us see. So this is the graph, and it is published in July 2013. It is a natural history of a simple common cold. In a common cold, what happens? First 48 hours, the fever will come. Then what happens? The cold will increase it will become mucopurulent discharge by day 4 to day 5. Then the cough will come, and finally by 12 days, the cough will settle. So cold and cough will settle over a period of 10 days. So this is the thing, natural history of anything. Anything away from this natural history, for example, the cold and cough is going more than 10 days, or if the mucopurulent discharge is coming in the first 2 days, or when everything is settling again, coming again, that it is a recurrent pattern, we should suspect you are dealing with a case of complicated cold. What happened in this case? You can see this mucopurulent discharge should appear only on day 3, day 4. This has appeared on day 1 or day 2 itself. That indicates that we are mostly dealing with a case of acute rhinosinusitis or acute bacterial rhinosinusitis. This is a condition has to be treated aggressively with a good antibiotics. So this is the first thing. So in case of common cold, so majority of time our tongue has to act rather than the antibiotic has to be acting. So finally, what is the message? Whenever the running nose is there, when a common cold becomes complicated cold in the form of sinusitis or otitis media, we should start antibiotic. So before that, so you can see the common clinical presentation of rhinosinusitis. I have told the common cold and cough pressing more than 10 days. This is the commonest presentation. Sometimes, as in this case, this is a severe presentation. Sometimes where happens double sickening. For example, initially the child will be getting better, again the child will become worse. This is known as double sickening. So that type of also can happen. Before going to think, we should know how common these conditions are there in practice. 100 cold patamna, how common the complication occurs. So the risk of sinusitis is only 5 to 10%. 100 URI if you deal, only 5 to 10% will go for sinusitis. Whereas otitis media is little more, and the age group is very less. Why? Because up to 1.5 years, otitis media is very common. Why? Because eustachian tube is very short and narrow, short and wide. So organism from the nasopharynx enter easily into the ear, middle ear, and produce infection before the sinus gets infected. So that is the reason up to 2 years, ASOM is more common. Afterwards, the sinusitis is more common. We should know at what age, what problem will strike. This is a very, very important statistics we should know. And how common is this complicated cold? So hardly 5 to 20% is the complication. So 80% of the children doesn't need anything except for the reassurance. This is the first message with respect to thing. So identifying the bacterial infection is the problem. For example, identifying viral infection is easy, difficult to treat. Whereas identifying bacterial infection is difficult to identify, but easy to treat. So once you identify it is a sinusitis, it is very easy to treat. Next step, I have told what are the organisms. I have told here the villains are pneumococcus, H. influenza, moraxella. These are the common villains. So what is the antibiotic of choice? In a community acquired, there are no resistance at all. The simple amoxicillin in India is more than enough, 40 milligram per kg. Very rarely in a severe condition like the previous child which I have shown, in any child less than 2 years, you can go for directly amoxiclav. So in that condition, we can go for amoxiclav. Or if the amoxicillin is not responding, you can go for amoxiclav. So this is the antibiotic of choice. How long we have to give? We have to give for a period of 10 to 14 days. And as the previous speaker nicely told, we have to know our thing rationality doesn't end with the starting the treatment. We should end the treatment. We should follow up the child, whether the child has completely gone, settled, everything is settled or not. Otherwise, we have to see whether our antibiotic is not working, whether the patient is not taking, what is the problem, you should go around. So this is the next complicated cold is otitis media. This is very common. Any URI child coming with incessant cry, without otoscope, you can't diagnose. The very important message I want the August audience is go for a simple otoscope, that is Raster LED 3.7 otoscope, which is available very nicely in the internet. Go for this bright LED 3.7, that is just 12,000 only. Go for this otoscope. It is a very nice. So this is a very, very important thing. Without otoscope, nowadays you should not practice, because every day is not passed without incessant cry, as well as in a fever without causes. Sometimes the focus will be sitting in the ears. We have seen plenty of times. You will examine everything, you will evaluate everything, and finally there will be focus will be there in the thing. Okay. So what about the organism and treatment? The organisms are the same as sinusitis. Treatment is the same as sinusitis. Amoxicillin is the first choice. Amoxiclav is the second choice. Sometimes if the child has been put on amoxicillin, there are 2 options more. Or if the child is having otitis conjunctivitis syndrome, or if the child is not responding to amoxicillin, you should go for amoxiclav in the first instance. Okay. Next scenario number 2, 6-year-old school-going child. That is a school-going child, 2-day fever, throat pain. Now, $1 million question is it viral or bacterial? How to decide? So whether we want to know whether all the sore throat are bacterial or the sore throat are viral, it is not so. So 1/3 of the sore throat, the evidence has told, are of group A streptococcal pharyngitis. This is the evidence. IDSA guideline clearly told 1/3 of the thing are bacterial origin, remaining 2/3 are mostly viral. So we should try to pick up this 1/3. How to pick up this? And even if you untreat the bacterial streptococcal pharyngitis, only 3% will go for rheumatic fever. So no need to worry unnecessarily whether all this throat will become rheumatic fever. Only 1/3 of the bacterial sore throat will lead to rheumatic fever. These are all the evidences which will give the confidence and boldness to practice rationally. So in this child, what happened? The child is looking ill, purulent discharge, exudate with inflammation, bilateral cervical nodes were enlarged. So diagnosis acute tonsillar pharyngitis. How confidently we can diagnose tonsillar pharyngitis clinically? Is it a clinical diagnosis or is it a microbiological diagnosis? To be precise, it is a microbiological diagnosis, should be done by antigen detection test or by culture. But as a developing country, even in England, the conservative model is go by the modified Centaur score. In a school-going child with a fever, in the throat pain, tonsillar exudate, acute cervical adenopathy, absence of cough, if the score is more than 4 or 5, you can straight away start the antibiotic. This is the one, even the real test nice guidelines also says you can go and start directly the antibiotics. The rapid antigen test is very good, particularly in the cities, and particularly when you are not able to decide whether I am dealing with a viral or bacterial, you can go for rapid antigen test, and it is very much available, around 150-200 rupees is available. So what is the organism? Group A beta hemolytic streptococcus. What is the drug of choice? Still amoxicillin. Amoxicillin 40 milligram per kg is palatable, and duration, see to that you are not stopping by 9th day also. You should go up to 10th day. They are told even if you stop by 9th day also, there is a chance of rheumatic fever. Don't stop by up to 9th day. Next comes, this is now because of the improper immunization, particularly the booster dose in the school going age. Now we are coming across with this problem nowadays. The fever 4 days, dysphagia, there is a membranous throat, membranous tonsillitis, suspect diphtheria, refer immediately for a higher institution. So it has to be given crystalline penicillin antidiphtheritic serum. This has become very common nowadays in our area also. Now the third thing, now plenty of times small children less than 3 years, they come with a throat that is a drooling of saliva along with a high fever. The parents say the child has been suffering from sore throat, so start some antibiotic. This is the thing. So whenever any small child come with a throat ulcers, it indicates that you are dealing with a mostly a viral sore throat, or viral sore throat are always with ulcers. It indicates no need of antibiotics in a less than 3 years age group. Think twice before starting antibiotics in less than 3 years of age group. Now come to the scenario number 3. 4-year-old boy coughs a lot, no fever. What is the best antibiotic for the cough? This is the million-dollar question. So we know cough is an airway disease, and we also know fever and cough is not equivalent to pneumonia. Okay. So whenever there is a airway disease, we know the villains. Every area there are villains. For a airway, the villains are mostly the notorious thing are viruses. Sometimes the atypical bacteria like pertussis, chlamydia, and mycoplasma can be the villains. The typical villains, pneumo, H influenza, and moraxella will not attack the airways. So this we should know, particularly for treatment aspect. So this is the child, you can see. Okay, this is a child with pertussis. This is a child with chlamydia. Okay, the video is not acting. Excuse me. Just a minute, because this video is because of them. So that was a pertussis video as well as a chlamydia video. So which I was not able to think now. So because of the technical issues. So what are the antibiotic used whenever the situation like pertussoid cough is there, use antibiotic. Staccato cough in a small infant, suspect chlamydia and start, and wet cough more than 4 weeks, you suspect PBB, which is nowadays it is coming up. And that day anybody would have heard about Annie Chang's lecture, you know about PBB, and we have to start antibiotics. So what are the drug of choice for all this? Azithromycin is the drug of choice mainly for the pertussis and chlamydia, whereas in the case of wet cough, the drug of choice is co-amoxiclav. Again mentioned, it's a co-amoxiclav, not amoxicillin. It is mainly for 2 to 3 to 4 weeks. That is the antibiotic of choice. So cough is over. Now coming to the common, very common condition. 1/3 of the respiratory conditions are wheeze. It's a playful wheeze. A child, when you see whatever the things, you should think it of. Whether the first episode of wheeze may be bronchiolitis, recurrent attacks may be Valry, and if it is an older child, may be an asthma, and rarely you may be any child with wheeze can be a pneumonia. Rarely a child can be pneumonia. So in this case, it's a bronchiolitis. How do you treat? Only with the supportive management. There is when to start antibiotics. There is no role of antibiotics in a happy wheezer. There is no role of antibiotics. So if at all, when to start antibiotic in a wheezy child? So bacterial infection is developed only in 1% and subsequent pneumonia in only 0.9%. This is the evidence-based statement. So very rarely in a child with a wheezing, the child becomes sick, you should suspect secondary bacterial infection and start antibiotics. Otherwise, 99% of the times, no need to start antibiotic. Coming to the scenario number 5, it's an averagely nourished child, 2-year-old with fever and fast breathing. This is the main thing. Cough is not a main thing. Fever, fast breathing, and bronchial breath sounds and craps, you diagnose the case as pneumonia. What is the organisms? Which I already told, the common organisms. Drug of choice, amoxicillin. IAP recommends 40 milligram per kg. WHO recommends 80 milligram per kg for a period of 5 to 7 days. Since pneumonia is a serious condition, I think we should not take chance. We should double the dose of amoxicillin as a 80 milligram per kg for OPD stake. So we get a very good, wonderful response for any case of pneumonia. No need to go for amoxiclav. Why? Because we come across mainly pneumococcal pneumonia, Hib pneumonia. Because of the vaccination, we don't come across Hib. So no point in adding clav. Staphylococcal pneumonia, we know we have the clues. So simple amoxicillin is more than enough for any case of pneumonia. So finally, coming to the gist of bacterial respiratory infection, it can be starting with the ENT, otitis media, sinusitis, and pharyngitis. Coming lower down, it can be pertussis and pneumonia. These are the only few conditions. Only few conditions we have to start antibiotic, and mostly amoxicillin is enough for all the conditions except pertussis or mycoplasma, where we need to use azithromycin. Coming to the next group of condition, coming to below the diaphragm condition is a high fever followed by frequent small sticky foul smelling stool with blood, with severe abdomen, pain abdomen preceding each stool. Febrile, normally what my antibiotic choice? The issues are what decides our choice in antibiotic choice in bacterial dysentery. The sickness of the child. The child is very sick and is throwing out, vomiting. You have to give a parenteral IV antibiotic. Otherwise, oral antibiotic will do. What about combination? All the Gil combinations are out. At least from tomorrow onwards, at least my humble request is don't use any combination of arnidazole or metronidazole or any Gil combination. Don't use, please. When does one decide to treat for amoebiasis, which is also very rare, and it can, if at all, it will occur in an older child, not less than 5 years. So these are the common issues when you are facing a dysentery. So what are the organisms? Shigellosis is to be taken as other, unless other prove it otherwise. Otherwise, enteroinvasive E. coli. Drug of choice is oral cefixime, 10 milligram per kg for a period of 5 days. Quinolones are not approved. Ceftriaxone in a sick baby. Even you can use 1 dose of ceftriaxone followed by cefixime. You can downgrade the antibiotic. That is also rational. Coming to scenario 7. So next group of condition, this is the most frustrating condition and the most abused condition of antibiotic, particularly the fever. In any fever, we are really struggling. Unless you have a clear-cut concepts when to use antibiotics, you will be struggling to use antibiotics in a case of fever. This is a 2-year-old child, fever of 3 days, no focus found, and child is also not sick. You do the CBC, shows neutrophilic leukocytosis, total count high, neutrophil high. So urine, you do immediately, small baby, you should not miss UTI. You do the urine is normal. Then what you do? Then you do the X-ray chest is also normal. Then what next? So when you don't find any etiology such a patient, when the baby is fine, this neutrophilic leukocytosis or along with the CRP is rise is not equal to ceftriaxone. We should not give. This is the message I want to give. When you don't know the evidence where from the bacteria is coming, where from the problem is coming, it's not from the top compartment. Meningitis is not there. Middle compartment pneumonia is not there. Lower compartment, that is UTI or sepsis, urosepsis is not there. And skin and soft tissue are fine. I should not blindly use the antibiotics in this scenario, because even some viral infections like adenovirus can produce neutrophilic leukocytosis. What happened in this case, the patient was asked to come the next day. So the next day fever settled. It was a simple viral infection. So don't use antibiotics based on neutrophilic leukocytosis or height of the fever. The temperature is 49, the child is struggling, whatever the pressure, you should have a clear-cut approach. So this is the clear-cut approach we should have. That is the baby sick? Now, step number 1, if the baby is sick, no doubt we are going to start antibiotic after sending investigation. Is there any focus? Is this a viral focus or a bacterial focus? For example, tonsillitis, lymphadenitis, cellulitis, we know it is a bacterial, we start antibiotics. If there are mumps, chickenpox, we know it is a viral focus, no need to start antibiotics. If no focus, what should be our approach? So this is the basic approach we should have whenever you come across a short duration fever. So first step, sick child or not, admit or evaluate and treat depending upon your situation. Well looking, focus is there or not, focus is present, viral markers, supportive management, bacterial markers, appropriate antibiotic. No focus, wait for 48 hours, wait for 1 to 3 days, do a urine first, next CBC. If there is leukocytosis, rule out UTI, occult UTI, rule out occult pneumonia. Don't worry about occult bacteremia. We are mainly worried about 3 occult bacteremia, occult UTI, and occult pneumonia. After this Hib immunization, occult bacteremia is not very common. So don't worry about occult bacteremia. And if the CBC shows leukopenia, it can be a simple viral infection. or if the platelets are showing a lower trend, we may be dealing with a dengue infection. This simple flow chart, everyone can take the screenshot. It will be very useful, but in the first 3 days of fever. Okay, if the fever goes for the 5th day, what I'm going to do? Day 5, the child is not showing any focus. Child is not sick looking. Again, here also, child is well looking. I'm not able to get any focus. I should strip the child, see from head to foot, any eschar is there or not on day 5. You should specifically look for eschar on day 5. And if there is no focus, what I'm going to do? Again, repeat the same test. Already, if you have done, repeat the CBC. If there, after ruling out UTI pneumonia, you should suspect any occult abscess anywhere in the body. For example, it may be sitting in the liver, it may be sitting in the kidney, or it may be sitting anywhere in the abdomen. So rule out occult abscess, or after ruling out all the infections, suspect Kawasaki. Don't bring SOJRA during the first 2 weeks of fever. Don't bring systemic onset juvenile rheumatoid arthritis. Don't bring it, except Kawasaki. Don't bring other conditions. If there is a leukopenia, we know definitely it may be a simple viral infection if the platelet is normal. If it is platelets are low and HB high, we know it's a dengue. If the platelets are low, it can be a typhus or typhoid from day 5 onwards. Next, what is the flow chart during the COVID flow season? Now, this is a very, very important slide. During this season, if any child presents with a school-going child or an older child fever for more than 48 to 72 hours, if the symptoms are more than one system, child is having abdominal pain, the child is having loose stool, child is having rash, be careful, and do a CBC along with the CRP, because doing only CBC can fool you. CBC can be normal, or CBC can be showing neutrophilia with thrombocytopenia. Sometimes CBC can be normal with only markedly raised CRP with more than 100 CRP. Immediately you should refer to an institution, because this is mainly you should suspect multi-inflammatory syndrome in appropriate clinical setting. This is the time. Now we are going through the COVID season. After COVID, active COVID season, we will, after 3 to 4 weeks, any child fever more than 3 days, multi-system involvement, do a CBC with CRP. Don't do only CBC this season along with the CRP. CBC can be normal with a markedly raised CP. Suspect MIC in appropriate clinic setting. This is the message to all in this season, COVID flow chart. Coming to the next common scenario, we all know entry fever. Any child with a school-going child, fever is going on, hepatosplenomegaly. We know we are dealing with the leukopenia, with eosinopenia. Leukopenia with eosinopenia is a very good indicator that we are dealing with the entry fever. What should be by choice of antibiotic after sending appropriate investigation? Start IV ceftriaxone if the child is sick. Start oral cefixime. The dose is 20 milligram per kg for a period of 14 days. Again, I remind you, it's 20 milligram per kg. Now, the ID specialists are recommending even up to 30 milligram per kg. Now, the dose of cefixime is increasing for entry fever. Please mind it. The alternative is azithromycin. Here also, the dose is 20 milligram per kg for 7 days. Always remember what is the ceiling dose. Cefixime, the ceiling dose for children is 300 milligram BD. Azithromycin also, you should know the ceiling dose is maximum 1 gram per day. That is. So what about the scenario number 9? Last 2 scenarios. Again, a child fever with 1 week. Now this is a very common scenario. Child is coming with a puffy face, generalized edema, hepatomegaly, leukopenia, thrombocytopenia. When you do the electrolytes, there will be hyponatremia. So whenever you come across a child, puffy child with more than fever of 1 week duration with hepatosplenomegaly, we all know that definitely we are dealing, mostly we have to strip the child, see for the eschar. So eschar can be in the hidden areas, in the scalp, even in the eyelids, the neck, or it can be in the back of the ears, or it can be the chest, or it can be in the particularly in the back, or in the thigh, or in the inguinal region. Anywhere it can be there. So the scrub is so rampant nowadays. Even a neonate with a fever of 3 days duration, 4 days duration, you are able to see the eschar even in the neonates. Coming with the scrub typhus nowadays become a very common thing. Don't ever forget, nowadays late onset sepsis is not the only diagnosis in neonatal fever. Even a neonatal scrub is also coming up. So what is the antibiotic of choice? Doxycycline 5 milligram per kg for a period of 7 days. The alternative is azithromycin 10 milligram per kg for 3 days. So in short, when you come across a fever more than 1 week and you are able to pin down the diagnosis, treat accordingly. If you don't have the diagnosis, you can go for empirical scrub typhus management. If you are after doxycycline for 48 hours, if the child is not responding, stop the doxycycline, go for enteric fever management with cefixime. After we are not able to get the blood culture, wait for 3 to 5 days, how the child is responding, and we should go. So in our part now, if you know your area is an endemic area, like Vilpuram Pondicherry area is an endemic area for scrub typhus, we diagnose any fever more than 1 week. The first and foremost thing we will do doxycycline, wait for 48 hours. This is the empirical scrub is taking an upper hand over than empirical enteric fever management. There is no role for empirical anti-malarial treatment anywhere in the particular in India nowadays. Okay. So coming to the last set of conditions, I have finished the fever, how to decide your antibiotics. And that is when you finalize what is the problem, you should shoot with a gun at a point blank range. Otherwise, don't use the gun in a particularly shooting in the forest. You should find out the infection, then treat. Otherwise, don't blindly treat any fever with antibiotic. Don't blindly treat neutrophilic leukocytosis, I have told already. Skin and soft tissue infection, we all know the organ, the culprit are staph and strep. The wonderful drugs are the first generation cephalosporin, 30 milligram per kg, cephalexin 50 milligram per kg for a period of 7 to 10 days. If there is a scalp infection, you should treat for 2 weeks to prevent the recurrent infection. You should go for 2 weeks if there is scalp infection. And if there is acute lymphadenitis, we know sometimes what happens, the oral cavity is the culprit, the anaerobes will be there. So except for that, the other lymphadenitis, simple cefadroxil cephalexin will do. But if oral cavity is suspected, you should go for amoxiclav whenever there is acute lymphadenitis. So, okay, what about bites? Human bite, cat bite, dog bite, whatever bite, amoxiclav is the drug of choice. So just to finalize, there are only 3 groups of infections. We deal with day in, day out, and you are rewarded with skin and soft tissue infection and respiratory infection, gastro and genitourinary infection. So just 3 groups of antibiotics are more than enough. Amoxicillin is more than enough in 90% of the times in RTI. Cefixime is more than enough for below the diaphragm condition like UTI, enteric fever, dysentery. Enteric fever, you mind it, 20 milligram per kg is the dose. Now, a word of caution, the ESBL UTI is on the rise. Particularly in Chennai city, it is around 50 to 70%. We don't know about the periphery. It is definitely on the rise. Whenever you start treating a UTI with cefixime, 48 hours if the child is not responding, your antenna should be high. You are dealing with a case of ESBL UTI. Or else if the child is having recurrent UTI, already the child is having some anatomical problems, the child is mostly having a ESBL UTI. If the child is presenting with urosepsis and shock, your antibiotic should not be cefatoxime, ceftriaxone. Your antibiotic should be piperacillin, tazobactam, or amikacin if the child is stable and the passing urine well. And like, for example, under treatment is also a not rational drug therapy. For example, these are the conditions you should start treating with the proper antibiotic. You should not, you may ask, what about why piperacillin, tazobactam for office practitioner? Even that is not an over drug. When you are dealing with a sick child with UTI, piperacillin, tazobactam is the drug of choice, or amikacin is the drug of choice. We should be very careful about UTI, ESBL is coming up, be careful. Cephalexin and cefadroxil is the drug of skin and soft tissue infection. Rarely you can come across community acquired MRSA. If you start with the cephalexin and the child is not responding, child is taking properly, all the lesions get exacerbated. Think about community acquired MRSA, go for clindamycin or a simple clotrimazole. That is the mainly drug of choice for SS community acquired MRSA. These 2 things are coming up. That's what you should have in mind. What are the special situations? Rickettsial and mycoplasma, doxycycline, azithromycin is the drug of choice. So now we are clear, just 3 plus 1, 4 antibiotic, and the caveat exceptions, ESBL and CA-MRSA, these are the exceptions. So finally, in short, when do I use antibiotic in my OPD? In a sick child, no doubt, any sick child in pediatrics with fever is a serious bacterial infection, SBI. So I will start antibiotic after sending appropriate investigation to know where the problem lies. Number 2, in any cold, if it becomes complicated cold, I will definitely start antibiotic. In any cough, if it is a complicated cough, suicide cough, or a chlamydial cough, or a 4-week wet cough, more than 4 weeks duration, definitely I start antibiotic. In a pneumonia, no doubt, antibiotic. Fever with oral ulcers or viral, you don't treat with antibiotic. Fever without focus, this is a common area. Try to find out the occult infection, occult pneumonia, occult UTI, or occult abscess, dig it out, find it, and finally treat, because the antibiotic for UTI may be different, antibiotic for pneumonia may be different. Don't use a different antibiotic for different thing, definitely it will be a failure. So fever case, unless you specifically find out the problem, don't treat if the child is not sick. Fever more than 1 week, empiric scrub or empiric entry fever minimum justified. During this COVID season, any fever more than 72 hours, see to that you are not missing a COVID MISC. Loose stools, we all know only when visible blood is there, go for start treat with the Cefixime. Benign bacterial infection like cellulitis, abscess, lymphadenitis, we all know first generation cephalosporin are very does wonders. Prophylactic antibiotics, because of lack of time, I'm not going, is only with specific indications. We should not use right and left prophylactic antibiotics in practice. So finally, routine antibiotics to prevent secondary infection. I am giving antibiotic to prevent secondary infection is not a valid argument. Evidence doesn't agree to that point. Evidence is against that point. So finally, this is the number of kids in our OPD. We in our center hardly use antibiotic less than 10%. So the take-home messages are to start your rational practice. The first and foremost is ink your prescription. Start putting a diagnosis in the head. Then your practice will become rational. Your antibiotic prescription will be rational. To get the confidence, go to the YouTube again and again. Hear Professor Ambedkar sir lecture. Get the confidence. The problem is the confidence is lacking among us because of the competition, because of the parental pressure, and many factors. If I am not going to use antibiotics, my neighbor is going to use antibiotics. I'm afraid I'm going to use antibiotic. At least gradually you try to reduce. Initially 10%, next 10%, next 30%, and finally one day you will particularly find it very difficult to write an antibiotic, whether it's needed or not. That will become a very problem to write an antibiotic. So provisional diagnosis is the first and foremost. Take home message number 2. Majority we are dealing with an office practice. Don't worry, 90% are viral. You can take for me because of the analyzing lakhs and lakhs of patients. This is the statement. Benign bacterial for 10%, serious 3, sepsis, meningitis. Meningitis hardly I have seen about 2 to 3 per the 10 years. So very rare, all this very thing. First 3 days of fever, cold, cough, and watery diarrhea, healthy baby, no need of antibiotics. The antibiotic obsession, we will try to de-obsess. It is the attitude, not the knowledge that matters. If you have the attitude to change yourself for excellence in office practice, to be rational and to preserve the wonderful gem of antibiotics, definitely you will do it. Everyone can do it. If I am in the periphery able to do it in my district now, I am very proud. In Viluppuram Pondicherry district, plenty of people are using a rational antibiotic because of repeated arrival of Professor Ambedkar and his lectures. Now majority of pediatricians in our district chapter are following the rational antibiotic therapy. I definitely vouch. In all the districts also is same. It is improving a lot. Thank you one and all. So finally, above the diaphragm, amoxicillin, below the diaphragm, Cefixime. Be careful about ESBL, cephaloxin, cephaloxin, skin soft tissue, doxycycline, azithromycin, atypical infection. Thank you very much. Thank you one and all.
Yeah, thank you, sir. As usual, you presented very nicely, and I think as Brini itself, I told you are like a Dhoni, you scored like anything. You have done very well, sir. And
thank you very much, sir.
Yeah.
Any doubts? We are ready to start. To start with, you can start with the antituberculosis. Any doubts on this antituberculosis therapy? We can start.
Yeah, antituberculosis, as per the, they didn't ask any questions, sir. And regarding, sir, you told that the cloxacillin, sir, cloxacillin is currently many area we are not getting cloxacillin, and only IV flucloxacillin only we are getting IV flucloxacillin only available. And what's your advice regarding this one, sir?
Cloxacillin definitely in government institutions it is available. In specific institutions, particularly higher institutions, it is available. But in the periphery or outside, the oral cloxacillin is not at all available. Now the only alternative to oral cloxacillin is first generation cephalosporins. So nowadays, particularly even with osteomyelitis, when you are starting with IV cloxacillin, what happens? As a step-down therapy, we are not able to send with oral cloxacillin. We are giving oral cephaloxin as an alternative to cloxacillin. So that is the thing. Cloxacillin is not available because we are not using. So that is the reason it has completely, because it's cheap drug. Because of cheap drugs, we are not at all using. So naturally, it has gone out of the market.
Yeah, another one is the COVID flow chart. You told that after blood count and CRP elevated, shall we do procalcitonin to rule out any bacterial infection?
Definitely, having the cost in mind in our setup in a developing country like in our state, definitely I don't think it is worthwhile. But definitely MIEC is a diagnosis of exclusion. Even there is neutrophilia is there, thrombocytopenia is there, CRP is markedly raised, but you are going to evaluate the patient in and out. You are going to see to that you are not missing a meningitis, you are not going to miss a pneumonia, not miss a sepsis, urosepsis, or serious bacterial infection, or a serious infection like Kawasaki and everything. Finally, only you are going to come to the diagnosis of MISC. It is not a first diagnosis, but during the season, definitely we should have in the back of the mind. Even in the institutions, if they are getting admitted, they will try to rule out all the infections before coming to the conclusion. But this awareness is very must, and particularly the CBC doesn't give the clue, so only CRP, addition of CRP will give a clue. So that is the message I want to take. CBC along with the CRP is very, very important during this COVID season.
And regarding
Panniraman sir, what about that PCR test, sir? You are not highlighting on PCR for COVID?
A test of PCR for COVID, definitely. Yeah. For example, in children, for example, primary COVID infection is not at all a big problem for children. Because, for example, if in the family, the members are affected, if they come and ask whether I should do COVID test for my child, whether you do it or not, definitely it is not going to affect the management part of the child. Because majority of the childhood COVID is very, very innocuous and no point in doing the investigation. Okay, so that is the reason, no point in. But the COVID test is mainly useful only when the child is presenting after 3 weeks of COVID, we presenting with the multi-inflammatory syndrome, whether we are having any problem or not. So when a child presents with MISC presentation, we will do both the test, COVID PCR as well as antibodies, because sometimes antibodies only will be present, sometimes PCR and antibodies will be present. We know that we are dealing with a case of COVID, post-COVID problem. So during the COVID presentation, whether it is a very benign thing, it is not affecting children much. No point in doing routinely COVID PCR in a children.
Dr. Panniraman, a question delegates is, how do you deal with the pressure of prescribing antibiotics? How do you deal?
No, actually, it is the confidence you built upon day by day from the initial years. Because my initial years were the late 90s. Late 90s started this rational practice. Gradually, I used to write cotrimoxazole for each and every prescription initially. Gradually, then you develop the guts after gradually eliminating little by little the antibiotics after hearing the lectures, and you start experimenting yourself with the minimal number of patients. And finally, you will getting the same patient again and again. You will be coming even without antibiotics. They are getting settled without antibiotics. You think now you can understand what the sir has told is correct. So no need to write antibiotics. So gradually you expand the patient, that is the number of patients particularly that is not using antibiotics. Finally, one day or other, naturally 90% of the patients you will not be using antibiotics. The guts you will automatically get. So it is not a one-day affair. You have to start the experimentation slowly, and slow and steadily. This is my regular patient, I can experiment with him. This is a problematic patient, I can't experiment with him. You start experimenting with your regular patient. Even the patient is not getting corrected, he will definitely come back to you. Then you can know whether you are right or wrong. So like that only you start your experimentation and you will get confident. So mainly the evidence-based guidelines and the experience by the seniors and the confidence definitely will play a major role in getting you the confidence. It is only the matter of confidence and the attitude, nothing else. Only when you attitude to do excellence and the confidence, naturally it's not a difficult thing. For example, Dr. Arulanand from Vellore, actually he is doing this for a very long time. We followed, myself, Dr. Dandamani used to follow him as a guru for particularly not raising the antibiotics initial days. Then only Professor Ambedkar sir came into the picture. So for giving the confidence.
Yeah, the patient counseling, you have to deal with the parents. Very patiently, you have to deal with them and explain to them what are all the effects and what we are trying to do and what we are trying to help the child. So in a way that the counseling will also help, I think. And as you usually used to say that that prescription audit, and you yourself self-audit whatever your prescriptions you've been giving, and now you can see your old prescriptions and you can see what are all mistakes you have done, and you can learn from it and you can change your attitude, because as you rightly pointed out, 90% of the infections are viral. Why to prescribe an antibiotic? That is the point that has to be taken during this CME, and hereafter the resistance has to be brought down, and we have to consciously, and we have to do a soul searching. Definitely. Thank you, Dr. Palna.
And definitely IAP software. Only one thing, sir, start using the IAP software. Definitely you will be self-auditing frequently, how much I am using, what is the problem I am daily facing. You can easily self-audit what are the problems you are going on, what are the antibiotics you are using. It's very useful. Start using IAP software. Definitely it will be definitely one step. It will take you one step ahead.
So regarding common scenario, UTIs, many a time we are sending culture and amoxicillin comes resistance, but clinically child is improving. What's your advice, sir?
Sir, if the child is not a case of recurrent UTI, if it is a first episode of UTI, you started on amoxicillin, if the child is responding, because we know beta lactams very much highly concentrate in the urine. So what you do in the urine culture, particularly culture or in vitro culture, may not be reflecting what is happening inside the body. If the patient is responding, go ahead with the treatment. Go ahead, no need to escalate the antibiotic as per the culture report. You can continue the same antibiotic, except in the sick child, we will not be hesitant to upgrade. In a sick child, even if the child gets, if it is, for example, if the sick child, if it comes, even if the child is responding, but you will be very hesitant to think whether to escalate or not. But in a non-sick child, no need to escalate.
Dr. Kritika, regarding MADO test, I think that nowadays that newer diagnostic test replacing a MADO. What's your opinion?
It is the first screening investigation we should do, sir, to detect the latent TB infection. The only problem is the recommended strength is 2 TU tween 80, but we are not getting it actually frequently. So in case it is not available, we can go for a 5 TU PPDS, but never more than that, sir.
Okay.
So it is mainly useful in two situations, sir. One, before starting immunosuppressive therapy in children with nephrotic syndrome or any children with the rheumatological conditions. So we want to detect the latent TB infection there, and also we want to prevent the progression of the infection to the disease, so that we can give 6 months of INH to them after ruling out the active tuberculosis therapy, sir.
Yeah,
Kritika madam, in a recent statement by NHM director, he's telling that do TB diagnosis for all cases of COVID. When do you do that?
Whenever it fits into the case description, we can do that, sir.
No, COVID positive patients after treatment, the NHM director says you have to do like HIV, you have to do for COVID positive patients, you have to do for tuberculosis. So
Even
is there
when
any
they are
guideline
not,
for?
even when they are not symptomatic, sir?
Yes.
I'm not aware.
No, not for children. I'm telling general. Thank you.
Oh, yeah, I don't know, sir. For adults, I don't know, sir.
Okay, okay.
Actually, in our center, when I was discussing this with our thoracic physician, he told that he is following up so much cases of tuberculosis, sir. So even only one extensive drug-resistant tuberculosis patient so far had been admitted with COVID in our center, sir, in Tele Medical College.
Maybe a immunocompromised, I think, may reactivate tuberculosis.
So he told me so many studies we need to do to know these things, and also he told that even COPD patients were not affected with COVID in Tele Medical College. I just know that scenario, sir. I don't know for the whole India.
Okay.
Tele Medical College, only one patient, adult patient with XDR TB had been admitted with COVID, got treated, and also he had gone well to home.
So we can explain, I think, immunocompromised child, maybe a reactivation. That's something we can explain. Yeah.
Okay, sir. Maybe, sir. Thank you.
Yeah, next one, sir. Hello.
Sir, thank you, sir. Thank you, Suresh Balan, sir,
Thank you,
and Rajendra.
thank you, Palniraman sir, for an excellent presentation. Thank you.
Thank you very much, Sendil. Thanks.
Thank you, sir.
Thank you, sir. Thank you.
Thank
Thank
you.
you. Thank you.
Thank you.
Another one.
We go to Dr. Vijay Bhaskar, the pediatric dermatologist from Chennai, who's a seasoned stalwart in dermatology, and he's an experienced teacher par excellence. We'll go to him without wasting much of a time. Over to you, Dr. Vijay Bhaskar from Chennai, the wonderful dermatologist.
Very good evening, sir. And after this excellent presentation of Dr. Palniraman, I am a bit scary. And you're able to visualize my screen?
Yeah.
So now we are going to talk only about photo gallery. First of all, I would like to thank the IAP TNSC for giving an opportunity to be a faculty for this great virtual CME. And pediatric dermatology, as we all know that around 30 to 40% of our practice, we have dermatology cases coming in. I was practicing pediatrics before because after my DCH, I was doing a pediatric practice, and I really don't know. Most of the time, I had so much of difficulty in making a diagnosis, and sometimes I refer and I follow the same prescription for many patients after that. And we see we have so much of patients. This is like this. Having a wife is a part of living, but living with wife is an art of living, right? So we have so much of patients, but the only thing is when we are able to make a diagnosis, yes, we can have an art of prescription and art of treating the dermatology patients. And topical therapy, if you see in dermatology practice, almost 70 to 80% we manage with topical therapy. And for a successful treatment of common skin infection, we have to follow three basic principles. One, if it is a wet skin, dry it. If it's a dry skin, wet it. Suppose you have a woozy lesions like an eczema, use a cream. Suppose you have a dry lesion, use an ointment. Second, first, do no harm. So do no harm and never overtreat. This is the second principle you have to follow. Third, always when you prescribe a medicine, you have to instruct the patient that they have to follow the instructions carefully and adequately regarding the application of medications. Because I have seen patients, one tube may last for 1 week, but they'll be using it for 1 month. Or they may finish it up within 1 day also. So that is very, very important. So these three basic principles are essential to have a successful dermatological therapy. So let us straight away go ahead with a small baby. Here we have a baby, and most of you would have come across this condition. This is nothing but an intertrigo. What do you mean by intertrigo? It is nothing but friction between two opposing skin surfaces. My professor, Dr. Jayakar Thomas, used to tell of one's own body. You used to add that, not two bodies, right? That is one. And so we all know that it occurs commonly in the axilla, groin, in the neck, and wherever there is a friction, you can see these lesions that are coming up. And sometimes you can even see a satellite lesions that is very, very common. And it is mainly present in the moist and warmth area. And initially it starts with intense erythema, particularly when it occurs over the neck or axilla. And candida is one of the commonest cause for this intertrigo. But staphylococcus and streptococcus may also cause this intertrigo. If you look at this picture carefully, you've got even slightly whitish lesions that are present, and you've got multiple satellite lesions also that is present. This is mostly candidal. Whereas in case of staphylococcus or streptococcus, it will be intense red in color. It will be intense red in color. No satellite lesions will be there, and most of the time there may be oozing that may be present. So how will you manage this condition? Very simple. First, you have to reduce the friction between the opposing surface. So you can use liquid paraffin or an emollient so that the friction comes down. That itself will bring down the lesions. And we prefer antifungal creams, particularly azole group of drugs here, clotrimazole, topical ketoconazole. All those drugs can be used twice daily. And whenever you suspect a secondary bacterial infection, or as I told you, when it is intense red with some amount of oozing, then you can go for antibacterial creams. Particularly your mupirocin or fusidic acid can be tried. I always go for mupirocin drug. And when it is very severe, when the ooze is there, then you can go for oral antibacterials. Otherwise, we manage intertrigo only with topicals. And of course, when it is not oozy, when it is mildly erythematous, then the best drug of choice will be topical steroids. That too, because it's going to be in the occluded area, you have to use the least potent or weak steroid like 1% hydrocortisone cream. You can apply twice daily for a period of 1 to 2 weeks. Most of the time, it will become better. And the main important thing you have to advise the parents is not to apply any talcum powders, particularly in these areas, because most of the time you can see that being applied. And there should be good aeration in this particular areas wherever these lesions are present. And these are all pictures which are sent by Dr. Parani Raman, what he comes across in his OPD practice. And this is another child, maybe around 2 to 3 months, or it should be around 2 months. You can see that lot of hypopigmented scaly lesions that are present over the face as well as on the chest. And if you see here, you can see some amount of scaling on the scalp also. This is a clear-cut patient of seborrheic dermatitis, right? It is very, very common. In Tamil, we call it as podugu. And podugu is one of the thing in seborrheic dermatitis. And anything scaling in the scalp, we call it as podugu. It is from womb to tomb. Karuvarayilirundu kallarai varai, you will have this seborrheic dermatitis. And usually in babies, we know that it starts as cradle cap, and they have the manifestations like this over the face. You can see scaly patches, and most of the time they will be associated with intertrigo of the groin, intertrigo of the neck areas, because in infants or less than 6 months, atopic dermatitis presenting with flexural area is very, very rare. So don't put it as atopic dermatitis. It's mostly seborrheic dermatitis that will occur. So how do you treat this? So just a baby shampoos is more than sufficient for this. Any baby shampoo can be used twice or thrice a week. That is more than sufficient. And liquid paraffin is the best medicine I can tell for the scalp. And what about for the face and body? You can go for a plain emollients or more than thing. And you have to apply twice daily, immediately after bath or after a wash you can apply. And in cases when the parents are very much worried, or if the baby has crossed 2 months or 3 months, even you can go for 1% hydrocortisone cream twice daily, 2 to 4 weeks. This problem will settle down. Most of the time, the seborrheic dermatitis will settle by 2 or 3 months of age. In case it persists for more than 6 months or 3 months, have in mind, look for other places, whether are you dealing with any atopic dermatitis, or if the scaling in the scalp is going to persist and it is severe for more than 6 months, think of even psoriasis in a child like that. Otherwise, most of them will get control with this therapy. And this is another common condition. This is a 45 days old baby which is presented to the clinic with lot of papillar lesions in the body. Otherwise, child is otherwise completely okay. Any bizarre lesions like this in a neonate or even second month or third month of life, always the first, second, and third diagnosis should be scabies, scabies, scabies. Here you can see that the next thing you have to look is the palms and soles. Most of the time there will be papillar lesions in the palms and soles. They may not have itching, they may not be scratching, but they may be irritable sometimes. And look at the mother's hand. You can see small papules in the wrist. This is a typical case of scabies, and it is 45 days old. And the drug of choice in a baby who is less than 2 months is only sulfur ointment, and above 2 months of age we can use your permethrin. 5% permethrin has to be used. No dilution of permethrin, because it's a baby. You have to use only 5% permethrin. But getting a 5% sulfur or 6% sulfur, it is not readily available in the market. It has to be brought, it has to be dispensed, and most of them, they don't do it. So in my practice, I still go ahead with the same 5% permethrin. I have to apply throughout the body and wait for only 8 hours. 8 hours is contact is more than enough. And you have to have one application now and then repeat it after 1 week. And all the family members have to be treated. If it's a child, you can apply and leave it for 10 hours. And if it's an adult, you can apply and leave it for 12 hours. So most of the time, but you have to treat all the family members. That is very, very important. Because US FDA has approved permethrin above 2 months of age group, but there are studies which has not been done below 2 months of age. So I have been using this permethrin even below 2 months of age. We don't come across any issues. And even nowadays, you can go for topical ivermectin is also available, but it should be used above 6 months of age group. You can use it up to the adult life. You can use topical ivermectin also for these scabies. And coming back to the dandruff, particularly I was talking about dandruff. As I told you, it is from womb to tomb, and there is a lot of myths about dandruff. they come and tell you that because I used my uncle's comb, after using the comb, I got this dandruff. Most of the time you can see more in the adolescent age group, because it starts in the utero, and you can see them as a cradle cap in the newborn or in the infantile phase. Then it resolves, then it comes back again in the adolescent age group. So most of the time they come and complain. And people also tell, I lose hair because I have dandruff. This is another myth about the dandruff. And third, they say when I apply oil, I have less dandruff. But all these are completely false. Dandruff occurs only in genetically prone individuals. There should be a genetic history. There should be a family history of dandruff. Only they are prone for it, one. And they get exacerbated during winter season. And Malassezia furfur is the main culprit here. And it can produce inflammation and scaling. And antifungal shampoos are more than sufficient. Coming to the myths, as I told you, none of the combs is going to spread dandruff from one person to another. And hair loss does not occur due to dandruff at all. And in fact, oil increases dandruff, because people, when they apply oil, they don't see the scaling. So they think that the dandruff is under control. But when you apply oil, what happens is this Malassezia furfur is a lipophilic fungus. It likes oil. So the dandruff increases actually because of the oil. So the less the oil or no oil, it's always better. And what antifungal shampoos you will recommend? Ketoconazole based shampoos like ketoconazole with ZPT, like zinc pyrithione, or plain ketoconazole lotions are more than sufficient. How do you use it? You slightly wet the hair, apply 5 to 10 ml of these shampoos, massage well into the scalp, leave it for 5 to 10 minutes. Just don't immediately rinse it off. It is like pouring money and washing it off, just like that. So apply it, wait for 5 to 10 minutes, then you can rinse it off. Initially, you can use it twice a week. Maybe after 1 month, when it gets controlled, even once a week application is more than sufficient. You can use it for 3 months. This is another common condition we come across in our practice. This is again a picture from Dr. Parani Raman. So you can see a linear whitish few papules which are coalesced to form a linear lesion. This can extend up to the gluteal region, and even it can go up to the toes. This is asymptomatic. They don't have any itching, nothing, because it is cosmetically disturbing and they are worried. Whenever they see a white patch, they are worried. It could be leprosy, it could be vitiligo, they come to you. So you can see that there will be some amount of scaling also, and mostly it will be papules that gets coalesced, and it is lichen striatus. It is very, very common in children, and usually it is unilateral, but we have seen bilaterally also. And either it will be in the upper limb or in the lower limb. In the upper limb, it can start at the tip of the finger and it can go up to the shoulders or even up to the back, depending on the dermatome which gets involved, or it can start at the tip of the toes and it can go up to the gluteal region. And usually it disappears. It starts as a small lesion and it can progress. And tell the parents, explain to them, reassure them that this will disappear. Maybe it may take a year or so, definitely it will disappear. In case they are very particular that the medicine should be used, you can use an emollient, or even you can use a safe tacrolimus 0.03% in children, or pimecrolimus can be tried as once daily application at night. And most of the time you can see them getting disappeared within 6 months to 1 year of time. This is yet another common condition you can see in the OPD, where you can see multiple papules and the child will be scratching, and most of these papules will be in the exposed areas, but may not be much on the face, but it will be more on the extremities. Both the extremities you can see multiple lesions, and the child will be scratching, will be crying more during the nights. You can see this. This is a typical insect bite hypersensitivity. And it is common between below 3 and 3.5 years of age. Of course, we do come across children even above this age group, and they'll have severe itching. Sometimes they disturb the sleep also. And all these areas are not bitten by mosquitoes. The mosquitoes would have been bitten only in a few areas, but it is an hypersensitivity reaction which causes this reaction. That is the reason not all children who are bitten by mosquitoes will develop this. Only few children who are prone for this will develop. So and the face may not get involved at all, because the mosquitoes don't sit on the face. They may sing a song near the ear, but they may not sit on the face, because if you have a repellent activity in the face, or you'll have a minimal involvement. And most of the time when these lesions disappear, it will leave a post-inflammatory hyperpigmentation. So how are you going to treat these patients? First and foremost, I tell my patients, I even write in the prescription, is 3 things. Prevention of mosquito bites. One, I tell them they have to wear full sleeve shirts and pants, maybe by evening or in the whole day they can wear full sleeve shirts and pants, particularly cotton pants. Second, they can go for your topical mosquito repellents, the commonly used ones, Odomas, that can be applied. And people are a bit afraid when I tell you can use Odomas. They tell, sir, small child, whether I can use it. Yes, you can use it. Above 6 months of age, you can use these mosquito repellents, which contains DEET safely. Nothing will happen. But it will work only for 4 to 5 hours. So they have to repeat it after 4 to 5 hours. That's very, very important. And third thing is they have to sleep under the mosquito net. And of course, the fourth one is available where you can move out of a place where there are no mosquitoes. I don't think anywhere in the world you don't have mosquitoes. So that is prevention. That is very, very important. Of course, topical steroids will take care of the papular lesions. I go for fluticasone or even desonide can be used for these type of children. Twice daily, you can apply it for 2 to 4 weeks. You can safely use these steroids. And antihistamines are very, very essential. I told you these are all hypersensitivity reactions. So you have the itching will be present. So you have to use antihistamines for weeks or even sometimes months together. You have to use the antihistamines. And sometimes when they scratch, they can develop secondary infections. So topical antibacterials, if the lesions are very less, you can go for mupirocin itself. Or if it is going to be a mixer, then you can go for a topical steroid with an antibiotic like fluticasone with mupirocin or fusidic acid with the hydrocortisone can be used. And antihistamines plays a major role in controlling the itching. And tell them all these marks, post-inflammatory pigmentation also will disappear as the child grows. And this is another child who is presented with papular lesions over the extremities. There is not much of itching, here. And you can see it is present over the lower extremities also. And you can see the lesions over the scalp also. And some of the lesions are present on the face. I particularly avoided the face actually here. So you can see the lesions that are present on the scalp. But itching is not that much. So what is this condition? This is yet another condition we are coming across nowadays. Very commonly we are coming across. It is nothing but your Geonitic Rosty syndrome, right? Which is very, very common. Any virus in the earth can cause this Geonitic Rosty syndrome, and they may not have itching at all, or it may be very mild itching they can complain of. Again, reassurance, of course, topical steroids you can use for the lesions, and antihistamine if necessary. If they have itching, then you can go for antihistamines, but you may have to use the steroids for 2 to 4 weeks, or even you have to step down after 4 weeks because these lesions may continue for a few weeks or even for a few months. It can continue, but most of the time they resolve and they will not have any problem. So please think not only about IBH, you have to think about Geonitic Rosty also whenever there is itching, whenever there is lesions without itching or very mild itching, and face is getting involved and scalp is also getting involved. So this is another common condition. You can see that scaly hyperpigmented lesions over this area, and you can see in the waistline also. So we know the culprit is going to be this one. The threads, the waistband that have been used, they cause a contact dermatitis or an allergic contact dermatitis can occur because of this. So the best thing is remove the contact. Whatever the contact has been there, you remove it. And of course, for the skin lesion, because it may be itchy also, when it is very severely itched, that can lead to secondary infections also. So you can go for topical steroids. As I told you, because in the body area, you can go for fluticasone, or even you can go for desonide, or it's very mild, you can go for hydrocortisone cream twice daily for 2 weeks, or at the maximum for 4 weeks. Everything will disappear. But don't reintroduce this waistbands or thread for some time. Even you can wait for more time also. And sometimes you can get lesions like this here, the same child. You can see the lesion here, because in our community, most of them wear the copper like thing. They wear it with the thread, sacred thread. So that can cause these type of allergies. So even that has to be removed. Of very sentimental, I ask them to tie it in some other place without any contact to the body normally. And as I told you, topical steroids, if there is itching, go for antihistamines, and most of these conditions will disappear. And I don't know how many of you are coming across this condition, or maybe during our PG days, we used to see more cases like this. This is nothing but horny keratotic papules that are present over the elbows, knee joint, and the gluteal region. We can see this is nothing but your phrenoderma. A lot of discussion about the cause for it. So many people used to tell vitamin A is the main cause for this, and vitamin B complex. But of course, the main deficiency here is going to be essential fatty acid. Essential fatty acid deficiency. Of course, there may be mild amount of vitamin A and B complex deficiency also. So how do you treat it? I generally don't recommend any topical preparation for this. If at all they are very adamant in getting treatment, you can go for salicylic acid. 3% salicylic acid can be applied, but I don't do that. I don't send them to the medical shop at all. I don't give a prescription. I send them to the provision shop for this, because they can buy gingerly oil or the sesame seed oil, whatever we call yellow ennai or nalla ennai. It is a good oil, right? It's a nalla ennai. They can apply over the idli, or they can use it for dosa, or they can use it for podi, and they can go for gingerly candies. Yellow runday, the karupu ella irundhalum sari, vella irundhal, vella ellu edu irundhalum. You can give 1 or 2, 1 OD or 1 BD for 3 months. Everything will disappear. Everything, all this phrenoderma will disappear. And I have seen good results. Of course, ask them to take plenty of greens, carrots, papaya, everything they can advise for these children. And of course, this a few of you maybe who are practicing the seashore or even the other areas may come across this condition. You can see a linear lesion, or it is going like a tract. So this is nothing but cutaneous larva migrans. You have to ask the history, whether the child was lying without clothes on the floor, or whether the child was lying somewhere in the ground, or in Chennai particularly, they lie down in the beach, or they may give bath to the baby or the child, and the child may be lying on the beach. And most of these people, they pass tools in the beach area and they cover with the sand. So this is your cutaneous larva migrans, which is very, very common. If it is moving very fast, that is, you see this one day here, and the advancing end moves very fast, then we call it as larva currents. It moves very fast. So here again, the treatment of choice is going to be albendazole. Albendazole, you have to give for 3 days, 400 milligram for children about 2 years. We give it for 3 consecutive days. Albendazole can be given. And in a small child who's less than 1 year, where we cannot use albendazole, you can go for ether. You can even spray ether in the advancing end, or you can freeze the advancing end with liquid nitrogen. The larva will die. What if I don't treat? What if I don't treat all this? Nothing. The larva has to die because there is no other go. Maybe it will persist for 3 weeks or 4 weeks if you don't give the treatment, and the larva is going to die at one point of time. But the only thing is they're more worried because there is some linear thing like this going in the body, and there are multiple. You may have multiple lesions also in the back. So then their parents are worried. So we treat them with albendazole. That is the drug of choice. In a child below 1 year, we can try ether, because you can freeze it with ether in the advancing end, and the larva will die and it will not progress after this. And this doesn't leave any post-inflammatory pigmentation or any scaling. Nothing is going to happen. And this, of course, is another biggest problem we face. And in one of the biggest school health problem in US also, this is one of the biggest school health problem. This is pediculosis. Pediculosis, yes. Again, wherever there is going to be hair, you can expect pediculosis, and particularly from one family member to another family member, it can easily spread. And in school children, it is very common because just 30 seconds of contact between two heads is sufficient for the pediculi to cross from one scalp to another. So common it is, and people think that this is a disease of poor. They don't get any pediculi. And you ask the poor person, he will say, "Sir, enga paramparaikke illa," because nobody they think it is disease of very poor people or unhygienic people. It is not so. Whenever there is a scalp, it can easily adhere to the scalp. So how do you treat them? It is only topical permethrin, 1% lotion. 1% lotion you have to do. But the main application is very, very important, because most of our children, they have oil on their scalp. The medicine may not work when they have oil. So you have to ask them to have a shampoo bath. They have to have a shampoo bath. They have to dry the hair, and they can apply the lotion. So the amount of lotion that has to be applied is 30 ml for hair which is up to the shoulder. And to the mid back, if they have a hair, you can apply 45 ml. And if the child has got long hair, you can apply 60 ml. You apply it, wait for 10 to 15 minutes, not more than that. After 15 minutes, they can just rinse the hair off, and they need not apply any shampoo after that. They can rinse it off, and they can dry it. When it is slightly wet, you can use a knit comb. You can do a wet combing in these children. So you can repeat it. Strictly speaking, you have to repeat it after 10 days, but that is practically not possible. So I ask them to repeat after 1 week. This Sunday means again they can use it on next Sunday. And all the family members has to be treated for pediculosis capitis, except people who are bald in the family, right? Otherwise, they have to be treated because it's very common. Of course, adult male may not have much issues, but all mother, grandmother, whoever is there in the house or other siblings has to be treated. You can give oral ivermectin also. You can give like the same dosage for scabies, 0.2 mg per kg body weight. You can use it, maximum of 12 milligram per dose. And of course, oral cotrimoxazole also we tried. And after Dr. Palliraman said, I don't know whether I should use this antibiotic. So oral clotrimazole can be used. You have to use it only for 3 days if the child does not have any allergy to sulfa, because the pedicles has got a gut bacteria and they have symbiosis with the gut bacteria. So when you give clotrimazole, when the pedicles sucks the blood, the clotrimazole enters the gut and kills the gut bacteria. So the symbiosis is lost and the pedicles dies. It cannot survive. That is how the oral clotrimazole works here. And after the treatment, successful treatment, this is the another problem we face. Nits, lot of nits. Sometimes you can have thousands or even I can tell lakhs of nits that is present in the scalp. And it is like putting a gum and Fevicol and sticking it. So tight it gets adhered to the skin. It's very difficult to remove them. So how do you manage this? One way you can manage is after you're successfully treating the pedicles, you can apply, you can slightly wet the hair and you can apply white vinegar. White vinegar can be applied. Leave it for 5 minutes and then you can rinse it off. Weekly twice you can do for 2 to 3 weeks. And then you do a wet combing also. Most of the time this nits may disappear. And if it is so severe enough, then the only way is you have to go for shaving of the scalp. But before that, you have to counsel the child, because you have to take it very seriously, because everybody will be in the school. They may feel ashamed to go with the shaved scalp. So you have to counsel the child before you advise that. This is another common condition. I mean, not so common, but we do come across this condition. You can see multiple papules. So if somebody is having the timer, please let me know, because I always overshoot my time. Sometimes I speak for hours. So please tell me when I should stop. And you have multiple whitish papules. They're all pinhead sized papules that are present. And some areas you can see cubnarization. That is, it is the similar lesions occurring at the line of trauma, or when they scratch, they can have similar lesions like this. This is cubnarization. It's typical of many conditions like wart or like MC. You get in many conditions in lichen planus, so many conditions you get. This is lichen nitidus. This is called as lichen nitidus. And initially, few years back, or even 20, 30 years back, people thought this could be a manifestation of tuberculosis, skin manifestation of tuberculosis, but that has been disproved. And again, this exact etiology nobody knows. And most of the time, we reassure them, if at all they need any drug, you can go for calcineurin inhibitors like tacrolimus or pimecrolimus can be used for this condition and it can disappear. It is called as lichen nitidus. And this is another common condition we come across in our OPD, particularly between July and December. They may have mild constitutional symptoms or they may not have. They may present with a small patch like this. This looks like a tinea, right? Looks like a dermatophyte, but it is not so. Non-itchy, a scaly lesion, they come to you. And most of the time you make a diagnosis of tinea or you give some medicines here. And after 2 weeks, this may disappear and they can come back with this type of lesions after 2 weeks. You can see multiple lesions, oval lesions that are present completely on the trunk. This is when they come to us. So initially the pediatrician gets caught with this lesion. So it's very difficult to make a diagnosis at this stage, but when they come with this, it's very easy to make a diagnosis. This is nothing but pityriasis rosea. This is a mother's patch, we call it as an herald patch. And this is the daughter patch which occurs after 2 weeks, which is very common between July and December. It's a viral infection. It's caused by HHV 6 and 7. They may be asymptomatic or they may have severe itching also. And it classically involves the classical pityriasis rosea involves the coat sleeve appearance or how you wear a half shirt. Only in that area you may have the lesions, and most of the lesions will be oval. And if you see the transverse diameter, it will be parallel to the, and most of this transverse diameter will be parallel to the costal margin. They can run like this. So this gives a fir tree or an inverted Christmas tree appearance that you can get it. And again, treatment is going to be soothing lotions or topical steroids. Even though it's a viral condition, you can go for topical steroids. If there is itching, give antihistamine. But this will take 6 weeks to disappear. So reassure the parents, tell them this will be there 6 weeks. Otherwise, they will be shopping from one doctor to the other. And the 6th doctor may be a quack, he may give some injection, they become all right. So please tell them that it will last for 6 weeks and nothing to worry about it. This is pityriasis rosea. Like you can, and you see the scales. You see that there are oval lesions, see the scale. The scales will be adhered to the periphery. This is called as peripheral collarette of scales, which is typical of pityriasis rosea, which is very, very common. You can see this. And once it occurs, it may not recur also again. So I told you topical corticosteroids can be used for these children. Of course, this has been dealt with the Dr. Paraniraman. This is the common conditions we come across, which is nothing but your impetigo. And this impetigo is caused by mainly by the staphylococcus, but it can be caused by streptococcus when there is a primary cause for it. Topical antibacterial, as you were telling, mupirocin is the best one, and fusidic acid also can be used, and orally cephalexin or cefadroxil can be used. When lesions are less than 5 in number, no systemic signs, only topical antibacterials is more than sufficient here. And when it is more than 5 lesions or when there is severe lesions, then you can go for oral cephalexin or cefadroxil. Of course, any child below 5 years or 6 years of age, when they come with impetigo, strip the child and see the axillon groin or on the face, you can see small scaling like this. This may be an early staphylococcal scalded skin syndrome. So you have to be careful about this. And how do you treat this crusted lesions that are present here? You can apply saline soaks. You can prepare a saline in the house. You can take 1 liter of water, add just 2 spoons of salt, and then take a gauze piece or a clean cloth, cut cloth. You can make it into 4 pieces, dip into that and apply over the lesion and wait for 10 to 15 minutes and then remove it. And like that, you can do for 2 to 3 days, twice daily. Then all this crust may come off so that they can heal very well. Of course, any SSS has to be treated. And this is another common conditions we come across in our practice where we can have scalp. You can see a lot of alopecia, but they are not smooth. It is not alopecia areata, and you have seen a lot of hair that is missing, and you get see some crust. This is not impetigo. And if there is any other sibling in the family, they may complain of similar lesion the thing. And there may be a recent haircut or recent head shave also in these patients. And here you can see a small abscess that is present. And any surgeon who looks at it will put a knife here. Nothing will come except the serum or blood. No pus will be here. And sometimes they can have lesions like this. This is again a chirion that is present. It's nothing but tinea capitis caused by the fungus. And sometimes they have secondary adenitis also. Whatever antibiotics you pump in, this adenitis may not disappear unless you take care of the fungus that is present. Whenever you have a doubt, you can do a hair root examination or just scrape the area of the lesion and then send it for KOH. Within 20 minutes, within 2 hours, you can get a diagnosis. If it is positive, go ahead. You can advise topical ketoconazole shampoos. You can apply. Wait, as I told you, for seborrheic dermatitis, you can apply this twice a week or thrice a week. You can apply. And oral antifungals like griseofulvin, fluconazole, and terbinafine can be used. But to be very frank, in my practice, I have burned my fingers with terbinafine and fluconazole. I have been using only griseofulvin 15 milligram per kg body weight in 2 divided doses. Gives excellent results, but you have to use it for 3 months. Minimum 3 months it has to be used. And this is another common conditions we come across in the nail. So you can see that half of the nail is growing when it is broken here, or it will be like this. You can see this. This has been referred to me many times as one as fungal infection, onychomycosis, and sometimes they refer this as even onycholysis and all. But you can see here, this is like this. It is nothing like it is nothing but called as onychomedicis. Very, very common after a HFMD, post HFMD, after 1.5 months, 2 months, you can see this. Or if any serious illness like an enteric fever or child with the dengue, then you can see most of the fingers, they may have lesions like this. It is nothing because when the child was stressed, this matrix doesn't grow, the nail matrix doesn't grow. There is a break and again it starts growing. That is the reason you see the gap. No treatment is essential here. Reassure them, and you can see in another 6 weeks or so, this nail will grow here and it will fall off. So this is onychomedicis. You don't need any treatment for this. And next common thing we come across in our practices, which is the best soap. So there are a lot of soaps available in the market and a lot of advertisements are going on. So people come and ask which is the best soap for you. And some of the intelligent patients have asked me, sir, which soap you use? So this is how they come. See, any soap is good actually, but they should be for children, particularly when you use it, or for babies, it should be colorless. It should not contain any perfume. That is very, very important. And there are something called as Syndets that are available. So if they come and ask me which is the best one, I always recommend a Syndet, but they are costly. They are 5 times more costlier than a soap. So if they are affordable, they can go for a Syndet. It is nothing but a synthetic detergent which has a pH of the skin of 5.5, and it doesn't disturb the moisturizing effect of the skin and doesn't disturb the microflora of the skin also. Particularly in conditions like atopic dermatitis or when they have a dry skin, synthetic detergents are the best. Otherwise, if they are not affordable, they can use soaps. There is nothing wrong. It is also good. So any soap, they can use it for 10 days. If it suits them, that will be a best soap for them. And next thing is, which is the best shampoo? Does shampoos cause hair loss? So many people, they come and tell, sir, I've been using this shampoo, I'm getting hair loss. To be very frank, these shampoos now, whatever available in the market, they are all regulated and they don't cause any hair loss. They are not harmful at all. Of course, they have an ingredient called as formaldehyde, which is act as a preservative, but the contact time is so short that doesn't help. So any shampoo, they use it for a few days, and if they're comfortable with it, they can go ahead with it. For children, as I told you, they should be colorless and it should be perfumeless always. And some of the mothers come and ask me, sir, can I use this on my child to remove the dirt, like loofah or tanga naru or this pirkangai naru? All these things they come and ask whether I can use it. To be very frank, these are used, not used for human beings, right? So please do not avoid all these things, because just a gentle application of soap itself will remove all the dirt that is present in the body. So these are all not essential. And some of the children, mothers, they come and tell, sir, papa ரொம்ப ஃபேர் ஆகணும், ரொம்ப அழகாகணும், இதுக்கு ஏதாவது வழி இருக்கா, இந்த மாதிரி ஆகணும் பெருசான அப்படின்ட்டு. See, genetically what we will be the same. இல்லைன்னா நான் ஏன் இப்படி இருக்கேன், I will be more fairer than this. I used to tell my patients. So genetically what we are, that makeup will be there. So you cannot become more fair also. So that is one. And some people tell, sir, கடலமாவு யூஸ் பண்ணலாம், அதனால ஃபேர் ஆகும்னு சொல்லுவாங்க. Whether you can use all this basin powder. No, it doesn't have much role with basin powder. In those days, it was used for dry skin. Our intelligent forefathers, they use it for dry skin because it doesn't have much problem. So they used this one. Now moisturizer soaps are available, so you can use that one. And some mothers come and ask us, sir, my child wants a long hair like this, or adolescents comes and ask what shampoo, what hair oil I can use. I can tell you there is no oil which can grow more hair. So again, it is genetically determined. So hair oil, as far as my knowledge goes, it doesn't grow more hair at all. So maybe only the oil companies are growing very well because of this. And another common condition we come across, premature graying. The definition of premature graying is below 30 years, if you get gray hair, it is premature graying for Indians. For Westerners, if it's below 20 years, they get white hair, then it's called as premature graying. So what is the condition? There are a lot of conditions which can cause premature graying. These are all so many conditions, but again, it is genetic. Most of the time, the majority of the time, it is only genetic. So you have to tell them, you have to reassure them. Of course, we can try topical melitane. There is a solution called as topical melitane, which you can apply daily in the night, and all the gray hairs will become black, because it can increase the melanogenesis and it makes the hair thing. But it works up to 25 years of age, not more than. So you and me cannot use it. So it works only up to 25 years of age. It cannot work after that. And of course, hair dye is another thing they can use. Sometimes we try calcium pantothenate with minerals and trace elements tablets combinations. Sometimes the calcium pantothenate deficiency is there, then it can be corrected and all the hairs may become black as you show. And next thing is, the common thing we come across is bad odor particularly. This is called as bromhidrosis. We call it as bromhidrosis. And when sometimes the shirts or the undergarments gets yellow in color, that is called as chromhidrosis. It's very, very common. It's because of the bacterial growth that is present in the body. They act on the set and liberate free fatty acids, ammonia and other things that can cause a bad breath. So here we recommend antibacterial soaps like triclosan based soaps. So otherwise, routinely, we don't recommend any antibacterial soaps for children. So for bromhidrosis, we can try this one. Sometimes even we use topical clindamycin in the axillary region. Most of the times it gives good results. And once the odor goes away, then they can change to the normal soaps. And some of the mothers come and ask which are the best sunscreens we can use for children, whether they should use sunscreens. Yes, of course, when they have a photosensitive disorder, it is recommended generally, or else it can be used. And most of the time,
sir, sorry to bother you, sir. 5 minutes, sir.
Yes, sir. Well finished off, sir. So the sunscreens which contain micronized zinc can be used. And what age you can recommend? All these sunscreens, either of SPF of 15 or more, definitely they can be used. But the problem is, it will last only for 2 to 3 hours or maximum 4 hours. So you have to repeatedly apply. That is one. And it should be applied on the sun exposed areas like face, neck, forearms. And main thing is, at least it should be applied 20 minutes before you venture into the sunlight. And above 6 months of age, you can safely use the sunscreens. But because there may be vitamin D problem, so you have to supplement them with therapeutic dose of, your prophylactic dose of vitamin D for all these children. That is very, very important. And this is another condition we get, pearly nodules that are present, like papules and nodules. This is nothing but molluscum contagion, which is very, very common. Here you can just reassure them. Most of the time this might disappear, but none of the mother will accept to have a child like this who is going to school where there will be discriminated, or the neighbors may come and comment on this, so they don't like to go. So the best method is needling. You can do a needling. I think this is a very short video. I'll play it how to do a needling. You just first clean the area that you can do and take an ordinary disposable needle, maybe 23 or 24 in size. And then you can see that umbilicated one, you can see that. And you can take the, you can clean it, and then you can use a 23 or 24 sized gauge needle. Yes, you have to go through and through. You have to go through and through, and then see that you can go through and through and just lift it or rotate it. Just lift it. Just open it up. Just you're opening it up, and then you can squeeze it off either with this or with the own hand, with the fingers also, with the thumb and index finger. You can squeeze. You can see a white molluscum body that comes out. There may be a gush of blood sometimes that may not be there. Just give a mild application of pressure will stop the bleeding. And once this is removed, this is the molluscum body. Once this is removed, he is cured. And of course, we charge 100 to 200 rupees for each lesions. And of course, when they are very fussy, they cannot use that. You can go for 5 to 10% potassium hydroxide, which has to be dispensed. You can apply twice daily for a week or two. That will remove these molluscum bodies. I think acne we can discuss. So dermatology is a very huge one. It is the largest organ in the body, and it is huge like this. And you can see that a small pediatrician can easily manage such a big, huge number of diseases. So do not refer all the conditions to us. And whatever I have spoken, no, all these conditions, you can manage it very well. And of course, very difficulties when you face, you can refer it to us. And I once again thank all the IAP TNSC branch who has given me this opportunity, and Dr. Palani Raman also for this. Thank you. And any questions, I'm ready to take it up. Thank you so much.
Sir, treatment for hyperhidrosis.
Yes, sir. Because I thought because the time was so short. See, hyperhidrosis, again, the hyperhidrosis of palms, soles, and axilla. All these three places it can happen. You have got aluminum acetate solutions that are available, sir. It is available. I don't know whether I can tell the trade names in the forum. It's called as sweat nil, all dry lotions. All these are available that you can apply in this, in the night you can apply. Daily in the night you can apply. The morning they can wash it off. In government hospital, we don't have this. So we use even 3% formaldehyde. 3% formaldehyde we prepare and give it, and they can apply in the night. But outside practice, you can use aluminum acetate solutions are available. Aluminum chloride solutions, aluminum acetate solutions are available. In the night, they can use it for 1 month. Then they can use it for on alternate days. And then third month, they can use it twice a week. And again, when the symptom recurs, again, they have to use it. Otherwise, if they have this as a biggest problem, particularly when they go for exams and all, you can go for iontophoresis. There is an iontophoresis machine that is available, which doesn't cost more than 6,000 or 7,000. And you can make them learn it, use it for 15 days. They may be symptom free for 3 months. There is no permanent treatment for it, sir. But you can manage with these lotions and iontophoresis machine.
Sir, the molluscum contagiosum hydrogen peroxide solution, sir?
Yes, sir. Potassium hydroxide. KOH.
Sorry, potassium hydroxide solution.
Sir, I prepare my own potassium hydroxide. I have got potassium hydroxide crystals that are available. I have a small weighing machine. I take 1 gram in 10 ml of water. Distilled water I take, and 10 ml of distilled water, that roughly makes 10% KOH. If I want to make them 5%, I add 10 more ml of distilled water, that will become 5%. Below 5 years, I use 5%. Above 5 years, I use 10% KOH. It's a simple, sir. You apply it daily for the morning and night over the lesion. It produces the irritant dermatitis. It starts irritating, and instead of opening it manually with a needle, after a week, it will open on its own, and it will throw the molluscum body out. So you're causing an irritant dermatitis that will help in throwing the molluscum body out. So this is how it is useful. I use it for a lot of patients. I get good results, excellent results.
Thank you, sir. Thank you.
Sir, the Placentrex role in hair loss, sir?
Sir, to be very frank, sir, I don't use Placentrex at all. Once upon a time when we were students, I was using a lot of Placentrex. We have been taught, and even for vitiligo, they say it can be used. No, sir. To be very frank, I'm not using. We all dermatologists, we don't use Placentrex.
The use of hair dyes in pediatrics.
You can go ahead, sir. There are some dyes which are available which doesn't have ammonia and PPD. right? PPD we are worried because it can cause bladder carcinomas in the long run. And ammonia, of course, can cause irritant dermatitis. There are the hair dyes which are available that without a PPD and ammonia that can be safely used.
Okay.
Umbilical granuloma, sir. What is your sir?
So initially when we were students, we used to tell silver nitrate, right? In those days are gone now. We use only common salt. Common salt, we can apply, crush it, apply it just for 3 to 4 days, twice daily. I mean, or even once daily. Most of the time we will see it disappears.
Okay. So, shall we go for what of things?
Yeah,
Can I
Yeah.
comment on the umbilical granuloma, sir? Dr. Karthik.
Karthik, what is it?
Regarding umbilical granuloma, sir. So this is a very common in usually neonates.
Yes.
The second week or third week of generally they come with persistent umbilical discharge. And the usual recommendation that I generally prescribe in OPD practice is used to apply common salt once daily for about 3 days, and generally dries up because the sodium chloride has got this hygroscopic effect. So it will absorb the water content from the granulation tissue, and the granulation tissue usually it dries off and then it falls off. So nothing is needed. Since the common salt is very easily available, salt application is more than sufficient for umbilical granulomas.
That's what, sir. We don't use silver nitrate nowadays at all. Those days are gone, sir. We use only common salt. Kallupu, particularly kallupu, we can go for it. Crush it in up.
Thank you, sir. Thank you.
What are the implications of any recurrence in cutaneous larva migrants?
Sir, the cutaneous larva migrants, once the larva gets into the body, it cannot survive in the skin. It can go around maybe maximum 3 weeks. It has to die. If it is going to be recurrent, then the children is sleeping on the floor without a shirt, or they are sleeping in an area where there are a lot of larvas that are present. That's the only way, because it cannot survive and it cannot be there. Recurrence is not, I mean, reinfection can occur. Like again, if they go and sleep in the area, otherwise it cannot survive, sir. It has to die without treatment also.
Okay, sir. Thank you very much.
Thank you, sir. Thank you, one and all.
Very wonderful, useful, and satisfying Tele-Cme with 3 youngsters, Dr. Karthik, Dr. Rajkumar, and Dr. Kritika, and 2 stalwarts, Dr. Palniraman and Dr. Vijay Bhaskar. Thank you so much. We had a wonderful time, and I hope the delegates would also have enjoyed. And it was really a nice CME for us. We also had a good time as office bearers. And over to Dr. Suresh. Unmute pannunga, Suresh.
Sir, Dr. Rajendran sir.
Yeah. Hello, sir. Chalunga. Yeah. Shall we go for water tanks?
Yes.
Yes, sir.
Yeah. It's my great pleasure and privilege to deliver the water tanks. I thank Dr. Karthik Balasubramaniam, Dr. Rajkumar, and Dr. Kritika, and Palniraman, and Dr. Vijay Bhaskar for delivering this wonderful lecture today. So after seeing this, the CME, I can remember that IPL matches, because IPL matches brought a lot of youngsters to the national team. So like that, no. So our president, our Aram Sedil sir, and Dr. Suresh Palan, hard effort. So because of we are conducting a lot of CME past 2 or 3 months in our forum. So we have brought really a lot of young talent. Okay, so to our state level and national level. I think I have to thank our IAP TNSC who has taken that wonderful step, and I thank Dr. Tirumurugan who has organized this web meeting, and I thank one and all for this wonderful event. I thank one and all.
Dr. Palniraman was instrumental in picking up the talent, the youngsters' talent, and both coordinated well. Dr. Palniraman and Dr. Tirumurugan coordinated well with the office bearers. Special thanks to both of them, and thanks to all the delegates who have stayed late. And I think regarding the Tamil Nadu Medical Council credit points, Dr. Tirumurugan or Dr. Rajendran can say, I think you have to pay 250 rupees to the account. Is it so?
Yes, sir.
Dr. Thirumaran, please just go
So
ahead.
thank you, sir. Thank you very much, sir. Thanks for those encouraging words. Regarding the points, what I think majority of them have entered their their names, their numbers, and their mobile numbers into the chat box or in the YouTube comments. So what next they need to do is they need to go to the IAP website and then fill the form in the which is available there. Before that, they need to pay 250 rupees to the IAP TNSE, and then the transaction ID has to be put into the registration form along with the rest of the details. So they need to do it within the next 72 hours. So you can think, sorry, Sunday. So which means by Wednesday night they need to finish it, because we need to then send it to the IAP TNSE.
Okay, we'll give them a reminder over the WhatsApp and Telegram channels.
Yes, sir. We'll do that tomorrow also. Tomorrow and day after, we'll just do that. Yes, sir.
Okay.
Sir, every month we are having same 4 hours program we are having, and I think with the credit points we are planning, and we will announce the date. Probably we'll keep it.
So we'll have 3 more CMEs.
Yeah. So we'll keep it last Sunday, sir.
October, November, and December.
Yeah. We'll keep.
We'll have it in last Sunday, October, November, and December.
Yeah.
But in November, it is going to be an adolescent program, so it will come in the middle, around November 14th. In the second week or third week, it will be there.
Okay. Sir.
Sir, and also I think we need to tell them about the UG and PG clinics, sir.
So we are having a UG clinic. We have started past 4 meeting over. Every Saturday we are having 2 to 3:30 we are having, and with the students, undergraduate student, and one internal from the same institute and external from the other institute we are planning, and already we are implemented. Another one is the PG teaching program. We are yesterday we started the program with our Director of Medical Education, Dr. Narayan Babu has started the event, and I think this is also we are having. So every Saturday, 7:30 p.m. to 9:30 p.m. we are having same one PG student from same institute, and internal from the same institute, external from the other institute. Will be a good event. I think we are every week we are having UG and PG teaching program on Saturday. It is on Saturday. Yeah.
Okay.
Thank you, sir. Thank you, sir.
Thank you very much.
Okay, once again, thanks to Dr. Murugan for the nice efforts he has been consistently doing for organizing these programs on the web, this on Zoom as well as the YouTube channel, and maintaining the website. Thank you, Dr. Thirumarugan.
Thank you, sir. Thank you very much. That's very kind of you, sir.
Thank you, sir. Thank you.
Thank you.
வணக்கம் சார். வணக்கம் சார்.
திருமுருகா ரொம்ப தேங்க்ஸ். திருமுருகா எல்லாம் உன்னுடைய எஃபர்ட் தான்டா.
தேங்க்யூ. ரொம்ப பின்னாடி போய்க்காதீங்க. நீங்க எவ்வளவு வேலை செஞ்சீங்கன்னு தெரியும். தேங்க்யூ.
இல்ல நான் வேணான்னும் போது இழுத்து போட்டு பண்ணியே ஆகணும்னு பண்ணேன். தேங்க்யூ. உனக்கு தான் போதும். ஆல் தி கிரெடிட் கோ டு யூ தான்.
தேங்க்யூ.